Okay, if everybody's in their seats, welcome to this meeting of the Perth and Kinross Integration Joint Board. I'm Councillor Colin Stewart. I'm the Vice Chair of the Board. First of all, I wanted to welcome everybody here. I'll introduce the table up with me. On my left is Gordon Patterson, the Chief Officer and Director of Integrated Health and Social Care. And next to him is Jane Smith, the Chief Financial Officer of the Board. We'll come back to our guest in a moment. On my right is Scott Hendry, the Clerk to the Board, and then we have Miss Molly from Committee Services. You're all very welcome. I think we have some new faces around the table. Mr. Hope, this isn't your first meeting, is it? The second? Second, right, okay. So I'm not going to welcome you again. Well, you are welcome, yes, absolutely. Ms. Gourley, is this your first meeting of the board? So Ms. Gourley from NHS Tayside as an Associate Nurse Director? Acting Associate Nurse Director. And we also have, I'd like to welcome Bob Benson, just to note that Mr. Benson is the incoming Vice Chair of the Board as an NHS appointee. I'd like to welcome Jenny Alexander as a non-exec appointee from NHS Tayside, and Dr. Pratt, again as a non-executive member of NHS Tayside Board and substituting today. And I think just to recognise, obviously, as well, the fact that I think we would like to be able to thank Dr. Pete for his time on the board and as chair, and he's stepped down, and that's why I am acting as chair for the meeting today. Are there any other apologies for absence or substitutions?
Chair, can I just intervene?
Mr.
It's
Benson.
a very peculiar layout for an integrated joint board meeting. It's very perplexing to me. I'm a bit of a traditionalist myself in terms of having us all round the same table. I wonder if that could be looked into. Creates a kind of a gulf between people at one end of the table, and now it feels like the Supreme Court again. I'm waiting for you to make a judgment shortly.
This is just a very standard layout for a committee in Perth and Kinross Council. It's been used for the IJB as well. And in actual fact, one of the issues is with the number of people, it's actually not possible to reconfigure the room round a square. Councillor McDade.
Yeah, just on that point, there has been comment in the past from members of the public that they found it difficult to distinguish between voting members and non-voting members of the board, and those who were not even members but were sitting around the table. So I actually think this might be helpful from the public point of view of establishing who are members of the board.
Okay, thank you. So just to clarify that point then, the voting members of the board are myself, Councillor Drysdale, Councillor McDade and Councillor Purvis from Perth and Kinross Council. And then just to get everybody in order, Mr. Benson, Ms. Kilpatrick, Ms. Alexander and Dr. Pratt from the NHS non-executives. Did you want to come in, Ms. Kilpatrick? Ms. Summer.
Just to point out that I'm the Deputy Carer Rep, Maureen Summers, but standing in today for Bernie Campbell.
Thank you. Clerk, any other apologies or substitutions?
Chair, can I just finish that point that I started? I think I'd like to review those arrangements again as an action point.
Clerk.
Thank you, Chair. So just to confirm today, part of which you've already outlined, we have Jenny Alexander substituting for Lorna Burr-Stewart, Dr. Norman Pratt substituting for the vacant voting member from NHS Tayside. We have Sandra Auld substituting for Miss Linda Lenny, Sandy Watts, substituting for Claire Gallagher. And I think that's all the substitutes.
Thank you, Clerk. Councillor McDade.
Sorry, can I just ask as a point of clarification, it's not normally standard practice to substitute for vacancies. Is this allowed under standing orders?
Thank you, Councillor McDade. That is correct under the terms of the standing orders. However, under the terms of the integration scheme, the parent partner bodies, the NHS and Council, undertake to make every effort to have quota representation of voting members at the board. The clerk can confirm.
Yes, Chair, I would agree that in terms of the integration scheme and the standing orders, both Perth and Kinross Council and NHS Tayside have an allocated 4 voting members. So NHS Tayside have sent their 4 voting members, one of which is on behalf of the current vacancies. I would agree with the Chair's interpretation.
Councillor McDade.
Can I just ask that that be reflected in the standing orders then, just from...
We are going to undertake a review of the annual review of the standing orders. I think that should be coming to the December meeting of the board, and I'm sure the clerk will be happy to reflect that in his update. Ms Gourlay.
It was just for clarity. I'm here as the Acting Associate Nurse Director in place of Sarah Dickey, who would be the substantive Associate Nurse Director on the IGB. Sarah is in the room today, but I am
okay, thank you very much. The clerk to the board is happy to tidy that up in the membership update. Anything else before we proceed with the substantive business before us? Okay, so just to explain what we will do, we have with us Dr. David Strang, who's the chair of the Independent Inquiry into Mental Health Services in Tayside. He is going to give us an update on the interim report and the status of his independent inquiry, and we'll then have the opportunity to ask questions. And we're then going to take a few, because it's themed, we're going to take a few items regarding mental health all at the same time. So we'll take a progress report and risk review paper on the Adult Mental Health and Learning Disability Service Redesign Programme. We'll take an update of on the Mental Health Alliance, and we'll take an update on the inpatient mental health budget. We'll then move into finance and governance items because we have before us today the annual accounts, and then we will break for lunch, and during lunch break we can, if approved by the board, sign the annual accounts, and then we will proceed with the remaining number of items of business on the agenda. I just wanted to take a quick opportunity to say that there are a large number of items on the agenda today. I'm not going to limit questions. However, just because of the large number of items on the agenda, I would ask everybody to be concise, not overly short, but just concise with any questions and answers, if that's all right. Just to ask everybody's indulgence so that we can move through all of the business. In May of last year, at the instigation of the then Chair and Chief Executive, oh, I beg your pardon. Thank you, Clerk. Are there any declarations of interest in items on the agenda today? No, thank you very much. Okay, so in May of last year, the then Chair and Chief Executive of NHS Tayside commissioned an independent inquiry into mental health services in Tayside. That was set up over the summer last year, and Dr. David Strang was appointed to be the chair. He took evidence during the latter part of last year and presented an interim report in May of this year, published an interim report in May of this year. So I'd like to invite Dr. David Strang to give us an update on his interim report and the status of the independent inquiry into mental health services in Tayside. Dr. Strang.
Thank you very much, Chair, and good morning, and thank you for inviting me to attend this IJB and provide an update on the independent inquiry. I want to say a little bit about the background to the setting up of the inquiry, to set it in context. And it was, I suppose, in relation to a number of concerns that had been raised over the years into mental health services in Tayside, which, in relation to this inquiry, came to a head May of last year in the Scottish Parliament, where there was a debate in which there were cross-party concerns expressed about mental health services in Tayside. So those concerns concerned lack of public confidence in mental health services in Tayside, issues about accountability and responsibility. They're saying there was lack of clarity. They particularly identified pressures on staff, the number of vacancies, particularly at consultant psychiatry level, the reliance on locums, and questions raised about leadership, both clinical leadership and management within mental health services in Tayside. So there was, at that debate, it was on the 9th of May last year, there was cross-party agreement that there would be established an independent inquiry, and that was proposed by the opposition parties and agreed by the then Cabinet Secretary. And in that debate, they talked about 5 principles, which are the 5 principles which appear in the terms of reference of the independent inquiry and are in the terms of the commissioning of the inquiry from NHS Tayside, that it should be truly independent. So I, as chair, was interviewed by a group of stakeholders, the Stakeholder Participation Group, which had been convened by the Health and Social Care Alliance based in Glasgow. So it was patients, family members, carers, and including some staff who interviewed me and others to decide on the chair. Second principle was that we would be open and transparent, and as an inquiry we have been as open and transparent as we could be. We've clearly some of the evidence that was given has been given in confidence, but we have had regular updates on our website. The third principle was that we should include and involve staff from the NHS, from partner organisations from the third sector, and we have done that. We've had an employee participation group who have conducted a survey that produced very valuable evidence for the inquiry. We should involve and include patients, families and carers, and so a stakeholder participation group who we have met regularly with over the life of the inquiry. And fifthly, that we would include a public call for evidence to ensure that everyone's voice was heard. And so in September last year, we put out a public call for evidence, and we had a very good response to that. Over 1,300 people have contributed to the what appeared in the interim report. So that has been NHS staff, patients, carers, families, communities, third sector providers, partner organisations, and the Health and Social Care Alliance I mentioned conducted a number of community events and produced a report on that about hearing the voices of those with experience of mental health services. And as the chair said, this report, which is the interim report of the inquiry, was published 4 months ago on the 22nd of May. And it is described as capturing experiences of mental health services in Tayside. And I think it's just really important to say that this report represents a summary of the evidence that we received as an inquiry team. And the criteria really, I suppose, for it appearing in this report, because as I say, it came from over 1,000 people's contributions, was that it had to be recent events. So some people gave us evidence from many years ago, perhaps where they had suffered a family bereavement, and we didn't put a limit on the time that people could come and give evidence to us for either in writing or in person. But for it to get into this interim report, it had to be something that had happened either in 2018 or 2019. So it is in general, recent events. And it had to be more than just one person's voice, because there's obviously a danger of kind of relying too much on just one person's voice. So it's always been corroborated. Everything in here, in this interim report, more than one person gave evidence to us, and it was recent. So what we have done since then is further analysis and investigation based on the evidence we'd received, and we are now working at drawing up our conclusions with a view to building a final report that will have useful recommendations which will lead to improvements in mental health services in Tayside. The way this report is structured, we identified 6 key themes and about 33 individual issues, and each of those will be covered in the final report. But of course, there are some additional issues that have been raised as a result of our investigations. So in terms of presenting this paper, I attended the NHS Tayside board on the 27th of June and accepted there an invitation to attend the 3 IJBs. So I'm pleased to be here this morning. So I'm very happy to take any questions. But before I invite questions, I just wanted to highlight a couple of areas of key concern, I think, which will be of interest to you as an integration joint board. Leadership and governance are 2 of the key themes. And I highlight that in the interim report, but I also highlight it with you this morning because of the importance of good leadership in managing change. As you know, change is needed, and that's kind of widely accepted, and reading your board papers, reading NHS board papers, there is a recognition that there is significant change needed to what is being delivered at the moment and has been. And as you'll all know from life's experience, that if you're going to manage change well, it needs to be well led. There needs to be clarity of direction, clarity of responsibility. And you can hear a but coming. And what we have found and been told, and under further investigation, I think it's the case that the arrangements for the oversight by the integration, the 3 integration joint boards and by NHS Tayside are complicated, complex. Some people say they're confusing. And a lot of people don't really quite understand or follow the scheme of delegation. Why are some delegated? Why are some hosted in the way that they are? What's been retained by NHS Tayside? And why should those be? Now, I'm not necessarily saying that any of those is wrong, but what I am saying is that there is complexity and confusion which doesn't aid clear decision-making. And senior people have said to me that some of them feel disempowered because things have to go to the IJBs, for instance, before they can make a decision. There's a kind of lack of clarity about who exactly is responsible. So within mental health services, within NHS Tayside, CAMS, so children and adolescent mental health services, doesn't sit within that, sits somewhere else. Similarly, psychiatry for old age, again, sits elsewhere and not under mental health. So it is complicated, and we not understand that, and I'm not saying it's simple. But I'm saying that kind of complexity of governance and oversight and risk management, I think, is a challenge for providing clear leadership. Now, I know that the Mental Health Alliance has been set up, and there are some issues there about what is their delegated decision-making responsibility, what rests here. And certainly at the Health Board meeting in June, for those of you who were there will know that there was quite a debate about whether access of patients into Carr's View was that a Perth and Kinross IJB responsibility, or was it NHS Tayside? So that's a little bit about governance. Perhaps more important, leadership and the whole issue about relationships, levels of trust, continuity of staff. We spoke to many staff who did not feel that they were well supported. And as you know, there are a number of vacancies at, well, certainly consultant psychiatry level, but at senior posts that are either have a temporary position or interim in senior positions. That inevitably, I think, has an impact on issues of leadership and governance. And then the second area I wanted to highlight was, and I've touched on it, but is the level of change that is needed. So I think there's an acknowledgement that significant and strategic change is needed in the delivery of mental health services in Tayside. And the scale of that challenge must not be underestimated. In the interim report, we talk about the need for a comprehensive review of the mental health strategy. That's very fragmented at the moment. There isn't a single mental health services strategy. But I think more importantly, it's not just a strategy, it's about new thinking is required in how mental health services is going to be delivered in the 21st century in a new world where there is a shortage of consultant psychiatrists. I mean, it's just that is the case. It's true across Scotland, and it is particularly acute here. And I mean, I think when I was first appointed, I had thought that maybe things would improve as NHS Tayside, as yourselves addressed some of the shortfalls that have been identified. But in reality, some things have got worse, and particularly the reliance on locums, and that's not a personal criticism of any locum in particular, but just in terms of their role and function and the kind of lack of continuity in post, means that there needs to be a fundamental redesign of how it is that you're going to deliver to meet the needs of the community and the needs of patients. And so I'd say that a fundamental redesign of how mental health services is delivered needs to be undertaken, and that's both, or particularly for the community where the vast majority of patients are treated and cared for. I know, understandably, there's a big emphasis on what's happening to inpatient. I understand that, and that represents 6% of patients and the most seriously unwell. But if the system is going to work, and we've been asked to look at end-to-end mental health services, then there needs to be that radical approach. And I know in Tayside documents it talks about the pace and scale of change required is significant. So I think there's a recognition of that. I think my fear, and I mentioned this at the Health Board, is that there might be a temptation to minimise how serious things are and kind of rely on a business-as-usual improvement plan and say that will be sufficient. And I suppose my message to you is that given the chronic shortage of consultants and the reliance on locums, we need something more than that, and it needs to be a credible plan that will lead to change. And I say that because writing a plan is not enough, because there's no guarantee then of changing behaviour and patient experience. Sadly, the history, if you look back just in recent years, there's a history of too many plans that look good and get signed off. But then when we as an inquiry team have looked through and said, well, where's the implementation of this? It's not been followed through, not been implemented. And I think particularly on the really hard issues of changing some of the staff culture, cultural issues, taking responsibility for ownership. There's a number of things that are identified in the interim report that talk about people's fear of taking responsibility because there's a blame culture. That's kind of how things are articulated. And that, to tackle those are quite fundamental issues that take more than simply writing a plan with some action points. And so I suppose my question for you to ponder is how do you ensure that what needs to happen is actually delivered. That's a kind of summary of the interim report and where we are, and I'm very happy to take any questions. Thank you.
Thank you, Dr. Strang. So I'll now invite questions, and the first one is Councillor Drysdale.
Thank you, Vice Chair, and thank you, Dr. Strang, for your overview of your interim report, which is much appreciated. Everyone understands that there are many deficiencies in the current delivery of community mental health care. And equally, there are many shortcomings in the delivery of inpatient mental health care. I'm curious, you haven't, I had thought that you might have explained clearly why you recommend the pausing of the current programme of inpatient transformation. You haven't done so. I wonder if you would take this opportunity now to explain why, notwithstanding the fact that I think everyone agrees that lots needs to be done in the community, why it is separately important in your view to pause the current work.
So your reference to the pausing was a comment that I make at paragraph 464 in what was called a service redesign transformation program. And the problem even with that title was that it would give you the impression that this was a transformational change to service design. But it's not. It is about how many beds you have and where they are. So nothing that is delivered in that. Well, I noticed that. So you've got a paper following which talks about service redesign program. So I suppose that title is now a more honest one. So it's not claiming that this is transformational, but it still calls itself service redesign. And what was clear to me was that a lot of energy and effort was going into this. There had been consultation back in 2017. There was a decision made at this board in January last year. And that seemed to be all the focus was on, because we're short of psychiatrists, we need to reduce to a single site. So it was about, because there had been in the year before, as you know, the closure of the Mulberry ward at Stracathro, and its relocation of its patients and staff into Carsview. Now, that did not improve the care and welfare of patients in Carsview. The conditions, the environment at Carsview were worse than what the treatment and care they were receiving in Stracathro and the environment. But it was done because of the shortage, and I understand that. But it was done sort of as sort of an emergency measure, with very short notice of that. And so I suppose what was being claimed, I think, was that this was transformational change of service delivery, and it's not. It was about moving the beds, closing of a ward here and a closing. And the point I make is that, in a way, that's the wrong way around, because what is needed is, if there is a shortage already and a growing shortage of psychiatrists, so how are you going to deliver mental health services? You need to invest in doing that transformational service redesign. That is absolutely needed. And that should happen first. So you need to do, you're going to look at how are you going to deliver in the community, in Angus, in Dundee, and in Perth and Kinross, how are you going to deliver an effective mental health services? And what do we need in the way of inpatients, and where should they be? So you do it that way around. Now, it's 4 months since I published this, and I haven't seen a redesign transformation program, and I don't see it on your agenda today. So what I said in the report was not so much you should pause the moving of beds. I mean, clearly, if I'm not going to be making decisions about whether Craigal Ward at Strathmartin closes or doesn't. That's an operational issue that those who are charged with risk management and safety of patients have to do. But what I was saying here is that what is called a redesign transformation program is about moving of beds and sites, and you're doing it the wrong way around. So you should do the major strategic redesign of how you're going to deliver mental health service across Tayside first, and then out of that will fall how many beds you need in the IPCU, in inpatient wards, in different wards, and where they should be.
Thank you. If I can just quickly follow up on that. So if I understand you correctly, what you're saying is that I think you said that you do not disagree with any essential movement of inpatient facilities, but that you're saying that in hindsight, the way that this has been gone about has not been integrated, and it's not been community and inpatient. It's been, the focus has been, in your view, entirely or mostly on the inpatient side, when it should have been on the full picture. And I don't think anybody would dispute that. But did you say that you're not suggesting that the work that has been done should be stopped? It's that there should now be additional work on the community side.
You're saying with hindsight. I was saying it with foresight. I was saying it back in May. But it looks like I might be having to say in the final report, notwithstanding the recommendation, there should be a strategic review of service design recommended public. I mean, that was why I published an interim report, was to give a heads up to say what was needed. Rather than waiting right to the end and then publishing with everything, I decided to publish an interim report which is a summary of the evidence we've received to allow yourselves, to allow NHS Tayside to start addressing these. And from the tone of your question, I see this paper, it looks as if I'm going to say, that is disappointing, that recommendation. I mean, it was the only recommendation in the whole report because I felt it was a very urgent one. So it wasn't about with hindsight, it was about something that was urgently needed. It looks as if the energy and effort has been put into about these bed closures. And the fact that they're talking about staff, it's as if it's because there's a shortage of staff. But actually, you need to look at it the other way around. Why is there a shortage of staff? And that's because there's not a clear, coherent plan for delivering mental health services in Tayside.
Councillor McDade next.
Thank you, Vice Chair. And thank you, Dr. Strang, for joining us today. I thought that was quite a useful answer to Councillor Drysdale, and I think it's important, as you've outlined, that you have only made one recommendation in your interim report, which is that there should be a pause. It is unfortunate that we are obviously considering this 4 months after you published your report, and that we haven't got progress that answers your query, as it were. But I was hoping you could give me a bit more about 1,300 people to respond to a public consultation of any sort is a high number, and given that the service in Tayside mental health services, that's probably quite a small number of the population that's accessing that service. That is a high number, I would say, of people responding to that. I was wondering if you could tell us a bit more in terms of your view on a lack of public confidence, which you mentioned as one of your first points, about the current process that has been undertaken by the IGB and the Health Board.
So first, let's say that the number of 1,300 would include NHS staff as well, so they weren't all patients. So we heard evidence from community groups that they felt consultation had been token, that either they weren't asked the right questions, or when they submitted things, they were ignored. Staff said that to us as well. I spoke to senior consultants who clearly had views on how the service should be delivered, and said, well, have you put these views forward? And they say, well, either we did and they got ignored, or they don't ask. I spoke to one consultant who had a week's notice that their ward was going to be closing. So, what we hear from that is that there's not a confidence in. So too many of the changes, so I've mentioned Craigall Ward, I've mentioned Stracathro, are done. It's almost as if it's crisis response rather than forward planning. That's what I would say is what I see in the management of this. So, as I said, there's a sort of strange combination of plans that look good. So the Healthcare Improvement Scotland did a lot of work in 2017, agreed a joint plan for tackling some of the cultural issues, for looking at long-term planning. And you look down that, and I said, well, that looks really good. And then you follow it through. And so on the one hand, they've got plans that aren't implemented in full, and particularly the important bits aren't. And then on the other hand, changes happen without a clear structured plan. And lots of, it's interesting, the next item at 3.2 goes back to history, and I think goes back to 2013, about trying to identify what was needed. But there's a sense of kind of urgency. We've got a crisis here. And I suppose what I would say is that staff and community groups don't feel that there's genuine consultation and involvement in decisions about future. And at the Health Board, there was talk about establishing a stakeholder participation group convened by the Alliance. Well, that hasn't happened. So that was back in June. We're 3 months on. So I suppose it's people kind of raise their eyebrows or put a question mark when there's some commitment to done something that's not delivered. And of course, that then undermines your confidence next time round, because you think, well, they said they were going to do that and it hasn't happened. So that is a fundamental problem, I think, in terms of, and it's a bit about relationships, but about trusting. If someone's going to consult, it will be genuine, and if someone says they're going to do something, they follow through on it.
Councillor McDade. Yeah, just a follow-up, thank you. I would share a lot of what you've just said, in having visited all the mental health sites across Tayside and spoken to the staff in all the wards we visited. There was a feeling from a considerable number of them that they had made suggestions and they weren't listened to. And I think that, as you outlined, has exacerbated the recruitment issues, has exacerbated people leaving, and has created the knock-on effect. And I think we perhaps have been looking at this the wrong way about actually we need to stem the bleeding in some respects before we can actually avert the full disaster. And I think what I would quite like to come on to is, in terms of you outlined the timeline earlier, and the initial, the report later on does mention 2013. I'm one of the few people who was on the board back in 2018 when we made the decision, and certainly we made the decision at the time, and I made it on quite a reluctant basis at that point, based on the fact that we were told in terms of clinical urgency was required and that this had to happen or people weren't going to be safe. But here we are 21 months later, and very little of that plan has been implemented. And you've mentioned other plans. So what do you think would actually allow a good plan to be implemented? What needs to happen for a decent plan to be implemented, whether it's the one that's already approved or another one, what actually needs to happen on the side of whether it's staff consultation, etc., to get that buy-in to make it work, because clearly things haven't been working for a very long time.
I mean, it's major organisational change in this one area of mental health. So you need to have a clear. Well, I mean, sorry, it's difficult to know kind of how much depth to answer that question. But I mean, you need to have a clear plan of direction, and you think that you might involve consulting staff and patients and community and partner organisations in developing that. And you then need to have an implementation plan that has got widespread agreement and then has milestones that gets implemented. I mean, I think it's interesting you say that that decision was made 21 months ago, and because it was urgent, but we're sitting here and that those changes haven't been made. So there's clearly something, and it wasn't because I produced my report, because that wasn't till May. So even if it was my report that put a halt on it, but you still had something that had been consulted on in 2017, but didn't attract widespread support for the conclusion. I mean, I think it was option 3A we went for in the end, but that wasn't universally supported. But that was what was decided. And then when I published at the end of May 2019, that still hadn't been done. But more important in my mind, why had the strategic review of the mental health service, what was needed in the community? Because in a sense, the evidence we received from people in the community was more distressing than the evidence from people who were in inpatients. I mean, at least people felt at least they're in a ward and hopefully will be safe and well cared for. But it was waiting times, it was GPs telling us that they wanted to refer, were supporting a family, wanted to refer a teenager into CAMS, and were either told, don't meet the referral, get a letter back, so the child wasn't even seen by someone in CAMS, or it was a waiting list so much so that they became 16 and into adult even before they were ever seen. So, I think the more acute problems, and certainly the solution, lies in how you provide services in the community. So, and we're going to talk in the final report about prevention, early intervention, enhancing well-being. And I know there's a lot of good work going on in schools across the region, but that's where the concentration, I think, of effort needs to be, not in deciding whether you've got 6 beds in the IPCU or 8 or 10.
Summers?
My understanding of the recommendations or the suggestions in Dr. Strang's report is that if more emphasis was put on the community services, now I've been hearing this for at least 5 or 6 years now, that they're going to enhance the community services. And I thought when the integration of health and social care took place, it would actually happen. But we've been going now for, 3 years or more, and the community mental health services have not been enhanced. I would say they're probably worse now, and that's through first-hand experience. But I think that the recommendation here is that if more emphasis was put on the community services and they were enhanced, which would allow early intervention and probably prevention of crisis in the first place, that would dictate how many beds were needed. Instead of deciding how many beds are needed and where they're needed, that would come out of, better services in the community. And my understanding was that was really what was being said in this report.
Yeah, I suppose my thoughts are really that it's not an either or. It's not either community or inpatient, because you need both. But in terms of the energy and effort, I see that more seems to be going into trying to sort out the inpatient problem than the community. But if you need to look at it holistically from end-to-end patient journey, you need to have very good, because it's only if you've got really good community services that you can reduce, because the proposal talks about reducing beds, inpatient beds. And of course, that's an aspiration that we would support, but you can only do that if you've got enhanced community services so that people are not having to be referred in, that there are good and effective services that have confidence. And I suppose the only other comment I would make on what you've said is that you need to tailor your plans to what's reality. So, you might do this big strategic review and decide that you needed another 40 psychiatrists. Well, I'm going to say, well, that's not a good plan because you won't be able to deliver that. So it needs to be tempered with the resource you've got, with the people you've got. The geography, obviously, of Tayside is different from elsewhere. So, it needs to be done together, both what you have as a resource and what is needed, and there'll probably be a compromise somewhere. But also you need to make sure you're looking at community and inpatient, and again there might be compromises there needed.
Do you want to come back in, Maureen?
The consultation, you said that you were getting feedback from staff as well as, patients and their carers, that it was very tokenistic. Now, I attended practically every consultation event that took place. There was only 2 in Perth and Kinross, and I don't think that anything that was said there was taken on board in the final decision. So, people are sceptical, they're wondering, if our decision's been made first and then they're fitted into what, the services actually, the health and social care actually want, instead of the other way about. Because the people on the ground, the people that you've been interviewing, you say you've interviewed over 1,000 people, that they're the ones with the lived experience, they're 24/7, this, and they know what's required, to make things better for the people that we're talking about, the mental health patients. So I just feel that, sorry.
No, that's fine. If I could just make one comment. I didn't say the consultation was tokenistic. What I was answering a question about lack of public confidence in the consultation, and I said that people had told us that they felt it was tokenistic. So I just
no, I'm not saying that you said that, but that is being said. I mean, I've attended some of these meetings.
Okay, thank you. Pat's next. Mrs. Kilpatrick's next.
Thank you, Chair. I think it's an excellent report, and I think I've expressed that to you before at the board meeting, and it's quite an emotive report. When you read it, it's a difficult read. And I have reflected, I've read it a few times since we discussed it at the board in June, I think it was, and I have reflected on psychiatry and mental health in the community and where is it going. And it strikes me that there's 2 issues. One is the model of care, that the model of care is possibly a bit out of date. It doesn't reflect the real needs of the communities it serves. It's still tied to the kind of currency of beds and having beds and all of that. And a lot of other services that we work with, they've really moved on from that. And I think the second aspect of it is the culture, and the culture obviously was out of date and didn't reflect the kind of culture that we're trying to embed as an integrated joint board. And I think if you look at the way we design models of care and other services, we always start with prevention. We always start with how can we keep people well. Now, whether that's social prescribing and giving people access to leisure facilities through the council, or it's guided walks, or it's joining a gardening club, or whatever it is. But there's an awful lot that we can do in preventative terms. I say that as the chair of the board's public health committee. There's an awful lot more we could do, I think, in prevention and keeping people well, whether they're teenagers or the elderly, because obviously we've got a lot of depression and loneliness in elderly populations and isolation. And I think, if I was starting with a clean sheet of paper, my first point would be prevention. My second point then, in terms of the model of care, would be community. And what is the first port of call? And some of the successes they've had in other boards like NHS Lanarkshire, looking at crisis intervention. Because people present in crisis, it might not be a health crisis as such, it might be a mental health issue brought on by debt, brought on by family bereavement, brought on by divorce. and they need advice, and that can help to support people in the community. The third point would be enhanced community, when not just getting advice or seeing your GP is not enough, but the enhanced community services. Then we would look at outpatients. What can we do in an outpatient setting, either through a hospital base or through a GP base or an extended primary care hub? Then we would look at day case. What can we do with patients from a day case perspective, where they come in, they get an intervention, they get support and they go home. And then at the very, very end of the line, we would look at inpatients. So I would like to say, I think the report is very helpful in helping us to reflect as board members that actually the model of care and the way the resources are being used is the wrong way round. We're putting money in the wrong end of the system. We need to put money in that front end of prevention and community and enhanced community and outpatient and day case before we get near the inpatients. And if you look at the points you've made, which I've raised before, about patients with drug and alcohol issues, you know, the bulk of boards are seeking to try and resolve that and address that and support people in the community. That's about getting the community services right. And if people got the community services right, they wouldn't have to be admitted. If we were doing that upstream work, we wouldn't have to get to that. So I think model of care and culture, that's where we really need to focus our efforts. And we need to invest at the other end of the model of care and not at the end. That doesn't withstand, in my view, the need to address patient safety issues and the need to make sure that if we're admitting patients, we can safely staff and safely provide for them, because we're not doing them any great service if we're admitting them to facilities where they are technically not safe. But I think it's a great report, and I look forward to reading your full report. I'm very, very grateful for all the good work that you've done. And I think these are really, really important issues for the IJB to take forward. Thank you, Chair.
Can I respond to that? Thanks very much for your comments. And I mean, I agree with your analysis. I'd make two comments. One, that you find it emotional reading that report, and of course, mental health is emotional. And in a sense, you know, if you've got a fracture or something, going to a day clinic, it feels very different. And I think that there's so many complications around people with poor mental health, and you've talked absolutely right about social issues. So whether it's about deprivation, whether it's about unemployment, whether it's about trauma, victimization, family relationships, whether it's drug and alcohol addiction. And while psychiatrists understand that, they're not equipped to deal with that. So I mean, by labeling all as kind of mental health and well-being, there's a risk that it slightly clouds it. So we train and pay psychiatrists a lot to deal with severe and enduring mental ill health, and people with psychosis, schizophrenia absolutely need that top-end care. But there's a huge long tail, and I mean, and they say that we all have mental health. It's either poor mental health or good mental health, and so I think I'd just add that layer onto your 6-point care planning, just to recognise that the sort of complexity of mental health and a slightly, I think, more nuanced approach.
Can I come back?
Quick follow-up.
I think if you look at patients with complex mental health needs, they absolutely need access to the right care at the right place at the right time. And as a board, we are committed to that. The thing is, we also have to make sure that that's done safely, it's done in a safe environment. And I think that's really, really important. And that must be scary, must be very scary for patients, must be very scary for families. So I completely agree with your observations. Thank you.
Thank you. Councillor Purvis.
Thank you, Chair. I would like to agree with a lot of the comments that have been made by other members, in particular the comments just made by Mrs Kilpatrick. I was going to ask you about the perceived urgency of the need to implement the recommendation, because I think some people were quite surprised by the inclusion of a recommendation in an interim report, but I think you have already clarified that, so I won't ask that again. I also think your clarification about obviously we as a board are responsible for strategic matters and strategic decision making, which the redesign programme was, rather than operational requirements and any clinical urgent measures that needed to take place. And I think your clarification earlier that any pause which is included in your recommendation would not preclude those things taking place, nor should it. So I think that was useful. Just to pick up on the comments made by Councillor McDade about the and your comments about planning going forward and things not being done in a holistic manner. The fact that we were told, I wasn't on the board, but was present at some of the discussions in the public gallery and watching them after and reading the report, that 21 months ago when that decision was taken, some of these things were clinically urgent and necessary to take at the time, but some of them still haven't been implemented now. So I think it's entirely justified for some board members to be at least somewhat sceptical about being told once again, that it's still clinically urgent and necessary, and that other things have happened despite the fact that those weren't included in plans at the time, which have not been pre-planned. So I suppose my question is, in the report which we're going to consider next, which you have referenced, so I'm presuming that you have considered it, at 6.2 it does say that it is acknowledged that there is a requirement for end-to-end pathway design across mental health services in Tayside, which I think everyone is in agreement with. However, this is not predicated on the suspension of the redesign programme. Clearly that's inconsistent with your recommendation, taking the caveat that obviously any necessary inpatient requirements which you do in your recommendation make. I would just like to ask if you'd like to comment on that, to give board members your views on that in advance of our consideration of the next paper.
Thank you. So your comment at 6.2 says there is a requirement for end-to-end pathway design across the mental health services in Tayside. I rest my case. But it's not saying it's being done. It's not saying we're underway. It says there's a need. So if you're saying there's a need, it means it's not being done. And, why was this not done last year? Why was it not done in 2016 and 17, 18? Why was it not kicked off in May when I published my report? Why is there still a need for end-to-end pathway redesign of mental health services in Tayside? Now, they say that they can be done in parallel. I wouldn't disagree with that, except I don't see it in parallel. It's a one rail train track, because this is saying that it needs to be done. And if you were, I can't say that choice. I'm saying that they're completely different. You're comparing apples with pears, because one's about patient safety and whether you're going to move from 6 beds or 10 beds in the IPCU to 6, and that's at one level. But you still need to do the wider...
Just a supplementary. Absolutely. Thank you for that clarification. It was just in terms of, obviously in your report, you do say that the proposed changes should not be implemented before there's a comprehensive review. So you're suggesting one should come before the other, if you see what I mean. I presume that's what you intended by that.
Well, I suppose that's just a logic. Councillor McDade asked me about strategic planning. Well, you have a plan, and then you operationalise it. But that looks like you're operationalising something that may change when you do the strategic review. So, of course, you do the big strategic bit first, and then you do the operational bit second.
No, thank you for that clarification.
Mr. Benson.
Thank you very much indeed. Thank you, and thank you, David, and very grateful for the update we gave us in June as well. I support the broad thrust of your report. I think it's an excellent report. I think it will highlight just why this issue is so important and get it up there, not just into the Tayside agenda, but into the national agenda as well. This is a national crisis. We know it's a national crisis. It's more than just the Tayside issue, although we have particular problems here. And we've already acknowledged that there are real problems in recruitment of key staff around psychiatry, nursing, all the key areas that we have a problem, and retaining them, because this is a very tough, intensive business to work in. So in saying that, that's equally true for community services as well, but also just particularly want to say something, I think Pat led into it quite well, around we are utterly dependent, all of these services, on families, carers and third sector support fundamentally. I think Maureen articulated that really well. And it would be quite useful when you come to your final deliberations, if you can say something more specific about what kind of support can we give to the third sector, the informal voluntary sector and to families and carers, what specific investment should we be making to support those groups, knowing that access to service provision will be patchy at times for them. They need hope, and I think that's a fundamental issue for me, that as we're moving through this service redesign, there are still real people out there, and I think that's fundamental for me. It would also be helpful to add on to that about the importance, I think Pat alluded to again, was the issue around about social prescribing, which is again fundamental, not just for people with mental health and other difficulties. It's an important plank to support families as well, and particularly thinking about if someone loses their job because of a mental health problem, then they need to know how to get access to financial help, housing help, all the range of different things. This is where the future will rest with some of this anyway. And the further issue onto this is one of public health itself. We know the health of many people with mental health problems is very poor in many cases, and we need to look at more reasonably why that is the case. Are they not getting it within the inpatient or community support? Are they not getting it from primary care services? We need to nail this one down, and I'd be grateful if you could make some specific reference to this necessary support as we're going through, because people aren't just dealing with illness, they're dealing with a whole host of other problems as well. It would be useful when you talk about governance, and it's an issue for me as a relatively new member, is about ownership of risk. Now, I think I understand the strategic risk ownership that I have, but I wonder if others are as clear about that. And we had an interesting discussion elsewhere just on who makes decisions about things. And it's kind of, and if we're still asking some of these questions, you know, is it government, is it IJBs, is it NHS Tayside, is it Perth and Kinross, then it's really important that we're clear about those routes and who are the responsible people, who owns the risk. I find this a fundamental problem in governance anyway, but it would really help if perhaps you could give some insight into that. The other part is around staff workforce itself. And it's really interesting because we've got people who are working who have different employers here. We have NHS employed staff, we have local authority employed staff, we have private sector employed staff. And I'm thinking about my experience of joint working has always been around the possibility of shared learning, where people can get the same opportunities to access information, to access joint training opportunities, all the things. And also I would say probably the opportunities that flow from that are often quite limited because of the nature of where you've come from. So there's an issue for me about the retention of staff in the long term is about looking at this more integrated model and how do we get over this, given that people have got different terms of conditions of service and things like that. That would be quite helpful. So I'm just going to leave it at that, but I very much welcome this report.
Just very briefly, I mean, the minute you're into kind of partnership working, joint working, collaborative working, it's more complicated than doing something within a single organisation, but it can be made to work really well. So I mean, you mentioned about risk. Your strategic risks rest with NHS Tayside, operational risks rest with the IJB. So is a shortage of psychiatrists, is that a strategic risk or an operational risk? It's both. It just needs clarification where that sits. But thank you for your comments, and we'll take note of those.
Ms. Reid.
Thank you, Vice Chair. David, 2 points, and then I'll go on to the substantive point I was going to make. I'm sure that you will take cognizance of the Public Bodies Joint Working Act in terms of the governance in relation to integration schemes, and I would urge caution, as you would imagine, in terms of what will follow in your final report, because the governance framework is clearly set out in the Act. So we need to interpret that in terms of making it clear for the IGBs across Tayside. The second point in relation to staffing, I would concur with what Mr Benson has raised in terms of there are opportunities regardless of who your employing agency is, but I do think those are covered within the joint working agreement that exists between the Council and NHS Tayside, and that agreement needs to be brought to conclusion quickly to enable those things to happen. So that's the 2 points in relation to what Mr Benson said. But I think what I'm hearing from you today is we really need to be clear across Tayside about what our vision is for both the quality and model of mental health care, wherever and whenever that care is delivered. We need to be clear about what we'll invest in and indeed what we'll disinvest in. And sometimes you need to make decisions in terms of disinvestment to enable investment. So in terms of informing the transformation plan, I'd also suggest that what we need to do is have sophisticated, intelligent use of data and indeed evidence, incorporating the views of staff, our communities, and indeed those who are living with lived experience of mental health. And that plan needs to have clear outcomes and indeed measures. It needs to have tangible actions and responsibility attributed to those. It needs to be clear on the resources and indeed the timescales that we're working to, and of course needs to be underpinned by a robust clinical and quality assurance framework. I don't think these things are unrealistic to achieve.
Thanks very much. And my point really about the Public Bodies Act is not that that needs amending, but it needs interpreting and clarity. So, I mean, I'm sure you're right about joint working agreements and you know, a scheme of governance. But what I suppose the point I was making was that people either aren't aware of it or find that it is an impediment to decision making rather than an aid to it. And yeah, no, I mean, I agree entirely with you, the way you've described the transformation plan, and the bit I would add, and maybe you meant it when you talked about an assurance framework, but is making sure that it gets done. You know, that, yeah, thank you.
Okay, do we have any more questions? Another question from Maureen? Oh, yeah, okay, we do. Maureen, sorry, Mrs Summers, if you want to come in again.
In regard to the staffing issue, I think there's probably been an assumption that if the beds are relocated to wherever, that the staff would go with them. But I don't think there is a willingness for the staff to go. I think staff are already leaving, and you know, so that's just going to make the staffing situation worse. I don't know if they've addressed the upcoming retirements that are coming up that they've known about, and I think it's actually just getting worse. I don't know what the answer is, but it's not been addressed, and I think that the assumption that if beds are relocated to anywhere else in Tayside that the relevant staff would move to, I don't think that's actually going to happen, so I don't know how they're going to address that.
Okay, thanks. These are issues that we will come on to in discussion in the next paper, but maybe you could indicate whether you had any feedback on that in your interviews with staff, Dr. Strang?
No, not in detail. I mean, I know that I mentioned.
And Councillor McDade.
Thank you. Thank you for allowing me to come back in. Just to follow up on a couple of the questions that have been asked already, in particular Mr. Benson's question around governance. And as the strategic commissioning body, I'm looking as a member of that strategic commissioning body for assurance around the delivery of some of these plans. So, as I say, we approved a plan 21 months ago. You know, there's been issues with implementing that plan, and we need assurance of it. And what I'd like is some assurance from you that, in your view, having carried out quite an extensive inquiry, whether you think the organisations involved are structurally able to implement that, or if there are changes required to allow that to happen.
So I do think things need to change because, as you say, and as I've said, I've seen plans that haven't been implemented, recommendations from SPSO reports, that the response is, yes, we accept that, but then when you look at have they been implemented, they haven't been implemented. So there's a bit about decision making, so making sure that what recommendations we approve, but there then needs to be a better mechanism to ensure implementation of that. I mean, that's a core governance function. And of course, there might well be some good reason why a recommendation has not been implemented, but you need to have a feedback loop to say that, we've got new information and we think that decision to do that was flawed, and so please change it. But loads of stuff just get lost. Things that were agreed that will deliver, and you come back to look and see, well, how was it? And there doesn't seem to be any kind of closing report back to the commissioning body to say we've changed a plan. It just gets lost, and it might be partly to do with change of personnel. I mean, there's been a high turnover of members.
Okay, thank you. Any other further questions from members of the board? No. Okay, if I could just follow up with one quick question then. Just in terms of next steps, Dr. Strang, so you've published your interim report. Obviously, following up on that, there'll be the more detailed. I can't remember if you said before that you were going to continue with evidence gathering or some sort of analysis phase, and then pull together a final report with more detailed recommendations. Just give us an overview and maybe a time scale for that.
Thank you for that question. So since publishing in May, we have been doing much more investigation. So when you put out a public call for evidence, you're in a way at the mercy of who wants to give evidence to you. And so we have then gone out much more, and so we've met with a lot of health professionals. So we've had meetings with CAMS, with old age psychiatry, with consultant psychiatrists, with GP practices, we've met with the 3 IJBs, with the police and so on. So we've been proactive and doing further investigation. And the stage we're at now is drawing up a final report that will have conclusions, have recommendations, and including recommendations about implementation and monitoring. So that's the stage we're at now.
And do you have a sort of indicative timeline for that stage? I know it will.
No is the answer. There's a balance between being comprehensive but being timely as well. So I mean, we're working on it now, and as soon as it's complete, we'll let you know.
Thank you very much. Okay, so I think I would just like to thank Dr. Strang not only for coming along today to give the IJB the opportunity to hear an update and ask questions that obviously NHS Tayside and I think Dundee IJB have already had, but also to thank him at this point for the huge amount of work and the comprehensive nature of the interim report, but the huge amount of work that's gone into the inquiry, and to say that we look forward very much to hearing your and reading your final conclusions in the final report. So thank you very much, Dr. Strang.
Thank you very much.
I think we'll take a short 5-minute recess just so people can get up and shake their limbs about in effort not to stay mobile and physically healthy. Okay, thank you everybody. I think everybody's back in their place. So we'll now move on to the second item on the agenda, an adult mental health and learning disability service redesign programme progress report and risk review paper. So I just wanted to quickly outline for those members that are new here, for each paper that's coming up on the agenda, I'll ask the relevant officer to provide an overview and an introduction to it. I'll then invite questions from members of the board, And as I said before, if we could keep our questions as concise questions and our answers as concise answers, because we are going to have a number of items still to come on the agenda. Once everybody's had the opportunity to ask all their questions on a report, I'll ask if there are any motions or amendments in relation to the business from any of the voting members of the board, and those motions and amendments would require to be proposed and seconded, which may be to either agree the recommendations in a report or suggest alternative actions to be taken. After any motions or amendments have been put, I'll invite contributions from members of the board, and each member will be allowed to make just one contribution during discussion of those papers. And at that point, we shouldn't be going back a step and asking any questions, because we've had the opportunity to explore those. But you might feel that you need to make a point of order or a point of clarification in response to another member's contribution, and then we'll move on to taking a decision. We will be attempting to arrive at decisions on the papers today by consensus, as that is the requirement in the standing orders. But if there are any unresolved issues in terms of accepting a recommendation in a report, I'll ask the clerk to conduct a roll call vote of members. So I hope, just for everybody that's new here and just for everybody that's perhaps been unfamiliar with the standing orders, that provides clarity to everybody on how we will conduct the business of the board today. So, item 3.2 on your agendas is the Adult Mental Health and Learning Disability Service Redesign Programme Progress Report and Risk Review Paper. This is a report by the Chief Officer and Director of Integrated Health and Social Care. I'll ask Mr. Patterson, the Chief Officer, to introduce the report.
Thank you, Vice Chair. I'm very grateful for the opportunity to present this report to IJB members, and recognise from what you've described that some IJB members are relatively new, which is perhaps why I have included within this report some of the background around the decision that the IJB of Perth and Kinross took last January to support and approve the proposed redesign programme. This paper that you have before you, item 3.2, seeks to provide IJB members with information on the background of that programme, to update on progress to date, and to provide some narrative around the factors that have contributed to some delays in the delivery of the programme. The report then references the specific recommendation in the interim report from the Independent Inquiry into Mental Health Services in Tayside, before outlining a review of the risks currently being experienced in the service, and which it is argued would be all the greater if we did not continue with the approved redesign programme. At sections 2.1 to 2.4 of the report, background information is provided to members, as I've referenced, who may not have been involved in the work of the IJB at the point when the decision was made to approve the redesign programme. This outlines the process of the review, the option appraisal activity, consultation and engagement in respect of mental health and learning disability services over a number of years. Thereafter, a range of relevant committees and boards, as outlined in section 2.5 of the report, considered the preferred option, ahead of the Perth and Kinross IJB approving that option in January 2018. The report highlights that the programme had the support of a number of bodies, including Clinical Governance Committee, the Clinical Forum, the Partnership Forum, 3 IJBs and NHS Tayside Board. The Mental Health and Learning Disability Redesign Programme was approved in order to deliver a new model for service delivery, as described in section 2.9. This involves moving to a single centre for general adult psychiatry in Dundee, a single centre for learning disability services in Perth, a Tayside-wide intensive psychiatric care unit at Carsview, with rehabilitation, forensic and regional secure services being based at Murray Royal. I would draw members' attention to the rationale for the delivery and development of the Mental Health Redesign Programme, which is summarised in section 2.10 and outlined further in section 2.12. This highlights that the programme was necessary in order to address the risks of workforce shortages, in order to deliver safe and sustainable services, to maintain training opportunities, and to provide a sustainable out-of-hours service. It also sought to address some of the deteriorating physical standards that had been highlighted in various reports, and that has led to the development of a environmental refresh and refurbishment programme. I would wish to draw members' attention to section 2.14 of the report, which highlights that the service is now in a situation whereby these predicted risks are now a reality. A reality which requires positive action to manage, with staff shortages, services delivered over multiple sites, a reliance on locum doctors, and the doctors in training programme at considerable risk. Section 3 of this report provides information on the progress of the programme to date, before highlighting some of the factors that have indeed contributed to delays and which have resulted in relocation, consolidation or contingency arrangements being necessary. Section 3.5 to 3.7 introduces the work of the Mental Health Alliance in mapping out end-to-end clinical pathways for mental health services, and this is the next agenda item that we will be discussing today. Important to reflect that the Mental Health Alliance is the vehicle in which we will deliver the comprehensive end-to-end strategy that Dr. Strang has highlighted as necessary. However, that isn't something that is being held in abeyance to wait for anything. That is something that is being actively pursued. And the key aspects for members to consider in that respect is that we need to reflect on the work that is happening within the health and social care partnerships, where Dundee, Angus and Perth are all developing and have developed and are delivering on community mental health strategies that seek to ensure that people are supported to remain well, and where they need support, that support is provided locally by a combination of voluntary and statutory services to ensure that people's needs are met at home without having to be amongst the 6% of service users who will sometimes need access to hospital beds. In section 4 of the report, I've outlined the recommendation that was made in the independent inquiry, in which we've discussed already today. The recommendation was that we should not implement the proposed changes before a review of the wider needs of the community beyond inpatient requirements. Section 5 highlights the implications of suspending the Mental Health and Learning Disabilities Service Redesign Programme by outlining the significant risks that this would bring. This section recognises that it is essential that we develop a wider mental health strategy that looks at supporting people in their communities. But to do that, we need not suspend the current programme. The development of such a strategy will be led by the Mental Health Alliance, with contributions from the Health and Social Care Partnerships and with appropriate reporting to the IJBs. But the continuation of the current redesign programme is necessary to mitigate significant clinical risk that currently compromises patient safety, as well as the sustainability of service delivery. Section 5 of my report also acknowledges that even with more effective end-to-end community services, we will always need a bed base to provide care, treatment and support for a small number of people who need inpatient support. The Mental Health and Learning Disability Service Redesign Programme seeks to ensure that this care is provided in safer and higher quality, patient-centred environments of care to those people who need to be in hospital. And the sooner we can achieve this, the better for their patients, for their care and for their recovery. Section 5 of my report highlights that the Mental Health and Learning Disability Service Redesign Programme can contribute significantly to reducing the risks in relation to workforce and environment. IJB members will wish to note that Section 5.5 and 5.6 of this report, where it advises that the continuation and acceleration of the current redesign programme will enable clinical and operational risks which compromise safety and sustainability, to be addressed in a planned and effective way. And goes on to say that these risks are such that if the current programme is deferred, there is every likelihood that for clinical and operational reasons, the service model may need to change. My report concludes at Section 6 by highlighting that the compelling reasons why this redesign programme was approved by so many committees and boards and endorsed by this IJB in January last year, these reasons remain and indeed are all the more pressing. The report recognises the need for end-to-end pathways to be redesigned and improved, and none of us will probably dispute the need for us to seek to ensure that we redouble our efforts to ensure that people are supported to stay well and supported in their local communities. However, the development of a comprehensive mental health strategy is not predicated on the suspension of the redesign programme. Indeed, the strong clinical view is that the delivery of the redesign programme will be a key factor in addressing the significant risks that services are now facing. And consequently, on the basis of that clinical view, I would respectfully recommend to IGB members that they endorse the continued implementation of the approved programme and accept the recommendations in this report. Thank you very much.
Thank you, Chief Officer. Are there any questions on the report? Councillor Purvis.
Thank you, Chair. I have a number of questions, if that's okay. I'll do them separately. Is that fine?
I presume they're on different sections of the report,
yes.
So we'll take them separately.
Oh, right.
As in one at a time.
Yeah. I thought you were going to ask them in chronological order there, because I would have to rearrange what I was going to say. My first question is about 5.7 under the risk section, where we've got the implications of deferring the redesign programme and then the benefits of accelerating it. I do have some specific questions about some of the stuff on the table. I'd just like to ask first, I think I was a bit disappointed that this was the way in which it was presented. What I would have preferred is a full assessment of the benefits and the possible implications of both pausing the status quo and indeed accelerating it. I don't think that this gives us the full information, because the implication here is that implications of deferring are all negative and benefits of accelerating are all positive, whereas clearly we have a recommendation from the interim report of the independent inquiry that does not agree with that. And just in the interest of balance, I would have hoped for a different way of presenting that. I'd just like if anyone wants to comment on that initial point before I go into the specific.
Thank you. So I'm sorry you're disappointed with the lack of that more comprehensive review. I think it is important to reflect that Dr. Strang's recommendation was the catalyst for having to bring back to the IJB a consideration in relation to whether or not we should wait for the delivery and development of a comprehensive strategy before addressing some of the significant risks that are being experienced in our hospital wards at the moment. I took the view that it was important that we continued to, that I needed to convey to the IGB the implications of us continuing or of stopping. I think it's important to, whilst absolutely and respectfully acknowledging Dr. Strang's recommendation, to see it as advisory, to see it as something that has been born of his consideration of the views of a number of people who have come forward. And whilst not in any way wishing to diminish the significance of his report and the interim report, I think it's also important that this is balanced with the current clinical view, the operational imperatives, and the added value that the redesign programme was seen to be delivering when it was first approved, and would continue to do so if we were to continue to deliver on it.
Okay, thank you. So just on to some of the specific points included in this table. The first one, there was a lot throughout the paper about the continuation of the doctors in training programme and the fact that the redesign programme might help to ensure that we can continue to train doctors within the service and hopefully then retain them in future. I'm just wondering if any consideration has been given to the fact that it might not just be the fact that the redesign programme hasn't been undertaken that is the reason why there might be problems with doctors either wanting to come to Tayside to train or to stay in Tayside. Obviously, there has been a lot of negative press, both in the media coverage and documentaries and various other things, some of which have happened around the time of this inquiry and the commissioning of it, in particular in relation to Carsview, which is obviously where we're talking about centralising generalised adult psychiatry. Is that not a consideration in addition, but that isn't included in the report? I would perhaps suggest that some of the reasons given aren't, while they might be reasons, they aren't the only reasons why doctors might not want to train in Tayside.
I don't think the issue is about whether or not doctors want to train in Tayside. I think the issue is potentially and increasingly importantly about whether doctors will be allowed to train in Tayside. We are currently under enhanced monitoring from the General Medical Council and NES. We are about to receive a visit from both bodies in relation to whether or not NHS Tayside will be in a position to continue to receive doctors in training. I am going to defer to my colleagues on the other table in relation to explaining what the implications of that would be in terms of the sustainability and delivery of our services. I think it's also important to reflect on the availability of our consultant psychiatrist workforce who oversee the work, the doctors in training, is critical, and the current challenges are that we have, as says elsewhere in the paper, significant vacancies in that workforce. That means that we need to consolidate our available workforce and to centralise our services as the redesign programme had expected of us. But I don't know whether, I'm very pleased that we have with us today Professor Peter Stonebridge, who's the Interim Medical Director from NHS Tayside. We also have the Interim Nurse Director and colleagues from the mental health leadership team who may be better able to explain the implications of us potentially losing our doctors in training status.
Professor Stonebridge.
Thank you very much. Essentially, to be a training scheme, we've got to give safe and appropriate environment as being supervised by consultants who are trained in psychiatry. So a non-psychiatrist can't train a psychiatrist. So fundamentally, a large number of our senior cover is not psychiatrically trained. So the GMC now, I think this is their third visit whilst in enhanced monitoring, and we are being given more room to try and sort these problems out. But fundamentally, when a junior doctor is on a ward, there is an expectation that there is a consultant psychiatrist available to him such that he runs into difficulties, not just any doctor. We have therefore got to put what we have across a larger number of sites than we can actually cover. Now, we've discussed this specific problem with Scottish Government, and we pulled together impact assessment should we lose our trainees. The anticipation is without significant change in a relatively short period of time, we will.
Can I make a couple of comments,
Mrs. Wood.
Chair? Thank you. Really just to emphasise the impact should the training programme be withdrawn. So if that decision is made at the revisit in October, the decision will be immediate, and that the loss of our doctors in training, they are a really important part of the workforce as well as part of their experience in psychiatry. And this will be added pressure onto the consultant group of staff who will then need to cover the work of the doctors. We also have an on-call rota that is a training grade rota, and there will be significant issues in terms of providing an on-call rota, and major issues for consultant job plans should we require them to cover junior doctor work.
Not to underemphasise the importance of that latter point, essentially you'd probably have to have consultants resident on call, which is a 3-session commitment should they agree to it. Now, if they don't agree to it, there's a job mediating process, which at its shortest, if they appealed at every stage, would take us 26 weeks out. And therefore, if we then say a consultant has a 10-session job plan, of which you're now knocking quite a few of those direct clinical care sessions out to cover the wards, then they will not be doing clinics. And therefore, the impact of losing trainees is actually quite immense.
Okay, I'll come back to Councillor Purvis for your next question, but I just wanted to check, as we're discussing this at the moment, if anybody else had any questions about this doctors in training issue. Okay, Councillor Purvis.
Okay, thank you for those answers. In relation to the next item on the table about the reputational risk, and I do understand some of the suggestions here about the refurbished Rannoch ward, and that the users, some of the users who are going to go there are quite keen to do so. I just wanted, again, in terms of the balance here, is there not also a reputational risk? And these things are often subjective, and we have similar situations in the council where obviously people have different views on these. But is there not a reputational risk of having had an independent inquiry commissioned, albeit not by this IJB, to feel the need to make an interim report and then make a recommendation that's quite explicit about the need to pause? Is there not a reputational risk in not heeding that recommendation? That's part one. And the second part is that given that there were quite a number of people who were not in favour of the adopted option when the original process was going through to choose the redesign programme, is there not a reputational risk of implementing this redesign programme when it clearly doesn't have universal support? Just again, in the interest of balance in these reports, that isn't referenced here. Chief Officer?
So the risks of not heeding the recommendation, I suppose absolutely that there is that risk. There's a need to recognise that Dr. Strang made that recommendation for a reason on the basis of what he was hearing from the people who contributed to his interim report. However, I think that notion of balance is absolutely key, and I think my attempt has been to include within the report that I've brought to the IJB today the information that enables that wider consideration to be given to the implications of potentially stopping something that by its very nature is critical now and is one of the key measures in which we can take forward to mitigate some of the risks that are being experienced. I think absolutely I respect the fact that the redesign programme did not garner universal support, and I recognise that there are people who are concerned that the services that are currently provided in Dundee may not continue to be provided in Dundee. I recognise too that there are people in Perth who are concerned that the services that are currently provided in Perth may not continue to be provided in Perth. That was, however, the decision of the IJB, and it was, I anticipate, based on a recognition that with the available workforce, with the demand for beds, we need to develop centres of excellence and expertise that enable the highest quality of care to be delivered in those two cities, and that we need to ensure that the opportunities for people to access that care are enhanced. So I think in these circumstances, inevitably there will always be people who will be not necessarily supportive of what needs to happen, but the determination of the IJB was that it did need to happen for the reasons that we've outlined.
Just before we come back to you, Ms. Reid.
Thank you. It's actually just building on the point that Councillor Purvis was making. It's a question for the Chief Officer or perhaps colleagues from NHS2 side. You mentioned about the mental health delivery in both Perth and Kinross and indeed in Dundee. In relation to benefits and risks, can I ask, in terms of the other IGBs and health and social care partnerships across Tayside, what are they doing in relation to strategic planning that may or may not either benefit or create another risk for the hosted mental health service here in Perth and Kinross?
Chief Officer.
So I suppose like yourselves in Perth and Kinross Health and Social Care Partnership, each of those other IJBs and indeed the Health and Social Care Partnerships in the two areas are committed to delivering and developing a local mental health strategy that seeks to ensure that sufficient provision is made to enable people to enjoy and benefit from good health and to be supported when they're not in good health to have services delivered locally. Each of the IGBs has considered, and officers within the health and social care partnerships have considered the implications of the redesign programme and the shifts in services, and are designing their local strategies in order to ensure that they align quite closely with the direction of travel that's been taken through the strategic commissioning and planning activity of this IGB and the redesign programme in relation to mental health services and learning disability services. So this is something that is being considered not only in this place but by health and social care partnerships and indeed by other IGBs in the context of their commitment towards ensuring that their local populace are able to access high quality services.
Do you want to come in on this point as well?
Yes, it's just to back up what Gordon said, really. I've recently read the Dundee Mental Health and Wellbeing Strategic Commissioning Plan, which is very good, and I think would answer the question about how they are. It's the point I was making to David Strang, how they've started with prevention and social prescribing and looking at, not rehabilitation, recovery, but they've identified 4 strategic priorities, how they'll take it forward at a community level. And that really addresses the issue of, forget about the beds for a minute, just park the beds for a minute, because that's for the small number of very complex, very sick patients who will need admission. We totally accept that. But I think having that plan in Dundee and in Angus gives them a reassurance that they have got a strategy in place to cope with community mental health. And I think that's a model, really.
Okay, thank you. And okay, Chief Officer.
Sorry, I just wanted to reply to that and say that equally Perth and Kinross are working on a strategy. We were planning to bring a paper here today on the development of our local community mental health strategy. We will do so at the next IGB, and it reflects the contribution that third sectors and communities can make to help people be connected, to be supported, to remain well. It reflects the fact that in Perth and Kinross we have 6 social prescribers. We've got Action 15 money. We're engaging with the third sector, and we are looking at how we can ensure that we are doing what we can to move upstream in order to reduce the impact of mental ill health and to reduce the need for people to have hospital treatment.
And Mr. Russell, you wanted to come in on this point as well.
Thank you, Chair. I just want to reinforce the view that there is not an absence of strategic planning for mental health services in Tayside. Dundee presented their mental health and wellbeing strategy to their last integrated joint board, which clearly sets out a co-designed, co-created plan for mental health and wellbeing in the city, which considers universal services against a tiered model to the requirement for inpatient services to support the residents of the city. And equally, our Angus have very clearly articulated their integrated care model, which sets out how integrated community care is provided across Angus for people of all conditions, including mental health. So there's clear strategic planning for mental health and wellbeing happening in Tayside currently.
Okay, thank you. Back to your questions.
Thank you. Just to pick up on directly the response from the Chief Officer to my previous question, just to be absolutely explicit, you are quite right. The IGB approved this redesign programme in January last year, and the comments about reputational risk are no way to criticise those who are implementing or trying to implement the strategy. Obviously, until such a time as the board decides otherwise, that it's entirely appropriate for you to do that. Just 2 further points to note, though, that only 2 members of the IGB who were on the board at the time as substantive members are still members of the IGB and did so on the basis of a number of insurances. And obviously, the interim report's recommendation does change the dynamic. So just to make that point. That wasn't my question, that was just a comment.
What? Do you want to carry on with your, unless you want to reply to that, Chief Officer?
Yes, please. So I recognise, I suppose that's probably why there is more background information in this report than might otherwise be the case, that there have been changes in IGB membership. And I accept and recognise Councillor Purvis's point in highlighting that there are only perhaps 2 members of this IGB who were around and involved in that decision making. I would, however, invite IGB members to reflect on section 2.5, which shows that there were any number of boards, committees in relation to governance, in relation to clinical care governance, in relation to staff side in the partnership forum, who were involved in considering the options and approving the preferred option before it came to this IGB.
Thank you, Chief Officer. With permission, Chair, what I'll do is ask a final point on this table, and then perhaps take a step back and allow other people to ask questions, and hope that some of my other questions are addressed, and if not, come back later. Is that okay?
Permission granted.
Okay, thank you. My final point here is on the ligature anchor point reduction programme for general adult psychiatry. It says here that it would cease if the redesign programme were paused. Does that need to be the case? Surely we as an IGB, if we wanted to pause the redesign programme, could put any conditions or restrictions on that. We've already spoken earlier about the acknowledgement that any clinically urgent or inpatient requirements that would happen at the same time, that would happen during a pause, would obviously have to be dealt with. Surely the same could be said for ligature anchor point reduction programme, because obviously that's an issue of patient safety. It's just whether or not that a cease is absolutely essential with a pause.
Chief Officer.
Thank you, Councillor Purvis. So I think I would be able to answer that, but I would rather that perhaps I could invite the Associate Nurse Director to explain, Keith Russell, why that has why the ligature anchor point reduction programme requires us to continue on the journey that we're on.
Sorry, I should have thought to bring in Mr. Russell first. Councillor Purvis, just to clarify the question.
What bit of it would you like clarification on?
Can I? So, I'm wanting to understand, is the question in relation to why the ligature anchor point risk reduction programme would have to cease if the redesign programme was paused?
Yes, that's the question.
I would start off by saying that design principles in mental health services have changed significantly over the last 10 years and over the lifetime of the buildings that patients are currently occupying in NHS Tayside. And the level of refurbishment that is required from issues of sanitary ware in ensuite bathrooms to door design and bedroom doors, and the refurbishment that's required to bedrooms and bathrooms is such that it cannot be undertaken in wards that are populated by patients. We are progressing the work that we can, where disruption to patients is minimal, but to deliver all of the ligature anchor point risk reduction work that we want to, and to deliver the new redesigned bedrooms and ensuite bathrooms, that requires vacant wards for us to work safely in. And the other point I'd like to make is that we are just about to sign off on the redesigned ensuite bedroom and bathroom, and a mock-up room is available, which clearly shows how design principles have moved on in mental health services. And my concern is that to delay the programme, it will impact on our ability to make significant changes to not only the safety of patients, but also their privacy, comfort and dignity in terms of the environments of care that we're currently looking after them in.
Okay, thank you for that answer.
Okay, does anybody else want to come in on the ligature anchor points?
And regarding the ligatures, I believe that there was a report back in 2015 which highlighted the problem of ligatures at both Carsview and Murray Royal. And that was back in 2015, and they asked that it would be addressed as a matter of urgency. So why in 2019 are we still talking about it?
Mr. Russell.
There's been some very tragic events in inpatient services in Tayside, and understandably we want to make sure that our environments of care are safe. And in Morden, significant revision has been undertaken to the inpatient environment to make that environment safer for patients. But the overall environmental challenges of a general adult psychiatry ward with 6 internal corridors, 3 internal courtyards, multiple access egress points, and extremely poor lines of sight for staff means that that environment is no longer, reflective of the design principles that we're currently applying to the redesign of general adult psychiatry services. It is not a set of circumstances that we would look to design into general adult psychiatry admission wards in 2019.
Okay, does anybody else want to come in on this point? Councillor McDade?
Yes, thank you. I want to explore a bit as to why this particular programme is tied in to the redesign, because when we visited all the sites in 2017, and I think you were there, Mr. Russell, we were told at that point that there was an ongoing programme of work to bring it up to the standard required, and we were shown mock room at that point of certain things that had been tried out and tested to see if they would work, and they were looking to implement, and that was at Murray Royal. So I'm quite concerned actually about the lack of action in 2.5 years on what is quite a important point really, and Mrs. Summers has just outlined that it goes back further potentially. So I'd like to understand why there's been so little action, and why, if it is something that's required by the health and safety executive, we wouldn't be looking to implement it. Even, I appreciate you've just outlined the difficulty, but surely it will become even more difficult to do future redesigns of the rooms, which from my understanding from what you've said, this sort of thing gets updated on quite a regular basis. If we reduce the number of beds by 22, then in the future we're going to have even less room to manoeuvre to do future redesigns of the rooms.
Okay, just to clarify that in terms of going back further in Mrs. Summers' question, the 2015 date is in 2.12 of the report, if anybody wants to come in on that point. Do you want to come in first before somebody answers that?
Yes, I do actually. Councillor McDade, you've mentioned reduction of 22 beds. I don't think that's a relevant comment to make in these circumstances.
I'm quite happy to retract that.
Mr. Russell.
Forgive me, I'll try and achieve a question out of that observation. I think that the position that little has happened is not an accurate position, and I'm more than content to share the breadth and depth of the ligature anchor point risk reduction work that has been carried out across the mental health estate. For example, in Morden alone, that includes the replacement of all bedroom windows. It includes the replacement of all King's Fund beds. It includes the removal of ensuite bedroom doors and the replacement with anti-ligature shower curtains. It includes the replacement of bedroom door sets with door top alarms. So again, I would urge caution around the observations that nothing has happened, because there's clear evidence that a lot of environmental improvement has been delivered. There has been significant work undertaken to arrive at a safe standard room specification, which has been the basis for the redesign of the new ensuite bedrooms and ensuite bathrooms, which, as I said earlier, is at the point of being signed off by the architect commissioned to deliver the refurbishment.
And Councillor McDade again.
Yeah, no, I think that's very helpful, and thank you very much for that update. I think that does sound like there has been significant progress made. I'm still slightly confused as to why it's linked so closely into this, given that, as you've outlined, actually an awful lot has been able to be done in the last 2 years, it seems.
Mr. Russell.
The requirement to refurbish the bedrooms at Carsview to bring them into line with the standard room specification would require sanitary ware to be replaced, ensuite bathroom to be stripped out, new flooring to be installed, a new bed to be positioned, an integrated wardrobe to be built, a new alarm system to be wired into the room, new electrics to be put into the room, new access hatches to be put into the room to enable workmen to have routine access to services. I don't believe that can be reasonably done in wards that are populated by people who are recovering from their mental health. I equate it to if this was your home, would you be looking to move out, or would you be looking to do one room at a time? And if we do one room at a time, we also increase the cost of the refurbishment.
Okay, any other points on this before we move on? Mrs. Summers, yeah?
Yeah, I think the point that Councillor Xander was trying to make there was that the refurbishment, including ligature, addressing the problems there, seems to be quite recent, rather than back in 2015 when it was highlighted as an urgent necessity that had to be done then. And we're talking about just quite recently, really, that it's now been addressed. And incidentally, there was 2 suicides that I know of because that problem wasn't addressed back in 2015.
Okay, Mr. Russell, do you want to come in on that, or we'll take another question?
I would just want to introduce a note of caution around those observations, because the work has been undertaken since 2015. And I can provide a detailed timeline if that's what was required about what has happened when. But again, I would just caution against an observation that nothing has happened in response to people taking their lives in inpatient services. That is not accurate.
Okay, I think it would... Mrs. Wood.
I just wanted to add something on to what Keith's saying. Whilst there has been significant anchor point reduction work that has happened since 2015 and now, there is far more mature design thinking that allows a full specification for a bedroom and facilities for patients, which is a very holistic approach and driven forward by Keith, that allows a really high quality standardised specification to be put in place across all of the estate. That does not mean that nothing has been done since 2015. There have been actions absolutely taken and underway. However, the design principles are maturing as the years go by.
Okay, thank you. I think maybe it would be helpful if the board took up your offer, Mr. Russell, of providing the detailed timeline of the actions that have been taken. Now, do we have any other questions on this point, or will we go on to the next person? Okay, was your question on that or something else?
Moving into the next question.
Oh, right, okay. Well, in that case, Councillor Drysdale was next.
Thank you, Vice Chair. Mr. Patterson, your recommendation here is to a degree at odds with that of the interim recommendation of Dr. Strang. I'm aware, obviously, you came into post on the 1st of April, and the report was published in May. And I'm just wondering, Dr. Strang's report, that is, and I'm just wondering what dialogue there was between Dr. Strang and yourself with a view to Dr. Strang understanding what you perceive as the imperatives around progressing with this service redesign programme.
Chief Officer.
So there have been a number of conversations. I think it's important to reflect the fact that Dr. Strang has had the opportunity to receive presentations from Dundee and Angus IGBs in relation to the development of their mental health strategies. He has had the opportunity to meet with colleagues in the mental health leadership team, and there are further opportunities that he will be provided with that will ensure that he's well cited on the quality improvement work that is underway, the ways in which we are improving the environment, the ways in which staff are being supported and trained, the reduction in the use of restraint, the fact that our intensive psychiatric care unit is being seen as a model for others in Scotland. So there are lots of opportunities that we are providing Dr. Strang to ensure that his report is well evidenced, balanced and is able to be very well informed. I myself have had a couple of meetings with Dr. Strang in relation to which I have had the opportunity to discuss the context of his recommendation and the clinical view and the view of the mental health leadership team, that whilst we absolutely recognise that we would like to have started from a position of developing an end-to-end strategy, we are where we are, and where we are is in a situation where that strategy is being developed, it's being delivered locally through the community mental health strategies, and that the continuation or otherwise of the mental health redesign programme need not be predicated on whether or not we have a strategy. These two things can be delivered in parallel, and my contention would be that they absolutely should, and that we should be redoubling our focus on the end-to-end pathways and the community strategy while the redesign programme is proceeding over the next 18 months or so.
If I may just firstly follow up on this, and then I did have another question, if you'll indulge me. Just to be clear, you've set out the meetings and dialogue that you had with Dr. Strang. How much of that was before his interim recommendation? How much was after?
So I only met with Dr. Strang, and I suppose he was only aware of my appointment and arrival after he had published his interim report. So I had no opportunity before then. I know that colleagues had the opportunity to speak with him. And, you know, since then we've had a couple of meetings and other conversations, and he is aware, and as he has referenced, aware of the views of the leadership team, the clinical views of NHS Tayside colleagues, and of the recommendation that I've made in my report, but I hadn't met with him before his report was published.
Thank you, that's interesting. Thank you for clarifying that.
Sorry, Councillor Drysdale, can I just check if there are any other questions on that point before we move on to... No, okay, carry on.
Thank you. I appreciate that the next item on the agenda relates to the Tayside Mental Health Alliance, and no doubt you will be giving us more detail on that, you know, in, well, I was going to say this morning, but sometime today. So, hopefully today. But I wonder, in the context of what we're looking at here in this paper and the sequence of papers that are before us today, if you can give an overview, just a brief overview in a couple of sentences, if you like, of what your perception is and your intention is in relation to the role of the Mental Health Alliance as opposed to the role of this Integration Joint Board.
So over recent months, the Mental Health Alliance has come together and has had a series of early meetings, the focus of which has been to clarify its role, remit and priorities, and to grow the membership appropriate to supporting the delivery of that work. The Tayside Mental Health Alliance will act as an enabler for NHS Tayside and the 3 health and social care partnerships to work collaboratively to look at how we can develop some synergies, where we can take a once for Tayside approach, and where we can weave in the development of the health and social care partnerships community mental health strategies into a redesign of patient pathways and consideration of how we can ensure that we move the focus of our activity upstream and are better able to support people to remain well whilst we are delivering improved environments in the inpatient service. I will say a bit more about that at the point when we reach that agenda item, but I hope that's helpful in terms of providing a little bit of context.
Okay, if I could just do a quick follow-up and question on that bit. In terms of, I know we're coming on to the Mental Health Alliance, but it's directly relevant here. One of the things that was asked at, I think, May's board meeting was whether there was potentially a professional bias on the the emerging membership of the Mental Health Alliance at that time, and I was given assurances that we were going to be getting quite a lot of third sector carer service user representation on the Mental Health Alliance. Can I just quickly check with you, Chief Officer, how much wider representation other than the directly professional representation there is on the Mental Health Alliance at the moment?
So the Mental Health Alliance includes representation from NHS Tayside and the 3 health and social care partnership. It also includes representatives from advocacy and third sector, as well as the staff side. I don't know, Ms Wood would be better able to provide an expanded answer, but I can certainly confirm and assure you that the membership, as I've described, it has grown and will continue to grow as the work gathers apace.
Okay, does anybody else want to come in? Mrs Summers?
The Alliance has been set up for quite a wee while now, and there are still no carer or service user representatives. And I would say that they're the people that are the most important. They're the ones with the lived experience, and they should be in from the start, not as an afterthought.
Mrs Wood, you want to come in on that?
Okay, thank you, Chair. So in terms of the Mental Health Alliance, one of the key things around establishing this was not to replicate the infrastructures that are already there in the health and social care partnerships around service user involvement, around public involvement. And what has been agreed with the leads from each of the health and social care partnerships is that the Mental Health Alliance needs to connect with and in to these already formed structures. So that is the plan around how these connections will be made. It's not to set up another set of groups, because they are there in Angus, in Dundee and in Perth and Kinross, and there will be two-way communication and connections made through that route.
Okay, thank you, Mrs Wood. I think maybe I shouldn't have diverted us onto the Mental Health Alliance too much at this point, given it's next on the agenda. But Councillor Purvis,
Chair, I would have to slightly disagree with you on that. I know that agenda setting is difficult, but given that there is a recommendation in this report which relates to asking the IGB to commit the Tayside Mental Health Alliance to do something, I do think that these questions are pertinent, and perhaps it would have been useful to have the verbal update before then. But just in terms of that, and in order to inform our discussion and decision about the recommendation that's before us, I would just like to clarify, having seen the draft terms of reference, which I know aren't on the agenda today, I am slightly concerned about perhaps some of the responsibilities that are being set out are perhaps straying into strategic areas and the statutory responsibilities of this board. I would just like to seek clarification that this board will have to approve those terms of reference.
Yes.
Thank you.
Sorry, I spoke over you in introducing your reply. That was a yes from the Chief Officer. Okay, Mrs Summers?
Yeah, my concern and the concern of carers and service users is that, you know, you are progressing, you're making very important decisions about, you know, what's going to affect them, and that they should be in now, you know. I don't know what the barrier is, you know, is there certain procedures have to be in before carers can be called in, but, you know, it shouldn't be all managers that are making the decisions without input from the people that's been affected.
Okay, thank you, Mrs Summers. We'll come back to membership of the Mental Health Alliance on the next item on the agenda, but I'm conscious of the question that you're raising because it's a question that I have too, and we'll make sure that we come back to that. Who else did I have? Mr Drummond.
Thank you, Chair. I'm just on under number 3.1, progress to date. Whilst the programme has a number of achievements, now for me, I've actually got more crosses than ticks for achievements. I appreciate there's a lot of remedial works that's been completed, but I can't see any patient focused within that. My concern is also under 3.4, where we go to the third paragraph at the very end of 3.4. We did raise concerns. It talks about transition team highlighted that there was an insufficient staff to progress the move to LDAU. Can I like it minuted, please, that we did raise concerns during the consultation process of option 3A, that there may be an issue with staff moving from Dundee to Perth and Perth to Dundee. And obviously that has been a challenge, and that has been raised. And just for accuracy within the paper here, it talks about the contingency arrangement required to be explored, which was not supported by the Area Partnership Forum. That is not actually accurate. It was not supported by the staff side Area Partnership Forum, for accuracy, because we're already in three contingency arrangements within mental health at this moment in time, being Mulberry, the crisis team and Craighill.
Thank you. Does somebody want to pick that up? Chief?
Well, I would only be able to note and accept what you're saying, but it may well be that Ms Wood or Mr Russell has a comment to make on that, or not. I don't know.
Mr Russell.
It would be fair to say, Alan, that this implementation of this redesign programme has not been without significant challenge for people and primarily for our staff in terms of how we support them in terms of their places of work, etc. So I note the comment that you've made around that, and I note the point of accuracy around the staff side Area Partnership Forum rather than the Area Partnership Forum. Thank you.
And Mrs Alexander.
I think it's really important that the paper is factual, because this is now in the public domain. So the Area Partnership Forum is the Chief Executive and myself that co-chair that. So it wasn't the Area Partnership Forum that disagreed, it is staff organisations that disagreed. So I think your papers need to be sorted, given that they're out on the web page.
Okay, thank you. I think we'll the point is made and taken on board, so the correction will at least be recorded, reflected in the recording of the minutes, recording of the meeting, and maybe in the minutes as well, Clerk. Yeah. Okay. Thank you. Next question, Councillor McDade.
Thank you. I'm in part 5.7, and it's the third box down where reputational risk is identified from carers who've already visited the refurbished Rannoch Ward and Murray Royal ahead of the planned move. And I'm wondering if perhaps there's also a reflection on reputational risk of the public perception of the responsible bodies not taking cognizance of the sole recommendation of the interim independent inquiry.
I think that was a point that Councillor Purvis had brought up.
Yes, but I think, given that it is quite specifically said, and I think it comes back to Councillor Purvis' original point about having the pros and cons of both things, I think actually it's a really significant point for the whole point of the independent inquiry in the first place was there was this perception that people weren't being listened to. I think that needs to be reflected.
You want to come in on that, Chief Officer?
Yeah, I mean, I won't answer the same question differently the second time. So I think it's important that the reputational risk is recognised in the context of those families who are desperately waiting for their loved ones to move from a quite unsuitable hospital ward in Dundee into a newly refurbished patient-centred environment in Murray Royal. And I had the pleasure of spending some time with staff in the Learning Disability Assessment Unit. I was struck by one staff nurse who said to me that she was desperately wanting to see her patients be able to be moved into this new environment, which they and their family, the staff and their families had visited. And I suppose I had to challenge myself because my assumption was that maybe she lives closer to Perth, but actually she lives in Broughty Ferry and she wasn't interested in how much of an inconvenience it was for her. Her commitment and her driving motivation was about better care for the 8 or 9 people who are currently ready to move from Carsview to Murray Royal.
Just if I may, I would absolutely share your view on the proving people to a better environment. It was actually the deciding factor for me back in 2018, having visited Strathmartin and seeing the conditions in Strathmartin and visiting and comparing that with Murray Royal. I don't think anyone would be in disagreement around that. The conditions are not perfect by any means, and I think so I would absolutely share your aspirations on that. I think my concern is just about there are much wider reputational risks, both internal and external staff and the public, that we need to be cognisant of as well.
Okay. Different topic.
Yeah, I think
Mrs.
it's
Summers?
very good that people with learning disabilities will be moved to a nice environment, but it's at the expense of people with severe mental health problems who live in our own area here, and they're being asked to go further away from home to a place that does not have a good reputation and that people do not want to go to. Even people in Dundee don't like the environment at Carsview, but that's what we've been asked to do. And I'm very pleased for people with learning disabilities, but I have to say it is at the expense of people in mental health distress in our own area being asked to move further away from home, which is not what's recommended by the Scottish Government.
Okay. Have you got a question, Councillor Purvis? I've got a couple.
A few other questions, if that's okay, Chair. First, I'd just like to ask, in terms of Strathmartin, obviously the original paper was proposing relocating one of the learning disability units to the Strathmartin site, and obviously for various reasons that was deemed not to be feasible from a building and cost perspective, it says here. I'm just wondering, has that ever come back to, obviously I haven't been on the board the whole time, but since the original decision, which obviously included that as part of the redesign package, has that ever come back to the board for agreement that that wouldn't progress? And because obviously in terms of cost implications, the board could decide that it wants to, I'm not saying it would, but could decide it wanted to fund those additional cost implications or whatever. I'm just wondering, from a governance perspective, has that decision that says it's been taken come back to this board for approval?
The decision to close Strathmartin was part of that package of measures that the IGB agreed in the context of moving to 2 sites from 3, as I understand it. The challenge that we have at Strathmartin is that we have to concentrate our efforts much more effectively on ensuring that the large number of patients who are there who need not be there for the want of a more appropriate community-based placement are able to be discharged from hospital in order that we can make progress with the developments that we're seeking to achieve at Strathmartin.
And Mr. Russell?
Can I just come in on that point around delayed discharges, because that's a significant issue for people with learning disabilities in Tayside. There's a significant number of bed days lost every year for people who are unable to leave hospital on time. There's 15 of our 26 operational beds in learning disabilities currently occupy people who shouldn't be in hospital. That equates to 14,000 bed days in a year. Perth and Kinross's contribution to that is 4 people who are delayed. But that equates to 6,600 occupied bed days. So I absolutely agree with the Chief Officer's view that there has to be a collective focus on reducing the number of delayed discharges in learning disability services so that the available beds can be used for people who are in the community and who require admission to services.
Thank you for that. Sorry, I'm just wanting to clarify. If my understanding is incorrect, I was under the understanding that part of the programme that was agreed in January 2018 included 2 sites, and what we're now saying is that, well, what happened in October 2018 from your timeline is that there was a decision taken that we wouldn't be progressing with the Strathmartin relocation. My question was, did that, well, first, is that, am I correct in my understanding that that was part of the original proposals?
My understanding is that, so Ms Wood's going to provide, rather than her my understanding, she's going to provide them with the facts in this regard.
So the reference in this paper is not that Strathmartin would not move as planned. This is about the logistical plan of the relocation and the times when each part of the whole would move. And initially, it was anticipated that the low secure element of Strathmartin Hospital would move over to Murray Royal into the Rohalian Clinic. And in order to do that, the plan was that the Learning and Disability Assessment Unit, which is actually in Carsview, would then move over to Strathmartin, to that vacated area. And what then would have happened is that the site would have remained stable by way of response. However, the environment that the LDAU required to move into in Strathmartin could not be made to a satisfactory specification in terms of the building work that required, or in terms of the cost that initiated. So that meant that it's not a change to the programme, it's a change to the order of moves and how we could achieve that.
So the assessment unit was only temporarily supposed to move to Strathmartin? Yes. Right, okay, so you just changed the order in which right, okay, that's fine. My next point was on financial risk. We've talked about reputational risk and some other types of risk that we might be subject to whether we progress with the redesign programme or not. I was just wondering, given that there is a review underway at the moment, or starting by the Mental Health Alliance, which the suggestion is that this will run in parallel with the redesign programme. I suppose my question is, if the outcome of that review is inconsistent, even in small ways, with the redesign programme, so suggests that some of the changes that were agreed in January 2018 should not be implemented, is there not a financial risk in terms of doing improvements that we would then not have to do, or making permanent changes that then might have to be reversed? And if that's not the case, well, do you want to answer that part first?
So I suppose I feel somewhat challenged by having to anticipate the outcome of the wider redesign programme and consider whether or not that might result in a financial risk. What I would say is that we are confident that the investment that has been made by NHS Tayside in relation to the capital works is about delivering far more patient-centred and safe environments, and that we will require to have the highest quality of bed base in order to meet the needs of the population moving forward. What we haven't got is clarity about the extent to which we can deliver more effective community services to diminish the need of that bed base. But we will be embarking upon that improvement in order to ensure that the people who are there here and now are receiving the highest quality of care possible.
I suppose I'm not asking for anyone, of course, to prejudge the outcome of any review. It's just that if we were to suggest there was no financial risk or there would not be any financial risk, that in itself would also be prejudging the outcome of the review, because we would be suggesting that we would be progressing with all of the changes anyway. So I'm just, again, it's just about achieving balance in our decisions here. There are a lot of things that have been put in terms of what would happen with not progressing with the review. I'm just suggesting that there might be other risks that would happen if we were to progress with the review. That's maybe more a comment if you've already answered.
Okay, I've got a question then, or two, if that's okay. I think my question is on, I'm trying to find the right page. So in section 2.10, under the service configuration, the rationale for the site configuration is outlined below. And we're talking about putting inpatient general adult psychiatry in Dundee and inpatient learning disability services in Perth. And that in both cases, the redesign programme creates a centre of excellence. And I think my question is relatively general. It's how does the redesign in and of itself create a centre of excellence? I would have thought that a centre of excellence was to do with the practices, the teaching, the staff, a whole suite of things, rather than just the location of the facilities. Is that best to go to Mr. Russell, I think?
I would agree with that observation. Moving a building doesn't necessarily mean that you therefore create a centre of excellence. What I can articulate is the things that we are doing to support learning in the environment and to support improvements in practice. The Chief Officer touched on a number of the actions that are being taken through our improvement plan. I think one of the best ways to give people assurance about quality of services is to work through an accreditation process. We're currently working through the accreditation process with the Royal College of Psychiatry for our intensive psychiatric care unit. We're about to start on our accreditation process with the Royal College of Psychiatry for working age adult wards, and to start to build a process where our wards are accredited as places of excellence by external bodies. In addition to that, we have a focus on how do we return learning to working environments. We've just are about to appoint a clinical nurse educator who will lead on practice-based education. We've just delivered a 15-week academic programme based on the identified needs of nursing staff that ran concurrently across 2 hospitals. 521 people attended those sessions over a 15-week period. We have a quality improvement programme which the quality of that work is being recognised nationally. The work of the intensive psychiatric care unit in improving observation practice is the best practice example for Scotland. The Royal College of Psychiatrists has asked us to write an article for their newsletter about the work that's been undertaken there. All of these, I believe, are steps on the road to improving the experience of people and moving us towards a position of excellence in terms of our educational practice, our clinical practice, and the care that we deliver to people.
Okay, thank you. And I think, Professor Stonebridge, I saw you reaching for the microphone as well.
A couple of issues. One was going to touch on the reputational issue, and fundamentally, the reputation of mental health services in Tayside would probably never recover if we lost our trainees. Fundamentally, we would get most of our consultants from our trainee pool, and therefore the ability to recruit and get consultants going forward without access to trainees who have a high regard of the training that they get within Tayside would severely inhibit this. So there is a very long-term issue here, and that's aside from the fact if you start putting consultants resident on call, not doing the job that they want to do, they're likely to look elsewhere where the job market is free and open, and it's certainly a seller's market. With respect to the Centre of Excellence, one of the issues that cuts across most clinical specialties
I think your mic's gone off. I think your microphone's gone off, Brit.
It times me out, does it? Okay. One of the, I'll start that bit again. One of the issues is bringing consultants and medical staff and clinical staff as a whole together. And so we run on principles of teams and multidisciplinary teams. We shy away from isolated or only a small number of consultants working together because that can breed unhealthy practice. There is I quite like a bit of variation in how people see the world because you can get different solutions. But equally clearly, if you're on your own, you're not hearing anybody else's views, and your variation may well be dangerous. And therefore, the idea that we spread the workforce thinly in an attempt to maintain it works directly against the ability to consultants to work collegiately to deliver the best possible care. So, you know, I as a vascular surgeon, I'm pretty experienced in some things, less experienced in others, and I've got a colleague I can say, what do you think of this? I haven't seen this one before, and you saw one last week. And so there is the semblance of excellence not being about a building, it's about bringing people together. And if we're very short of people, then the number of places that we can bring people together gets very small.
Okay, thank you. And my next question was just going to be, you nicely touched on workforce issues there. So there's note of various workforce issues in the report. In terms of consultant psychiatrists, we've got the accessing the Scottish Government recruitment campaign and also through the Scottish Government contacting other boards to recruit. If it were a normal, well, I mean, it is a normal medical service, but if there were a sudden urgent shortage in I don't know, like an intensive care unit needing a nurse, then we would be able to contact one of the neighbouring NHS boards to potentially provide cover for that. Have we spoken to the other NHS boards directly about providing cover rather than about recruitment issues?
What you're describing is the principle of mutual aid. It's a big red button that you can press and say, we need help. And so that red button was pressed by Grant Archibald beginning of this month, and we went to Scottish Government and we had a chat with their principal medical officer, a chap called John Mitchell. We got round the table with a number of senior clinicians from elsewhere to see what assistance we can get, but as has been pointed out a number of times, the number of consultant psychiatrists vacancies in Scotland is quite high. And as a result, nobody has actually come forward and say, here, you can have Johnny, he's free on a Tuesday. So we have not received any medical clinical support by pressing that big red button.
Okay, thank you. Mrs. Zoll, you wanted to come in on that point?
Yeah, I'm sure you
probably have, but I've wondered about the use of technology, video conferencing and telehealth to bring in support from other areas.
We're about, hopefully, to appoint a director of e-health and try and bring technology more and more across NHS Tayside as a way of keeping people at home, both in terms of giving advice, asking questions, but obviously you have to have an infrastructure for that, and our IT infrastructure probably isn't up to it at the moment, but that is a huge agenda item for us, because we see it as a way forward to address issues not just in mental health but across a number of specialties. So although mental health is, number one, there are number 2s, 3s and 4s.
And Ms Kilpatrick, you wanted to come in too?
I mean, everything that Peter says is absolutely true, and it's been discussed at length at the board at NHS Tayside. It's not, I mean, this is all about, we're talking about mental health and we're talking about psychiatry vacancies, and it's, as Peter's already said, it's not a Tayside problem, it's not a Scotland problem, it's a UK problem. And another interesting thing, because we're talking about Bridge of Erne later on in the agenda today, is 46% of qualified doctors who do their foundation years 1 and 2 do not go on to specialist training. And that's the real issue here, is in the past, they graduated, they did their FY1, their FY2, and they went on to do specialist training. Some would have gone into psychiatry, some would have gone to A&E, orthopaedics, paediatrics, whatever. 46% of those now are choosing not to do that. And that's the real issue. It's not just a psychiatry issue, it's a manpower issue. We are a doctor short organisation. We are not attracting young doctors to stay on and do specialist training, and that's just as true in general practice. We are not making it attractive for people. They don't want to do it. We lose a large chunk of people to New Zealand and Australia who pay more money. It's a better work-life balance in fewer hours. So you have to just see the whole thing in context.
Okay, can I add to that?
Yep, Professor Stonebridge.
Okay, I mean, I suppose this is me whining slightly. There is this issue that they're not going on to training, but there's also the issue that the work-life balance for doctors has changed. And so we had a conversation yesterday about the number of general practitioners who are part-time, and it's a large number. And therefore, when you train a doctor, let's say you get a doctor equals 100, at the end of the time you get 46% going into specialist training, and out of that 46%, another 50% will probably go part-time. And therefore it's a matter of how do we get people to be here, which brings us back to where we very started. It's the quality of our training. If we make this the place to train across the board, come to Tayside, learn how to be then that is the way we generate a workforce. And that's why, to me, the issue about the trainees is absolutely fundamental to this issue. If we can create the perfect training environment with, they're almost supernumerary, because that's the way they see themselves, and they can train and think, this was a really good place, I'd like to stay here, but also I will encourage other people to come here. And we're in enhanced monitoring. Nobody applies to a place in enhanced monitoring. We've got to get out of enhanced monitoring, desperately. We had this situation in surgery, and we turned it round in a year, which is a record. We have to make us a training excellence in mental health. And that's why the trainees and supporting, supervising, and unfortunately reducing the footprint so they can be supervised is absolutely vital, both for tomorrow and for 10 years' time.
Okay, thank you. And my last question was just on, we'd heard about, again, on workforce issues, we'd heard about how some of the staff were very keen to advance the moves and see their patients within the new environments. And I just wanted to check whether there were any staff concerns about any of the moves and moving to other locations, because I know that there have to be are they called transition arrangements and then potentially other things. But I just wanted to know whether there were staff concerns about any of these moves as well, Chief Officer.
Yeah, so I think we need to be absolutely clear about the ways in which we are and committed to engage with staff to ensure that we are sensitive to the impact that the redesign programme is having on them and recognising their personal circumstances and you know, that in no way cuts across the fact that, you know, staff are highly committed to providing support to patients. But we need to be sensitive to the fact that the journey from Perth to Dundee or vice versa, or the relocation of a workplace, has a significant impact on people. We are committed and need to do much more work in relation to engaging with staff, ensuring that they are aware of any proposals or changes as soon as we are aware that they might need to be made, that we are compliant with the staff governance standards, that we are engaging effectively with staff side, because it is only through continuing to benefit from the commitment and goodwill of staff that we will be able to get further down this road and complete this journey together.
Okay, we've been at that for, a question. Yep.
Not necessarily a question, just a reflection and an observation. I think the conversation that I've heard this morning is very similar conversations that are happening across many services, across health and social care. And just building on the points that have already been made, I think what I'm hearing today in terms of particularly the nursing workforce, there has been investment in the nursing workforce across inpatient mental health, and the programme I think that Keith has been able to share with us, I think shows a positive move towards trying to recruit new staff, maintain new staff, but also invest in developing new roles as well to support the new ways of working.
Okay, thank you. We have been discussing that paper and answering the questions. I think we've had a good coming up for an hour and a half on it. With that in mind, there are no further questions.
Chair, I have a comment, if I may.
Councillor Joystick.
Thank you. Of the things, it's been a very, very interesting discussion, an hour and a half's discussion today. Of the things I've learned today, the most alarming thing I've learned today is a simple thing. It's that while Dr. Strang received and he did 1,300 contributions, over 1,300 contributions, he did not take the time to speak to the new chief officer in the 6 weeks or so before his report was published. That was a concern to me, and I don't know if also if there was any conversation with the chief executives of the parent bodies at that time either. As I say, I'm astonished about that. I'm absolutely gobsmacked that he hasn't stayed to listen to this conversation today and to form a fuller picture of why we are in this situation and what we're trying to do about it. And so I'm not sure that I would have a lot of confidence, unless of course he watches it all on YouTube. I'm not sure I would have a lot of confidence in there being a balanced final recommendation.
Ms. Reid.
Thank you, Chair. Just very briefly, I was not interviewed or had the opportunity to discuss the interim report by Dr. Strang prior to it being published, just for clarity.
Okay. I'm conscious though that the Chief Executive and Chair of NHS Tayside, who are, after all, delivering that service and in operational manners, they did have that opportunity. Okay, moving on then. We've had, as I say, a good hour and a half answering questions or asking and answering questions on that report. Do I have any? We've got a number of recommendations outlined on the front page there. Do I have any motions or amendments?
Chair, I'd like to make a motion if that's possible.
Dade.
Yeah, thank you. I've been on the board now for 2.5 years and have seen this process from pre-consultation, pre-public consultation, through the public consultation where I went out and advocated at public meetings for people to get involved in the consultation, explained what the proposals were, and particularly, in fact, I not just explained the proposals, but I actually went out and advocated for them following the visit of the mental health sites across Tayside, because I was so appalled by the conditions in some of them. However, from my point of view, a lot has moved on in the last 21 months. A lot of new things have happened, and we've had quite slow progress in some respects on the plan that was approved. And it was approved on the basis of a number of reassurances, and I hope that those reassurances will still be borne out. But I would quite like to see a temporary pause, and a very short pause, I think, where we can actually do a full strategic plan on mental health services, as Dr. Strang has recommended, which would allow us to not put the cart before the horse, as it were, and actually say this is the number of beds we're going to need. And it may actually be, you know, even less potentially if we invest in the community services. And I think, you know, I've heard a lot of consensus views around the table this morning about we all believe there needs to be a huge investment in the community side, and we want to reduce the amount of crisis care and inpatient services that are required as a result. I think it is unfortunate, and you know, Councillor Drysdale's already mentioned, it is unfortunate that you know, the Chief Officer wasn't consulted prior to the publication of the report, but 1,300 people, including NHS Tayside staff, members of the public, service users, carers, etc., did respond to the consultation, did input evidence. Dr. Strang has been supported by medical experts and himself has a very strong record as a professional investigator. And I think if you establish a public inquiry, which is effectively what this is, it's an independent inquiry, but it's funded through the public purse, it's calling for public evidence to come forward, you are really almost contractually bound to carry forward recommendations that come out of it. I think the fact there is only one recommendation in the interim report says that we should really take cognizance of it. But as I say, I don't think we should allow that to hold up everything. I think we should do it as a matter of urgency. I think we can turn this around. I'm very pleased to hear that the surgery issues were turned around in such a short space of time. That gives me confidence and assurance, which is what, you know, I am looking for today. Because to be honest, 21 months later, I have a serious lack of confidence and assurance about this. And I think, from my point of view, the operational aspect, absolutely, I fully expect that we will need to go into emergency measures, and that is entirely appropriate, and that is a professional decision for the expert staff to make. But that doesn't mean that the board has to say this is our strategic view. That is an operational matter, and that is something that needs to be done for clinical safety. That is not a matter that we as a board take as a matter for the professional staff. But I think as a board, we have responsibility to say we are listening to the independent inquiry, we are listening to the views of the public who have inputted to that independent inquiry. We're going to consider them. It doesn't mean we're going to agree with them, but I think we need to take that pause to allow us to do that, so that we have that public credibility that we are listening to it, because there were a lot of concerns for those who weren't sitting around the table, which is most people at the time in January 2018. There were a lot of concerns about the public consultation at that point, and you know, we did decide that clinical safety at that point was the overriding concern, and we made that decision on that basis. but we are now 21 months down the line and the clinical safety issues still exist. So, you know, I think that if emergency measures need to be taken, they need to be taken. But I don't think that actually the board has to say, this is now our long-term plan. It may well be, but I think that we need to just take that pause as recommended. You know, Dr. Strang's been advised by medical experts as well, so I don't think he would have put it in his report had he not thought that it was an appropriate thing to do. So as I say, I think there needs to be a look at how we are going to do a full transformation that focuses on community, and I think that that'll have to be linked to organisational change. I appreciate there are an awful lot of changes going on at NHS Tayside. However, perhaps this is absolutely the right time to do that. And I think it's important that the staff and the service users feel that they are being listened to and consulted as part of that. I think that's really important. So I would quite like, I'll read the terms of what I'm proposing, but I would stress that from my point of view, it's very much a short pause. It is not a long, we don't take 6 months, 12 months. It is a short pause to allow us to consider how best to go forward in terms of actually doing a full transformation programme that will deliver long-term benefits. Because I agree absolutely with Ms Kilpatrick's comments about I've got several cousins who are doctors, and they really even struggle to get, you know, placements, etc. And huge numbers of their compatriots are now in Australia and New Zealand. So we do have to be cognizant of the national picture, but actually a few months will not make a difference for us. I think a few months will allow us to make the right decision, and that in terms of the long-term picture improving is more important, and that will be better for recruitment in the long term. Would you like me to read the terms of the motion?
Please.
Yeah, okay. The terms of the motion are that the Perth and Kinross Integration Joint Board note the significant clinical and operational risks that the services are currently experiencing and the impact on patient safety and quality of care, but consider that many of these remain regardless of the progression of the redesign. Further note significant delays to parts of the redesign programme that have resulted in measures that were previously suggested to be critical not being fully implemented 21 months after the programme was first agreed. Consider the fact that a recommendation has been made by the Independent Inquiry into Mental Health Services in Tayside in its interim report in advance of the final report to be significant. Agree that there is a clear case for a comprehensive review of the mental health strategy rather than simply undertaking a move of beds and sites in order to ensure that the permanent changes are not made prematurely, and that's an quote there. Therefore, does not endorse the continued implementation of the mental health redesign at this time, and instead agree that the redesign programme be paused until such time as the review of mental health strategy has been completed. Agree that the review should not be led by the NHS Tayside Mental Health Alliance, any Tayside IGB, NHS Tayside or Tayside Council, but should be led by an independent individual or organisation agreed by the IGB, and agree that this independent review should focus on the existing and required community mental health infrastructure across Tayside before determining any requirements for and changes to beds and sites. Agree that the pause does not prevent any necessary temporary actions to ensure inpatient requirements are met and environmental improvements, including anti-ligature measures, should continue to be undertaken meantime, and instructs the Chief Officer to instruct any necessary directions to NHS Tayside to give effect to this motion, and asks him to report back to the IGB with progress on the establishment of an independent review at the earliest opportunity. And as I said earlier, I don't see anything in this that particularly goes against what has been expressed around the table today. I think we're all very much, you know, wanting to see the best results, and are concerned about actually ensuring we have a strong service going forward. So I hope that there will be consensus around this issue.
Okay, thank you. Have you got a copy?
Copies, yes.
Who can go and grab them? Or do we need it seconded first?
Chair, I wonder.
Yeah, okay, sorry.
I didn't understand any of that, to be honest with you. I really can't hear it. We need a break.
Sorry, yeah, okay. have we got a formal seconder?
Well, yes, but I think that the copies should be circulated.
Okay, well, what I'm going to suggest then is, if we've got a motion and a formal seconder, that while the copies are circulated, we take a recess. What I'm wondering, given that everybody will be getting vaguely hungry, is whether we take hang on a sec.
Chair, I'm not sure this would be the appropriate time to take a lunch recess.
No, that's fine. Okay, you're absolutely right. The clerk agrees with you, and I agree with the clerk. So we won't have the lunch recess now. We will have a short 5-minute recess so the copies can be circulated and everybody can take a break. But please tend to be back, because we need to conclude the discussion on this issue and then move on with the rest of the agenda.
Chair, can I ask, are you not formally required to submit a motion in advance?
No.
I'm surprised by that.
Not as per the standing orders. Okay, so recess is called. Welcome back, everybody. So thank you for your indulgence with the slightly longer recess than I had indicated. But I think everybody, given that I can see one cheese sandwich left, I think everybody's at least taken the opportunity to become, I hope, a little less hangry over the, as the Chief Executive of the Council put it, over the recess there. Now, in the meantime, Councillor McDade has, and Councillor Purvis have taken advice on the text of their motion from officers. We're getting committee services are bringing in a revised text of the motion, but Councillor McDade, if you wanted to read it out. Oh, it's just coming. So just off mic there, somebody's asking.
I'm asking, yeah, sorry.
Yeah,
I'm switched on. I'm just asking what happened to this motion? Why we got a revised motion?
So I think I'd explained that Councillor McDade had taken out advice from officers, but I'll leave it up to him now that you've got that in front of you.
Excuse me, I didn't get one. No, that's the standing orders. Okay.
Yes, thank you, Vice Chair. Following discussions with officers, I'm quite happy to propose the revised text that is now in front of members. It incorporates the key points of what I wanted to get across, but also officers are content with the text, that it doesn't prevent them from taking actions as required. So it is in front of people, but I will read it out just for the record. The Perth and Kinross IGB are asked to consider the content of this report and provide constructive comment. Note the significant clinical and operational risks that the services are currently experiencing and the impact on patient safety.
Sorry, Chair, can I possibly ask that Councillor McDade read that out rather more slowly so that members of the public and press can perhaps pick up what he's saying? Thank you.
Hopefully there's enough copies for them, but I will read it slower. Note the significant clinical and operational risks that the services are currently experiencing and the impact on patient safety and quality of care. Agree our full commitment to a full review of end-to-end mental health services across Tayside and endorse our participation in such a review. Agree the continued implementation of the approved mental health MHLD SRP for short, to secure current patient safety and quality of care insofar as the implementation of any change does not prejudice the outcome of such a holistic transformation of mental health services. Ask the Chief Officer to prepare a revised programme plan with key milestones and timeline. Commit the Chief Officer to provide regular reports on the progress, risk and delivery of the MHLD SRP, and commit the Tayside Mental Health Alliance to provide regular update reports on their ongoing work to support the IJB in shaping their strategic outcomes for the service.
Okay, thank you. And Councillor Purvis, you're content with those changes to the motion?
Yes, I'm happy to agree under Standing Order 14.9 to the revised motion. Do you want me to formally second it?
If you would formally second it?
Yes, I think we do need to. I appreciate the strongly held views on all sides of this debate, but given the interim report from the independent inquiry into mental health services in Tayside. Councillor McDade talked about being contractually bound. Well, of course, that isn't the case, and we don't have to follow necessarily any recommendations. I think we are morally bound to follow recommendations. The report into mental health services in Tayside was pretty damning, as people have indicated. While there is a lot of good work that is being undertaken, and any criticisms does not preclude recognising that fact, I think that the whole process of this redesign programme has been the wrong way round, and I think even some of the people involved with it would recognise that now. The logical way to go about this, if we're talking about shifting the balance of care to the community from acute settings, is to first look at the infrastructure in the community that already exists, and the infrastructure that is necessary in advance of any decisions about beds and sites. And as I think Councillor McDade said earlier, it's putting the cart before the horse to do it the other way around. But obviously that was not the approach that was taken. However, I think it is important that we do commit to undertaking a full review of end-to-end mental health services. And while the Mental Health Alliance is doing some work on this, as David Strang indicated earlier on, he has not seen a formal commitment from Perth and Kinross Integration Joint Board, which obviously has responsibility for the whole of Tayside for inpatient mental health services, a formal commitment to such a review. So I'm glad to see that this motion includes a formal commitment to such a review. And while having had the discussions with officers around competency, but also not just that, listening to some of the concerns of other members for whom perhaps a pause was too far, I think this strikes an appropriate balance of agreeing the implementation of the approved programme to secure the current patient safety and quality of care, but insofar as it does not prejudice the outcome of such a holistic transformation review. And I think that is a crucial point, because we shouldn't prejudice any reviews, as I was discussing earlier on. So given that I think that this is something perhaps around which we're more likely to reach a consensus, we are taking into account, if we are to agree this motion, the recommendation by David Strang, but perhaps, while it doesn't go as far as perhaps Councillor...
And that's the motion that I would be putting forward. And the reason for that is, and the reason why I can't agree to what Councillor McDade has put forward today, is we've actually had 4 reviews. I think you can keep me right here, Keith. We've had 4 reviews in mental health, and in fact the board have just commissioned another. The mental health services have been reviewed by 4 different bodies over the last 18 months to 2 years. In addition to that, the board have just commissioned the Royal College of General Practitioners to come in and do a review of mental health governance. So we've got review exhaustion, and I feel that my job as a board member, I'm here to represent the patients, the public and the population of NHS Tayside. And my view is that we have to put patients at the heart of this. We have to allow our senior officers to get on with the job in hand. A review is something that we've already done. We've done reviews. David Strang has still got to report on the final review. And there is a perception amongst the public, when you talk to people, that actually we don't know what to do, so guess what, let's have a review. Now, we've had several reviews. We know what we need to be doing. Gordon's telling me today that we've got a plan for local mental health, community mental health and wellbeing for Perth and Kinross, which I wasn't aware of, which I think is excellent. We've got that bit of the jigsaw. Maybe councillors need to sit down and understand the end-to-end mental health pathway, and I'm sure the mental health team and Peter and Gordon and others can do that. But I see absolutely no benefit in going back and reviewing anything else. We have a blueprint, we have a strategy, we know what we're doing, we need to get on with it. It is our responsibility to the people of Tayside, to patients who need our services, to be able to start to move forward. And my worry about a review is that nothing happens when you're having a review. And that's my concern. So my motion is to accept Gordon Patterson's recommendations in full.
Okay.
And I would like that, that needs to be seconded.
Chair,
Thank
could
you.
I first make a point of clarification? There's a number of things that Mrs Kilpatrick has said, and perhaps the change to the original motion has confused that somewhat, and we apologise for that. But Mrs Kilpatrick said that nothing would happen while a review was taking place. That's not the case of in the revised motion. So just to clarify that it does say that any necessary things would continue to happen in order to ensure patient safety and quality of care. And just on a point of order, I don't particularly appreciate the suggestion that councillors need to sit down to understand the process. I find that quite offensive and would ask if Mrs Kilpatrick would retract that remark.
I think everybody has to, and I include myself in this, I have learned so much about mental health services from talking to the mental health team, from talking to people about what's being provided, how it's being provided, where it's being provided, and all the useful work that's going on. So it's not intended to be an offensive remark. I think if you and anybody around the table, and I include myself in this, doesn't understand end-to-end services, then there are experts in the room who do understand end-to-end services, and the only way we as a board can understand the whole thing is if we talk to people.
Yeah. Okay. If everybody can take their seats.
Can I speak, Chairman? In relation to the motion which Councillor McDade's put forward, I would like to propose a change in the wording, which is that at bullet point 3 it would say agree our full commitment. And I don't like the use of the word review, because in the NHS a review means a very specific thing to us. So agree our full commitment to the ongoing transformation of end-to-end mental health services across Tayside. So it's agree our full commitment and endorse our participation in the ongoing transformation of end-to-end mental health services across Tayside.
So just to be clear, you're withdrawing your previous amendment and now suggesting an amendment in the terms that you've just stated to Councillor McDade's motion.
I'm trying to find some middle ground so that it allows us to go forward.
Vice Chair, I'm quite happy to incorporate that into my motion in the spirit of trying to find consensus around the table.
Okay, thank you.
I'm also happy to accede to that.
Chair, if I may, at the risk of prolonging things just a few seconds longer, I would like to propose a further slight modification of the motion. I'm not sure that Mr Patterson will be too pleased with me, but in terms of the frequency of reports, we use the word regular. I'd like to be more specific in the final 2 bullet points and ask for updates on the final 2 points to be standing items on each future IJB meeting.
I'm likewise happy to accede to Councillor Drysdale's proposals for incorporation.
Councillor Purvis.
Sorry, I'm having my lunch. I'm happy to accede to those changes also.
Okay, Clark, do you need Mrs Kilpatrick just to clarify the wording there?
Apologies, if you could just clarify, what I picked up was in changing the 3rd bullet point was that you said that it was agree our full commitment and endorse our participation in end-to-end, was it transformation?
Yes, agree our full commitment and endorse our participation in ongoing end-to-end, endorse our participation in ongoing transformation of end-to-end mental health services across Tayside.
Thanks.
Okay, are there any other amendments to Councillor McDade's motion? Would anybody like to...
Eric's amendments to the last 2 bullet points.
That's, yes, so Mrs Kilpatrick's and Councillor Drysdale's amendments have both been included by Councillor McDade and Councillor Purvis in their motion. Are there any other amendments to the motion as it stands now? No. Are there any comments that anybody would like to make before I draw this item on the agenda to a close? Mr Benson.
I just want to say is that I'm not terribly happy about this process of making decisions. I've not had full consideration of all the implications of this. I've had no officer input into what these might mean in effect. So there could be implications of this that we're not aware of. So I'm just registering my dissent.
Clerk to the board.
If I could just make a comment, Chair, in relation to that, my advice is that the decision that's been made today has been fully met in line with standing orders. And just a further comment in relation to your comment about officer input within the recess. There was input from officers into the competency of any motions and amendments.
Thank you, Clerk. Mrs Summers, did you want to come in? Yes. Do you use your microphone?
Could you clarify which part of the longer motion has been changed then? Is it every time that review is mentioned?
I will
or-
do. So that everything in that longer motion has been replaced by the second piece of the second one that was
So
circulated.
we don't have two motions. This is the
So-
one we're looking at.
Yep.
Right.
So the
okay.
first one was
Right.
withdrawn and then replaced by the text in the
Second
second one, and that's been amended since
Yes.
by
Yes.
the wording that we've heard. Okay.
Yep.
Have I got any other comments before I draw this? No. Okay. So the motion put forward by Councillor McDade, seconded by Councillor Purvis, and with the noted amendments that have been read out, becomes the resolution of this board with no need for a vote. Thank you very much. Okay. The next item on the agenda, we have two more items on mental health. However, I need to advance us, with the board's permission, to item 4 on the agenda, which is the 4.2, which is the annual accounts, because we have to sign these and send them off this afternoon by courier to the auditors. So unless there are any objections to changing the order of business, I will therefore ask the Chief Financial Officer to introduce the report, introduce the annual accounts for 2018-19.
Thank you, Chair. The unaudited annual accounts for 18-19 were approved by the IGB at its meeting on the 26th of June, and these were submitted to Audit Scotland. The external audit by KPMG has taken place between July and August, and on 16th of September, the Audit Performance Committee received the final accounts along with KPMG's annual external audit report, which provided an unqualified opinion on the 18-19 financial statements. A number of key messages were highlighted in the report, which are set out in the covering paper, and 3 key recommendations have been made by KPMG, all of which have been accepted by management. Those recommendations relate to the approval of all parts of the budget by the 31st of March. They relate to a recommendation that the Chief Officer takes forward with both parent bodies the need to agree financial risk-sharing arrangements, and a recommendation that the Chief Officer address key gaps to provide appropriate strategic planning capacity for the partnership. Just before finishing, I would like to thank my finance team who've worked extremely hard to prepare the accounts and to support external audit over July and August, and to Donna Mitchell in particular for that. I'd like to thank the design team of Perth and Kinross Council, who have, I hope you would agree, provided a document which will, much more than it did last year, be accessible to our public. And to our external auditors who've worked hard with us to very tight deadlines, and who are currently waiting in their office in Edinburgh to receive these accounts, so we're grateful to them. On that note, I'm happy to take any questions.
Are there any questions on the annual accounts for 2018-19? No questions. Okay.
Maureen's got a question.
In the conclusion there,
Maureen,
where you're saying
Summers.
it's almost wholly driven by medical locum costs, are you?
Which paper is she on? Different paper?
I think that's maybe not the accounts
This is
paper,
the paper
but
that Jane had written here, no?
I think that's maybe the financial recovery paper that you're looking at.
We're on the annual accounts paper, Maureen. Paper 4.2.
I thought we're looking at the budget for the mental health.
No.
No.
Oh, sorry, we had to just amend the agenda there.
I'll just leave it then, because I was looking at the wrong paper. Just carry on.
I can't make that out. What was he saying? Don't know. Okay, right. If there are no other questions on the accounts, then I'm happy to formally move the recommendations in the report, the covering report, which are to note that the Audit and Performance Committee have considered the audited annual accounts, the letter of representation and KPMG's annual audit report at its meeting on 16th of September 2019. That we've considered the contents of KPMG's annual audit report to members of Perth and Kinross IJB and the Controller of Audit on the 2018-19 audit, and that we should approve the audited annual accounts for 2018-19 and approve the letter of representation for signature by the Chief Financial Officer. Do I have a seconder for that?
That's what I was trying to say to you, Councillor Stewart.
Apologies.
I'm happy to second the recommendations in the paper. First, I'd like to echo the comments made by the Chief Financial Officer in terms of thanking officers for their hard work in bringing these together, and to echo the comments made about the formatting of the accounts themselves. It's a very readable and a significant improvement on previous years, so that's very much appreciated and welcome. Although there haven't been many questions today, I think it is important to stress that this has already, both in its unaudited and audited form, come to the Audit and Performance Committee and been subject to significant levels of scrutiny at those committee meetings, which resulted in our being able to recommend these accounts in their audited form to the Integration Joint Board itself for approval today. I would also like to echo some of the comments that are made in the external audit report in terms of ensuring that we try to get the full budget set by the end of the 31st of March for the forthcoming financial year. I'm sure that's something that we all want to strive to achieve. We made significant improvements last year in setting a 3-year financial plan for the core health and care services, and while we have taken various bits of the budget, hosted services later on, I do hope that we can get to a position where we can look at things holistically, which will obviously help with the principles of integration that we are all here to achieve. So with that, and on the basis of the comments and questions that happened at the Audit and Performance Committee, I'm happy to second this, and the Audit and Performance Committee was happy to endorse the accounts.
Okay, thank you, Councillor Purvis. Are there any other comments? No. Can we agree the recommendations in the report then? Thank you very much. I'm now going to declare another small recess. Apologies for this, but I need to go and on behalf of the IJB sign the accounts so that they can be shipped off. So when I return, we'll resume. Please don't go very far, anybody. Thank you very much. Okay, thank you for your indulgence. Apologies for having to have another recess, but as I said, the accounts did need to be shipped off today. We'll now go back to item 3.3 on the agenda, verbal update from the Chief Officer on the Mental Health Alliance, and particularly if you could reflect on any of the comments about the Alliance during the earlier discussions that we've had today, Chief Officer.
Okay, thanks very much. I shall try to keep this brief. I've taken some excerpts from the Memorandum of Understanding that the Alliance have developed in relation to its work going forward, but I want to speak around that and say something about what implications it might have for our work as for the work of the IJB. Just by way of background, the Tayside Mental Health Alliance has been formed. It includes representation from the 3 health and social care partnerships and from NHS Tayside, as well as we had indicated earlier, it has some representation from staff side, third sector and advocacy. The Alliance is seen to be acting as a key enabler for NHS Tayside and the 3 health and social care partnerships. Its terms of reference acknowledge that mental health is delivered by many agencies, and the Alliance needs to bring together those agencies and distinct organisations that hold responsibility for the planning, commissioning and delivery of mental health and social care services across Tayside. As I said earlier, the aim is to work collaboratively with partners to understand the full Tayside landscape and the associated challenges, working together to deliver a whole system 3-year strategy for mental health care and treatment. The health and social care standards will be core to the work of the Mental Health Alliance and will help drive improvement, promote flexibility, encourage innovation in how people are supported and cared for. We in Perth and Kinross Health and Social Care Partnership are enthusiastic and excited about the prospect and potential that the Mental Health Alliance brings to working collaboratively, to learning from each other, to improving service delivery and to mapping out patient pathways and highlighting opportunities for improvement. The primary purpose of the Alliance is to bring together each of those distinct organisations that holds responsibility for planning, commissioning and delivery of mental health services, bringing them together in order to better understand the full Tayside landscape and its associated challenges. The Alliance aims to work together to develop a whole system 3-year strategy for mental health, wellbeing, care and treatment to ensure the delivery of consistent, safe, recovery-focused, evidence-based models of care. However, the Alliance, it is important to acknowledge, recognises that the 3 integration authorities should work alongside NHS board, councils and community planning partners, and the IJBs have responsibility for planning, delivery of care for individuals and their communities. The terms of reference says that the IJB has full power to determine use of resources and how delegated services will be delivered, reflecting this in their strategic plans. So we, within the Perth and Kinross Health and Social Care Partnership, are committed to membership of, to working with and to supporting the Mental Health Alliance. But we recognise that we need to bring the Memorandum of Understanding for the Mental Health Alliance to the IJB to seek formal approval. We intend to do that at the next meeting. We haven't done so today because of representations I have received that query whether or not the MOU, the Memorandum of Understanding, is currently framed in a way that recognises the role, authority and responsibility of IJBs for decision-making around strategic planning and commissioning of mental health services. I think it broadly does, and I've spoken to other chief officers who are content with how it's written. Their IJB has given delegated authority to the lead officers for mental health services to participate in the work of the Mental Health Alliance. A similar approach taken in Dundee. Of course, those officers will report back to their IJBs and will recognise that some decisions are not for officers and will require formal consideration by the IJBs. I would propose to look at some slight refinements to the Memorandum of Understanding in light of the representations that I have received to then bring this back to the next IJB with a fuller report and to seek approval for us to be part of the Alliance.
Thank you, Chief Officer. Any questions regarding the Mental Health Alliance?
If I may, Chair.
Mr. Benson.
One of the things that people have said to me about the Alliance is they have this perception, whether true or not, that it's kind of stuff with professionals. And I wondered if you could comment on that. I think one of the issues was that they were particularly keen to get the service user experience involved in prospective involved in this, not least through issues around co-production of what may emerge out of the alliance as well. And I would like your thoughts on that. And what progress is there on the draft terms of reference for the group as well?
So the terms of reference are have been approved by other IJBs, and in light of the representations that I've alluded to, that I think we need to perhaps make some comment on it in order to ensure that it absolutely captures the roles, responsibilities of the IJB, the authority that this IJB has and the others do. I think your question about engaging and involving stakeholders is key. I think we perhaps covered some of that in an earlier response to a question in the previous paper. Ms Wood has identified that what we need to do is to not necessarily replicate the existing measures and mechanisms that are in place for the local health and social care partnerships, to engage with the third sector, the independent sector, with service users and carers that they're already doing in the context of delivering and developing their own local community mental health strategy. But we will need to think about, if the Alliance is bringing forward proposals and is seeking the views of the third and independent sector, that those are embedded in the work going forward, and that we make sure that there are mechanisms for us to address that. I don't know if Arlene would want to say anything more.
Thank you, Gordon. As Gordon says, the Mental Health Alliance is really in place to support integration joint boards and to enable a conversation, a Tayside-wide conversation. And much of what we've heard and discussed today around understanding the whole system and having a forum where the leads for mental health services can come together right across the pathway and have dialogue together and work back within the health and social care partnerships through all the stakeholder structures that are there. So at the moment there is third sector representation. We have Chief Social Work Officer representation, leads from mental health across CAM, psychological therapies, 3 health and social care partnerships and a number of others. And there's quite a big stakeholder map underway, and each of the leads, and in Perth and Kinross, that's Diane and Evelyn, have been linking back into all of the stakeholder groups to establish how they wish to connect, and whether that be through their representative, or whether that be through a person on the group. So that works to be complete, and then that will allow us to just finish the memorandum of understanding and describe how that communication, participation and engagement will occur. I think what's important is that the Mental Health Alliance will support a number of design groups, and on the design groups is really where we need to have the stakeholder and service user voice. And we've recently, via NHS Tayside, we have a programme director, programme manager dedicated now to the Mental Health Alliance, and they're currently pulling together some of the emerging priorities, which are very much similar to some of the things discussed today around end-to-end pathways for crisis care, community mental health. But really important, it does not replace the mental health strategies that are in place across the 3 localities, Dundee, Angus and Perth and Kinross.
Mrs Summers.
Before this comes to the next IJB meeting, will you have enhanced membership of the Mental Health Alliance? And that means, you know, service user and carer representatives, and I don't know if third sector are there already or not, but certainly if they're not there already, they should be there too. And as regards, you know, as regards, you know, whether a group should feed in, I think that there should be an actual carer and service user representative sitting around the table so they can be part of any discussions or our ongoing, deliberations on the group. They can then liaise with a wider group of carers and service users, but there should be somebody sitting round the table at the Alliance for each of these groups.
Councillor Purvis?
Was that a question?
I thought you wanted to come in.
I want to know. I want to make a comment, but I'll wait until
okay.
the questions are
Right.
finished.
Okay, that's fine. Sorry, my misunderstanding. Somebody want to address that issue that's just been raised?
So I think that's essentially what Arlene answered in relation to how that would work through, but certainly it doesn't exclude the potential for us to have nominations from the local groups who could come and be part of that Tayside-wide group. I don't know, Keith, if you wanted to add to that.
Just to reinforce that, it's a question that we've asked the Health and Social Care Partnerships. It's a question from the Alliance collectively. How would you like your local stakeholders represented in the Alliance?
Okay, any other questions? Yes, Mrs. Watts.
Thank you, Chair. The Third Sector Forum had quite significant concerns about the Alliance because, if nothing else, we were confused about the membership and who was likely to be on the Alliance. I understand the point about not duplicating groups and forums that were already in existence, but as key partners in the delivery of mental health services in the community, we felt that the third sector should have a strong presence on the Alliance, and that is absolutely crucial for effective design of services.
Somebody want to take that up as a question?
We would agree. We would agree with that, and the membership reflects third sector engagement in the membership, and there's an identified person from the Third Sector Integration Joint Board representative from Perth and Kinross as a key member of the Alliance.
Does anybody want to come? Do you want to come back in?
I think that's partly what the confusion is, because it wasn't at all clear to us why that member was actually on the Alliance and whether it was in her capacity as an IJB member or in her capacity from her day-to-day work in the Independent Advocacy Service.
Where the Alliance, our view would be that we would be looking for someone to represent third sector partners in the Alliance and be able to do that from a Perth and Kinross perspective.
Chief Officer?
So I think this is part of a wider issue that we need to look at, and I've given a commitment to seek to address. It's not unrelated to one of the issues that comes up later on when we begin to discuss the joint inspection of the Health and Social Care Partnership. And essentially it's my view that we need to refresh and review and reinvigorate the work of a number of bodies that support us to ensure that service users and carers' views are adequately represented in our strategic planning activity and our delivery. I've given a commitment to look again at the membership of the strategic planning group to give it a greater strength of voice, to enhance the membership and to look at how it can support the work of the partnership. Beyond that, I need to have some conversations about our third sector interface and how effectively that supports us. But in terms of the third sector forum, I am meeting with members of the forum and have given a very strong commitment that I see it as essential in shaping the delivery of services moving forward. I want it to have a more active and supported voice, and I think that provides a platform for us to think about how that will feed into the delivery of local plans and the contribution that they make into the Tayside-wide Mental Health Alliance. So I'll give a commitment that we'll look at that and look to bring that forward. And the officers that I have on the Alliance are Evelyn Devine and Diane Fraser. So they'll feed that in and we'll look at making sure that there's adequate representation.
Okay, so I'd like to reflect myself on something which is that NHS Tayside Board has had courtesy of having version 2, the draft version 2 of the Mental Health Alliance in terms of reference and memorandum of understanding circulated, but members of this integration joint board haven't. I think it would be advantageous to circulate it in advance of bringing something back for agreement at the next IJB meeting, because if there's something that we're not content with at the next IJB meeting, it would then perpetuate and kick the can further down the road. I think it would be good to get this circulated so that members can input at the earliest opportunity. Some of the concerns I have regarding the wording here, acknowledging that mental health is delivered by many agencies, this will bring together each of the distinct organisations that hold responsibility for planning, commissioning and delivery of mental health and social care services for Tayside. I think reflecting on some of the concerns that we've heard today, if each of the distinct organisations is to be brought together into the Mental Health Alliance, then it seems that there may be, currently at least, some gaps identified. In terms of responsibility, there is a very clear statement very early on in the document that the Tayside Mental Health Alliance is a formal, strategic and decision-making alliance established between the four parties. But I think that that potentially conflicts with the right and responsibility of the different IJBs, boards and councils to make decisions within their own strategic remits, particularly, for example, in the case of this integration joint board, our hosted service of inpatient mental health. It's not appropriate that we don't get input into a discussion about how much and to what extent we are delegating any strategic or decision-making power to the Mental Health Alliance. And specifically, given that the question, as I said earlier in the meeting, was asked at the May's meeting of this IJB about whether the membership rules and responsibility, the membership of the Mental Health, what the membership of the Mental Health Alliance was, and whether the question was asked whether it would be professional heavy or whether we would be bringing in the valuable lived experience of service users, carers and the wealth of experience as well that exists within the third sector. There's very limited direct involvement. The problem with limiting the direct involvement and asking the public partners, for example, and the third sector to feed in through individual design projects is that they are then removed. They are then at a remove from the top level of discussion around these issues. And I think that is where their voice needs to be heard. I think that would potentially reflect some of the concerns that we've heard from our public partners today, and some of the concerns that the public that have been reflected by board members in the past. Did you want to come in, Chief Officer?
So just to apologise that IJB members haven't had a copy of that version of the Memorandum of Understanding. Because of the representations I have received from my monitoring officer, from the Chief Executive of the Council and from the Vice Chair of the IJB, I felt that it was more appropriate to take those representations back to refine and develop that document before it was brought back to the IJB. And all that you've said is all that I know we need to reflect on, as well as some comments also from the monitoring officer in relation to the need to be clear about the responsibilities of the IJB, the need to distinguish between the Health and Social Care Partnership and the IJB, and from the Chief Executive of the Council to recognise that the Council is a key participant in this work and needs to be reflected and represented in the terms of the Memorandum of Understanding and in the governance arrangements.
Thank you, Chief Officer. Are there any other questions or comments at this stage, Councillor Purvis?
Working now. Just very briefly, I agree with all the points that the Chief Officer has just raised in terms of the feedback that he's had, and I won't reiterate my concerns from earlier. I think it's the right decision not to bring it to this board meeting today, and for the Chief Officer to bring us a revised version of the Memorandum of Understanding. Just like to endorse the comments of Councillor Stewart that it would be useful to have that revised version a little bit in advance of the issuing of the papers, rather than just the papers coming out. But I think that hopefully we'd be able to agree something at the next meeting that reflects all of the concerns, both in terms of the membership and also in terms of the ensuring that the IGB and indeed the Council's statutory responsibilities and role in this mental health alliance is reflected.
I suppose just a word of caution that this needs to be signed off by the 3 IGBs and NHS Tayside, so we need to make sure that the changes that we would like to see reflected in it are encapsulated, but that doesn't take us to a position where we're having to negotiate with others about a change to what they've signed up to. Keith Russell.
Mr. Russell.
Can I just make an observation that much of the challenge that we've had today is around the pace of change in mental health services? And I can understand the absolute requirement to have clarity around the role of the Mental Health Alliance. But I hope that won't in any way delay or impede the work that we are attempting to progress. And I'm also very minded that the motion that was passed by the Integrated Joint Board commits the Tayside Mental Health Alliance to a set of tasks. So my understanding then is that we're committing the Mental Health Alliance to a set of tasks, but we're not quite clear yet from a Perth and Kinross perspective what the role of the Tayside Mental Health Alliance is.
I think the point is extremely well made, Mr. Russell, that we do need to get the Mental Health Alliance terms of reference and memorandum of understanding set up and running so that any discussions can proceed. But just to reflect, I have in various fora asked for the memorandum of understanding in terms of reference to be provided for debate and discussion, while the Mental Health Alliance has been referred to as an organisation taking forward plans since around the start of the year, and clearly the Mental Health Alliance terms of reference and memorandum of understanding, who's on it and what its responsibilities are, need to keep up. But if we've got a Mental Health Alliance set up since the start of the year, we should have been able, between the various partner organisations, to come to an understanding of responsibility and membership earlier in the year, I would have hoped. If there are no other questions or comments, we'll move on to the next item on the agenda, which is the inpatient mental health budget for 2019-20 to 21-22. This is reported by the Chief Financial Officer, so I will ask Chief Financial Officer to introduce it.
Thank you, Chair. The IGB have considered financial plans for all areas except inpatient mental health, so I am pleased to be bringing forward the financial plan to the IGB today. However, it is a one-year financial plan, and I think taking into account the discussion that's taken place over the course of this morning, I think the challenge for us is going to be bringing forward a 3-year plan, not for inpatient mental health services, but for mental health services. How we do that will be a challenge for officers, but I think a lot of what we've heard this morning is we can't see inpatient mental health in isolation, and therefore we would seek to be bringing forward something that looked different as part of a 3-year financial plan moving forward. The scrutiny and review of this plan has been significant. So much so that even in the course of the last few days, we've been working closely with Keith Russell to ensure that the savings set out in the plan could be signed up to wholeheartedly from a professional nursing perspective. And on the back of that additional work, there are a number of changes. There are 2 changes to the level of savings set out in the report. Savings number 4 and savings number 7 will reduce. They'll reduce from 300,000 to 204,000 and from 203,000 to 107,000, and I'm keen that that be minuted. So apologies.
Could you repeat those numbers just so? Of
course. Yep. So savings number 4 is reducing from 300,000 to 204,000. And savings number 7 from 203,000 to 107,000. Just following on from that, and before going into the detail of the report, also further to the discussion this morning, and taking that into account, and having had further discussion with my service management colleagues, we would like to propose that nursing savings, which are currently proposed as being recurring savings, be moved to be non-recurring savings for 1920, to take into account the wide discussion this morning about the need for investment in community-based services. And by holding these savings as non-recurring for 1920, it leaves us the flexibility to decide for future years how that redesigned saving from nursing is best used moving forward. So that's a further change, and apologies for that further change, but that change is supported by Keith and Arlene and myself to ensure that we are not taking recurring savings without understanding how they are best invested moving forward. So just in terms of the detail within the report, what the report sets out is a number of investments and disinvestments. We see investment in the 7-day home treatment service in Angus. We see investment in the police triage service and in crisis care. And we see investment in additional leadership resources and in the quality improvement team, both of which have been discussed this morning. The importance of both have been discussed over the course of this morning. The plan sets out a number of offsetting efficiencies from reviews of administration, of management and of non-pay spend. But in addition, and importantly, it recognises the workforce redesign savings from the significant redesign of workforce. But as I said earlier, we want to hold the savings on the nursing workforce to ensure that they are invested in line with the agreed strategy moving forward. So we will move those to be non-recurring. A number of short-term benefits are set out in the plan, recognising the contingency plans that are in place in general adult psychiatry and in learning disability services. And I would want to be unequivocal today that those are short-term cost-saving benefits driven by service decisions to ensure safe services moving forward. They are fortuitous cost reduction benefits that we're now able to absolutely legitimately build in to the financial plan. The most significant pressure that you'll have noted is the significant pressure around medical locum costs. And what we've heard this morning is the service impact of that. What we're seeing in the financial plan is the very, very significant financial impact of the medical locum costs. An overspend on our medical staffing budget of £1.7 million, which is clearly from a financial perspective not sustainable. And a lot of the discussion this morning was around how services will change to address the shortages in general adult psychiatry consultants. And as we come together to do a 3-year financial plan moving forward, the finance team will work hand in hand with the service to understand what the new service models look like and to understand the investment and disinvestment that will sit alongside that. So the changes in the savings that I advised you of at the beginning of this introduction take the gap on the financial plan for mental health services to 1.7 million. And that's the difference between the expected cost of the service, taking into account pressures, investment and savings, and the money being made available by NHS Tayside to fund the inpatient mental health service. Our share of that deficit in here in Perth and Kinross is 0.574 million, and that takes the IGB's overall structural deficit for 1920 to a figure of 4.168 million. For information, this financial plan has been shared with the 2 other IGBs who have had a chance to comment, and they have commented and we've responded to that. As I said, it's been subject to significant scrutiny, 2 meetings of the Budget Review Group, and I'm sure Callum may want to feed back on that. But before doing so, I wondered if Keith and or Arlene wanted to make comment on the service side of the financial plan.
Thank you, Chair. I just want to make it unequivocally clear that I am not supportive of nursing posts and the savings associated with nursing posts being on a recurring basis. And that is significantly influenced by the conversations that we've had across the course of today, where there has been a clear message from everybody around the table that there is a requirement to look at the service provision and the service offer in communities across Tayside. So I am, as the person who's been asked to professionally support the savings, I'm very clear that I'm not supporting them on a recurring basis. I'm content that they are seen as a recurring in-year saving, and that we look at that resource in the future in the context of further redesign of services.
Okay, are there any questions on the report? Mrs. Summers.
On page 25 under the amendments, under the expenditure pressures, we have pay uplift. Now, is that for the staff currently employed in Perth and Kinross, mental health staff?
That's staff employed across the hosted service, across Perth and Dundee and Angus.
Right.
In the
And
inpatient
that's
service.
500, it's $500,000, we're talking
Yes.
just over $500,000, right. Now, the last one there is senior management and quality improvement staff cost pressure, 367,000. How many people are on the improvement staff? How many people are we talking about here?
So I'm content to talk around the quality improvement element, because
Well, I'm talking about how many members of staff are there,
Well,
senior management and quality improvement staff, because that's only a very small amount of people compared to the pay uplift for the whole of Tayside. 559, as opposed to senior management and quality improvement staff, 367,000.
Okay,
I just
Mr.
wondered
Russell,
how many people are we talking about here?
Yeah, so do you know part of the answer, Mr. Russell, in terms of the quality improvement staff?
So I'm content to talk to the quality improvement team, and that is 2 staff.
2, right? Okay. And senior management, I mean, how many staff are we actually talking about here that are sharing that 367,000?
Sorry, can I come in there, Chair? I think there's a wee bit, I might be wrong here, but the £500,000 is the statutory pay uplift that staff will have got as part of the National Pay Award. That's not all their salaries. That's just the additional. So if the government gives them 2.3% as an uplift on their pay, that's what that £500,000 represents. It's not the salaries for everybody. It's just quite, I think sometimes it's maybe a wee bit confusing. These are not the salaries for all the staff. That's just the pay uplift. That's just the additionality that the staff get.
Yeah, but I'm trying to point out that the amount of people involved in the 559,000 as opposed to 367, whether it's salaries or whether it's, it's a big, I just wonder if you can tell me how many people are involved here.
Yeah, so Chief Financial Officer?
Yeah. Okay, so to be clear, Maureen, the 367,000 is a big sum, but it is made up of 2 constituent parts. It's made up of the quality improvement team investment, which is 2 whole-time equivalent, as Keith has outlined. The balance is in the leadership staff within the inpatient service, and that is a legacy issue of the requirement to invest. What I would say, and it's written in the narrative, if there is an offset, so that's not being done in isolation. It's not about an investment in isolation. There's been a fundamental review of what is required, what's there at the moment. So we have a £367,000 investment, which includes the quality improvement team, but below that, we have a saving of 81,000 that offsets that, and that's savings in management and service management posts that it provides an overall offset. So in a sense, I mean, we discussed that at the BRG session last week. I've tried to be transparent and be very clear and not net off the overall 367 investment, but below the line there is an offsetting saving of 81,000. The overall investment in posts in management as part of that is a further 2.5 full-time equivalent.
you've got a big savings there under the workforce redesign, which is probably frontline staff on the ground of 203,000 there as opposed to 81. You know, I just feel that the figures are not really telling the whole story. You know, you're just getting a block figures there. And I just wondered how many staff we're talking about for the 559,000. How many staff we're talking about for the 367, you know. And, okay, you're talking about savings, but the savings are, you know,
well, just to be clear, Maureen, to answer your question, the 500,000 that you're referring to is uplift for all staff across the inpatient service.
Yeah.
I don't have a figure at my fingertips in terms of how many staff that relates to, but that's across the whole service. In terms of the 367,000, that's an investment in 4.5 full-time equivalents.
Sorry, 4.5?
Full-time equivalent staff.
Sorry, isn't it the case that the issue with this additional staff is that whatever this employers' costs are 23% or something now between national insurance and superannuation? So it looks like a lot of money, but by the time you've paid employers' costs, is that not what makes it look bigger, Jane?
In terms of the pay uplift?
The 4.5. It does, for 300, I know what you're saying. For 387, you don't think you're getting a lot of staff. The problem is if we pay somebody £40,000, we've got a 23. I think it's 23% additional that we as employers have to pay to cover employers' costs. So that's another almost 25%. So that would be almost so to employ someone at 40,000, it really costs us 50,000. Do you see what I mean? So it's a wee bit misleading if you're not thinking that way, because it looks like you're not getting a lot of people, but unfortunately, employers' costs now are so great in local government and the NHS that takes a lot of the money away. Is that not the case, Jane?
Absolutely. Yeah.
I just wanted to point that out, like, you know, because the figures just jumped out at me, like, and I just wanted to.
Okay, Councillor Drysdale has a question.
Yeah, thank you. I'm conscious we're going to come on later on the overall financial position, so I'll hold my question on the overall position until later. But in terms of the inpatient mental health section, Jane, you've spoken about how the figure of 1.7 million is arrived at, and that's understood. You do, however, set out in section 6 of the paper further financial risks, and you set out what these potential risks are for the remainder of the year. So if these come to pass, are we looking at a higher shortfall for 2019-20, and if so, by how much?
So since this paper was written, Eric, the risk around increased superannuation costs is no longer a risk, it's now a reality. The funding that NHS Tayside have received from the Scottish Government does not match the costs that are being incurred in relation to superannuation contributions, and that gap is being passed out to each part of the NHS Tayside system, including the 3 partnerships. And for inpatient mental health, that additional cost pressure, which is not built into the financial plan, is not currently built into the financial forecast it will come on to, is round about £200,000.
Yeah, okay, so there are 3 items listed: additional medical locum costs associated with implementation of a consultant out of our rota to support doctors in training. And then point 2 is about staff superannuation costs, and point 3 is about NHS Tayside transforming Tayside staffing costs to support the mental health transformation that we've been speaking about all day. So again, are you able to estimate the combined effect of these 3 points on the overall shortfall for 1920?
Not at this stage. In terms of superannuation, I've given you an update based on the cost pressure that we know now is real. In terms of medical locum costs and out of our service, that is currently being worked through, and finance are working closely with the service to make sure that we can build in the known costs of that once the service actually know how that's going to be delivered. So we can't quantify that at this stage. But Gordon may say that I've highlighted the risk around NHS Tayside transforming Tayside staffing costs perhaps prematurely. However, there has been discussions around investment in resources, and there has been discussion about contribution coming for that from the Health and Social Care Partnerships. We don't know whether that is going to be an ask of us, but I thought it was important to flag it, but we don't know whether it is going to come as an ask or how much that's going to be.
Any other questions? Okay, the recommendation then is that the Integration Joint Board, now I'm going to ask you to jump in, I think you've got the correct numbers written down there, so I'll ask you if we can do this as a duet. Chief Financial Officer, it's recommended that the Integration Joint Board approve the 2019-20 financial plan for inpatient mental health services and set the budget thereon, noting the gap of
1.713 million.
Which remains. Request the Chief Officer to work with NHS Tayside to identify an action plan for reducing medical locum costs, and ask the Chief Officer to issue the necessary direction to NHS Tayside to implement the actions within the 2019-20 financial plan. Note that on approval of the inpatient mental health financial plan, the formal budget deficit for the IJB for 2019-20 is
4.168 million.
So I'm very happy to move the recommendations in the report. If I have a seconder.
I'm happy to second that. It is, I would note, it is unfortunate that how late we had those changes, but I appreciate the reasons in terms of the saving now being non-recurring in relation to nursing staff, and obviously those changes which you have indicated in terms of the revised savings. So happy to second.
Okay, thank you. Do we have any amendments or comments, or can we agree those recommendations?
Agreed.
Agreed. Okay, we'll move on to the next item on the agenda now. Give me 1 second to catch up. Yeah, but there's no point. Okay, so I think we'll take the next item that we'll take on the agenda, with permission, is the minute. And then we were due to have an audit and performance committee update, but we'll bring that in when we carry on with the finance and governance items on the agenda. Item 5 on the agenda. We have before us the minute of the meeting of the Perth and Kinross Integration Joint Board held in the Council Chamber on the 2 High Street, Perth, on Wednesday the 26th of June at 2019. I'm not going to go through page by page, but can I move that we agree the minute? A seconder for that? Do I need a seconder for the minute? Okay, the clerk has advised me that we can agree the minutes on a general aye, if that's acceptable.
Aye.
I need to really hear it though. General aye.
Aye.
Great. Okay, that takes us on to the next item on the agenda, which is the action points update. Chief Officer, if you'd like to go through the action point update, please.
Thank you, Chair. So we've got here a number of items that have been picked up from previous IJB meetings and are action points taken to take forward. The first couple of items relate to the proposed input to development session that's scheduled for the 23rd of October, with an input on improving Scotland's health and on self-directed support. The next items relate to reports that are anticipated for the 11th of December, in relation to our strategy for independent living and an update on free personal nursing care for the under 65s. Thereafter, a report is due next year in relation to the update on the primary care improvement plan. That's not until next May. And in response to a request from Councillor Drysdale, we are proposing to bring forward a report on the 11th of December in relation to the balance of provision in relation to the care home market in Perth and Kinross and how we use those services. Members might recall this was in particular request following an update in relation to the financial situation that Four Seasons Healthcare continue to experience. And thereafter there's a further report that will be brought
from any matters arising from the minutes and or the action point update. Chief Officer, you have one?
I have my microphone on in anticipation, yes. Members of the IJB will be aware that we had given a commitment earlier in the year that we would be bringing back our Perth and Kinross Strategic Commissioning Plan to this IJB, and we have been involved in significant work over the summer months. We had an earlier development session with members of the IJB in here in June, and we then embarked upon further work which included much community engagement, consideration of the high-level proposals that were coming out of our strategic groups and our programme boards of care. And we had anticipated having a further development session to share with IJB members a draft of the Strategic Commissioning Plan in July. Unfortunately, that was not able to proceed. So we do now have a draft Strategic Commissioning Plan. I have to say it has been a bit of a challenge in terms of getting there, and that reflects some of what is included in the Joint Inspection Report about the approach that we have in Perth and Kinross at the moment to strategic planning and the need for us to refresh our strategic planning processes and groups. The challenge was also around the various iterations that we've drafted, reflecting different views on whether or not we should be delivering a very short, concise plan of 6 to 9 pages, or a longer, more evidence-based plan with lots of data behind it, which would have run to many more pages. And the tension also in relation to the delivery of our final plan was about whether we write in relation to the 5 strategic priorities that the IJB has agreed, whether we write in relation to the work of the 4 strategic programme boards, or whether we write in a way that reflects our ambition to work more effectively in the 3 localities. In any case, I was hoping to bring a draft strategic plan to today's IJB, but members will recognise that from the agenda that was unlikely to be given due consideration, and I think that the need for us to consider mental health, to sign off the annual accounts, to consider Bridge of Erne, the inspection and financial recovery have meant that we haven't got the plan on today's agenda. But we'd intend to, and I'll take IJB members' views on this, either circulate it for comment ahead of a proposed development session, and we would look at the 23rd of October as the date for doing that, or we arrive on that day and we have, or we issue before that a version of it, in order that that discussion can take place on the day. So in effect, I am asking the IJB members for their approval to further delay the delivery of the Strategic Commissioning Plan, and in doing so to accept the proposal that the existing plan remains valid meantime, and to request some forbearance in terms of what I've described as the factors and challenges that have led us to get to the point where we haven't finalised the plan, but would wish to engage with IJB members before we arrive at that position. Thanks very much.
Okay, any questions on that update? Councillor Drysdale.
Yeah, thank you. Fully appreciate we've got a rather full agenda today and all the rest of it, and I completely take on board what you're saying. Obviously, it's a critical next step in terms of the direction of travel for the Integration Joint Board, and I'm sure it will be given full consideration at the development session, which I think also is intended to cover self-directed support. I think that was the original plan for that development session. So yeah, I mean, I am supportive of this continued delay. I'm assuming that the Scottish Government are also supportive. Is that the case?
So the Scottish Government are not expecting us to submit. They're expecting us to deliver a plan, and they haven't expressed any concerns about the timescales. Similarly, I will have to, as I'm doing today with the IJB, have this sort of discussion with the NHS board about looking for them and for the council to recognise the reasons for delay and to approve that.
Any other questions? Okay. The next item on the agenda then, we were going to go back to finance and governance, but with your indulgence, board, the clerk is champing at the bit to give his membership update. So I would invite Mr. Hendry to address item 9 on the agenda, and then we'll come back to the Chief Financial Officer.
Thank you, Chair. Apologies for this not being in writing before you. However, there have been a number of kind of last-minute updates. So just to update you, in terms of the membership, as the Chair's already alluded to, following Robert Peate's resignation, Councillor Stewart will take the Chair on behalf of the Council from the 4th of October as per the integration scheme. It's already been noted that Mr Bob Benson will be the new Vice Chair, and I understand that that will be ratified by NHS Tayside Board on the 31st of October, and also that Dr Norman Pratt will be the new additional voting member from NHS Tayside. Jenny Alexander, who we have today, will formally replace Lorna Burr-Stewart as a voting member from the 1st of October. Sarah Dickey was appointed as the nurse representative on the IGB at the June board meeting. However, due to a change of roles within NHS Tayside, the board are now asked to agree that Sandra Gurley, Acting Associate Nurse Director, be the representative on the IGB until further notice. In relation to the third sector representative, Claire Gallagher was the main member, with Sandy Watts as the substitute, who were appointed until the 30th of September. The third sector Health and Social Care Strategic Forum recently agreed that between now and the end of the year, Sandy Watts be nominated as the IGB representative, with Claire Gallagher being the substitute member, prior to a full election process at the beginning of next year, and the board are asked to agree this position. Lastly, in line with the ability of the IGB to appoint an additional non-voting member of the board, it is proposed that Miss Lynn Blair, who is independent sector lead with Scottish Care for Perth and Kinross, be appointed to the board initially for 1 year.
Okay, thank you. Any questions, or can we agree those appointments as outlined verbally by the clerk? Agreed. Thank you very much. Okay, so we'll go back to finance and governance. I said that I was going to come to the Chief Financial Officer, but I think I'm going to go to Councillor Purvis as Chair of the Audit and Performance Committee to give his verbal update, and then we'll come to the Chief Financial Officer, if you can hang on just a second longer. Councillor Purvis.
Thank you for remembering me, Chair. I'll try to be brief. We have discussed a number of the other things, including the accounts, and have already considered them, so I won't go into detail about this. We considered some of the usual standing items in terms of governance and assurance and audit. Just to pick up on some of the important substantive items which were on this particular agenda for the most recent audit and performance meeting, we had a paper on EU exit preparedness, to give assurance to the Integration Joint Board that the Health and Social Care Partnership would be able to manage any implications of our impending exit from the European Union, and regardless of whether that is with a withdrawal agreement or not. That will prompted some robust discussion, and I hope that that was useful to all members to provide them with assurance that all those arrangements are in place, and perhaps alleviate any concerns that some members might have had about that. In terms of another important item that we had on the agenda, we had the Older People in Unscheduled Care quarterly performance report. This is the second time that this has come to the Audit and Performance Committee. And just like to note that if anyone hasn't had the opportunity, board members who are not on the Audit and Performance Committee, I would certainly encourage them to have a read of this report. Certainly the feedback that we gave when this came to the previous Audit and Performance Committee has been taken on board, and that was certainly a very useful document, I think, to allow the Audit and Performance Committee on behalf of the IGB to scrutinise the performance of this programme of care board. So just again to reiterate, as I said at the committee, our thanks to the officers who were involved in putting that together. It's very useful, both having a high level overview of some of the indicators and targets, both national indicators and some of our own indicators, whether we're meeting them or not, and also additional detail that people can look into should they wish to do so on our performance in those areas. In line with the revised terms of reference, and this is something that was picked up on in the inspection report, we are all committed to a greater focus on performance at the Audit and Performance Committee. We have reiterated in the past, while audit, risk, governance and assurance are all, and finance are all extremely important things for the Audit and Performance Committee to consider, and we are a service-based organisation and we do have to ensure that we are effectively monitoring the performance. So the stage that we want to get to is having a report for all 4 programme of care boards to come to each meeting of the Audit and Performance Committee, and I think that we are looking to get to that position in the new year. Did give a commitment that at the next meeting of the Audit and Performance Committee, even if we weren't in a position to bring a formal report for some of the other programme of care boards, we would look to either have a presentation or a verbal update from those programme of care boards that were felt sufficiently advanced in order to do that. I know that the Primary Care Board and the Carers Board were making significant progress. So it's very encouraging to see the progress that has been made with the OPUSC board and their reports, but obviously we would like to see that across the Health and Social Care Partnership. And in addition, in terms of, we did approve a work plan going forward, which includes these 4 programme of care board reports coming to each meeting. We also approved that locality action plans would come on a regular basis to the Audit and Performance Committee, and given that localities are a very important way in which we deliver our services to residents in Perth and Kinross, it is important that the Audit and Performance Committee and indeed the wider IJB has oversight of how those locality action plans work and are able to scrutinise the performance of those, because again that's something that has not happened in the Audit and Performance Committee in the past. So it was very encouraging. Again, I would encourage everyone to go and read that OPUSC report if they haven't. And just to reiterate that as per the revised terms of reference, all members of the Integration Joint Board, both voting and non-voting, and stakeholder representatives are invited to come along, contribute, ask questions and comment during Audit and Performance Committees, in addition to the formal 6 members of the Audit and Performance Committee. So I'd very much welcome anyone who wants to come along to get more information about the performance and audit of the Integration Joint Board.
Thank you, Councillor Purvis. Have we got any questions on the Councillor Purvis's update on the Audit and Performance Committee? No. Okay, thank you very much. Councillor Purvis, we'll move on then to the 2019-20 financial position and the report from the Chief Financial Officer.
Okay, thank you. The approval of the inpatient mental health financial plan in the last hour, as we said, takes the overall budget deficit for 1920 for the IJB to 4.168 million. And therefore, all other things being equal, this IJB should expect that our forecast position should be £4.168 million overspent due to that underlying budget deficit. Notwithstanding the efforts being made by officers, not only to address and to identify in-year recovery measures that can help to offset that, but also to begin the process or to continue the process of identifying the transformation, efficiency and very difficult decisions that may be required to address that gap on an ongoing basis. So the first forecast that we're bringing forward is based on the first 4 months of the financial year, and it predicts an overspend of 4.8 million. So that is above the £4.2 million that we should have been expecting. In the first 4 months, there has been a number of unanticipated pressures, predominantly across older people's services. We have been able, however, to build in a number of non-recurring benefits, including slippage on planned investments. Recognising the structural deficit in our position, actions and activity have been underway since early in the financial year to identify in-year opportunities to offset the approved deficit. And the financial recovery plan that we've brought forward today seeks approval to identify, to implement a number of actions that will reduce the forecast position to 3.550 million. And work will continue to identify other in-year measures. The report does, however, raise a number of further financial risks. We have talked already in relation to inpatient mental health around superannuation costs. The overall implication for the partnership is a further unanticipated cost pressure of £500,000, which is not currently built in to the forecast. We have also talked about the risk around inpatient mental health locum costs, and as colleagues know, there is always risk associated with our prescribing forecast, although I'm pleased to say that the prescribing position seems to be headed in the right direction, and the month 5 position shows further improvement on the position that we're reporting today, so that's some good news. I'm happy to take questions on that before moving on to the financial recovery plan.
Councillor Purvis.
Thank you. If I could ask the Chief Financial Officer a question, and excuse my ignorance if that is indeed the case in relation to this, but I'm not aware of what this means. On the second paragraph on page 147, the continuation of 3.1, it talks about the staff costs driven by incremental drift issues in North and South hospitals. I was just wondering if you could explain what that means.
Yeah, apologies, because I have had that question now from several people, and we'll choose to explain that more carefully in the future. But basically what that relates to is the fact that our budgets are set assuming that on average we have staff sitting at the midpoint of a salary scale. What we're finding, and particularly in our community hospitals, is that a significant number of our staff have been on that scale for a significant period of time and are at the top of the salary scale. And therefore, there's a difference between the available budget and what we're actually having to pay out, because staff are at the top of their pay scale.
Mr. Benson was next.
Thank you very much indeed, and thank you very much indeed. The current forecast position based on review of results for the 4 months to July 2019 is an increase in the forecast overspend to 4.860 million, as I understand it. The underlying deterioration in forecast is 2.094 million. This is clearly a significant movement over a 4-month period, which leads me to ask two questions. Why such a significant deterioration in the forecast position after only 4 months? And could or should this have been known at the start of the year? And secondly, the draft recovery plan is all non-recurring. What will be done to deliver recurring savings and prevent the same issues arising next year? And I'll come on to risk share in due course.
Okay, so just taking each point in turn, yes, we have seen a number of unanticipated pressures in the first 4 months. As I said, these are predominantly in relation to older people's services, in relation to care home placements in particular, and in relation to the need to cope with the level of demand for our inpatient beds within Tay ward and in psychiatry of old age. We hadn't predicted this level of surge in demand, although we have done detailed work in terms of our budget settings to predict demand. The level of demand for these services in particular has given rise to a level of unanticipated spend that we weren't projecting, and obviously gives cause for concern. In terms of recurring savings, our ongoing budget setting process that we will be coming back to the IJB with a 3-year financial plan, as we did last year, and that's when we will bring forward the really kind of fundamental decisions about how services need to change to address this deficit. The financial recovery plan is a 1-year in-year response to try to reduce levels of spend in-year. The 3-year financial plan will bring forward the much more fundamental, transformational, structural response to that deficit, which will include, and unsurprisingly, given the level of overspend in terms of our structural deficit, given those further increases in demands that we've seen in the first 4 months, will include a level of very difficult decisions for this IGB to make that may or may not take us away from our strategic plan direction.
And thank you. May I move on to risk share, please?
Sorry, Bob, can I just come in there?
If you want to follow up with a supplementary,
yes, it's on the same point, Jane. If I'm looking at this correctly, the 4.860 is the deficit. The 1.338 million is the non-recurring savings.
Yes.
Yeah.
In the recovery plan, yeah.
In the recovery plan. But is that then not really a deficit of 6.2 million?
No.
4.8 is before you apply the 1.3, should we realise it?
But the 1.3 is non-recurring. And that's assuming that we agree today that that's appropriate use of non-recurring monies.
It's not built into the 4.8, so whether you approve the 1.3 or not, the 4.8 million is the professionally assessed year-end forecast based on discussion with the service. The 1.3 million further benefits would take that down, and if it was approved today, our forecast when we come back would bring that down to the reduced sum.
Right, so it's not 6.2 million?
No.
Right, okay, sorry, that was just a point of clarification. Thank you.
Continue, Mr. Benson. Microphone.
Oh, sorry. The current risk share agreement exposes NHS Tayside to the overspend on health budgets only. So NHS Tayside will have to provide 2.079 million funding to support the IJB overspend at year end if no action is taken to address the overspend. Now, there have been questions asked about changing the basis for risk share between the IJB and Perth and Kinross Council. In our view, there is no need for a change in the risk share agreement to get consistent figures across partnership organisations. It just needs simple communication between partners. And if I might go on, there is no incentive to do any changes. There would be a significant financial disadvantage to NHST in agreeing to this. That is, the board would be badly exposed to adult social care overspends and the share of overspend that NHS Tayside would pick up increases from the 2.079 million above to a figure of 3.645 million. These are based on your figures. So these would certainly be our concerns, and we would not agree to any change on the basis of the risk share.
Thanks for the comment, Ms. Benson. The issue in relation to the risk share agreement is that in terms of the integration scheme, there hasn't been a formal a formal change, and so what was in the integration scheme for the first 3 years continues. It's not really a matter of, I'm not going to say it's not a matter of concern for the IJB, but it is for the partner organisations to discuss and agree that risk share agreement between themselves. I think the IJB has in the past just taken taken the stance that it was our responsibility to point out that the risk share agreement was kind of open-ended, and the language was kind of in the integration scheme was kind of loose when it came to what happened after the 3rd year in relation to the risk sharing. I think it's really for the chief executives of the two organisations to discuss, as we've asked before, but I'll let you come back in.
I'm pleased I've raised the issue anyway, because clearly it's a matter that needs ongoing discussion. But we are looking at, if we can't cover, if these predictions are real, we may have to look at using existing reserves of the IJB, and that's a difficult issue. So.
I mean, I absolutely accept that it's a difficult issue, but what I would say is that, that the IJB has approved the financial plans that gave rise to a structural deficit that recognised the difference between the money that we required and the money that was being made available. So there should be no surprise around the 4.2 million, which is on the back of the financial plans approved by this board.
Thank you. On the issue of the risk share agreement, did the head of legal and governance at council want to come in? No.
No, I think you described it perfectly, Vice Chair.
Thanks very much. Councillor Drysdale was next with the question.
Well, before I ask my question, if I may just quote directly from the KPMG audit report on the issue of the risk-sharing agreement and the recommendation made by our independent external auditors. And I'll just read out the paragraph because it's very clear. This arrangement gives the this is the existing risk-sharing agreement. This arrangement gives the IJB comfort that overspends will ultimately be met by the partner bodies. We note that it does not motivate collaborative working between the three parties. For example, overspends in a council-funded area of service may be driven by increased high-outcome activity, which delivers reduced demand in an NHS-funded area of service, given the given the benefits of preventative care. There is no consideration for this in the integration scheme. So, I mean, that's for me is a clear steer from the external auditors that the risk-sharing agreement should be revised in line with the risk-sharing agreement of the other IJBs in NHS Tayside. So I'd make that observation. I do have further questions after that.
Thank you, Councillor Drysdale. Anybody else want to come in on the risk share agreement? Otherwise, we'll carry on with the questions. Do you want to come in, Ms. Reid?
Thank Thank you, Chair. I've just caught the tail end. I'm sorry, I had an urgent item to deal with. But I have raised the risk-sharing agreement with the Chief Executive of NHS Tayside. I'm not confident that we will have traction on that matter at this moment in time.
Thank you very much. Councillor Drysdale, do you want to continue with your questions? I know I've got a couple of hands up over on my right as well.
Yeah, thank you for that, Chief Executive. But I ask you to stick to your guns on that one as much as you can. In relation to my other question on paper 8.1, we have obviously spent all day talking about inpatient mental health services, but there's so much else going on within the IJB. At 3.4, there's a short sentence on prescribing which states, further information is currently awaited from NHS Tayside finance team to understand the variance from plan, which is over £750,000. So while we've been rightly focusing on inpatient mental health all day, £750,000, whilst an improvement apparently is that is the only figure we have, and I do not recall seeing very much in the way of figures over the 2.5 years I've been on this board. When can we expect the NHS Tayside finance team to deliver the goods?
Well, I'm pleased.
Chief Financial Officer.
Sorry, Chair. I'm pleased to say that we have much more detailed information being made available by the finance team in NHS Tayside for the month 5 position. And what that will allow us to do is look at our own financial plan line by line. And if you recall, that made assumptions about growth in items based on increased demographics. It made assumptions about changes in price based on a significant increase in prices we've seen in the previous years, and it made an assumption about the impact of our own quality and efficiency in prescribing programme and a significant challenging target. So what we'll be able to bring back at the next meeting, based on the further information that we've now received, is a granular assessment of where we are against our planning assumptions in relation to price growth, in relation to item growth, and in relation to the impact of the quality, safety and efficient prescribing.
Okay, Dr. Pratt.
Thank you. My question, in fact, has just been asked about the prescribing, but I wondered if this had been looked at the same forensic way as Angus have done.
Absolutely. I mean, Hamish Dougal, unfortunately, our Associate Medical Director, had to leave today because he's unwell. But Hamish has taken an absolutely, invaluable leadership role, which has been around real engagement with our GP practices to change, to embed a change in culture around prescribing costs. What we've seen is a number of measures that, yes, will reduce prescribing costs on a short-term basis, but what Hamish brought forward to the IJB a number of years ago now, just at the start of the IJB, was approval to spend money on working with practices and releasing time in GP practices so GPs can come and engage with us to change their prescribing behaviours. And I think what we're seeing in terms of that change in item growth that we're seeing for the first 5 months, that's significantly improved our position beyond what we're reporting today, is an impact of that work at local level with our GPs. So a lot of what we're doing very much mirrors what's happening in Angus.
Thank you.
Mrs. Summers.
I know of 2 carers who have husbands in the short-term psychiatric old age beds at Murray Royal. I say short-term in inverted commas because they've been in there for well over a year. They were put out to care homes but were unmanageable and put back to Murray Royal. So in actual fact, they're bed blocking, and this is causing huge problems. I wonder, is there anything being done to address that? Because I told them I would bring it up and find out what would be happening for them, because that's obviously costing a lot of money as well. They're in there and they should really be out in care somewhere, but there isn't an appropriate place for them.
Okay, so I think this is a question about delayed discharge, so maybe, or do you want to take this one, Chief Officer, rather than the Chief Financial Officer?
I was just looking at the expenditure there for psychiatry.
So I wasn't wanting to speak about individual cases, but the Chief Executive maybe wants.
This is not a forum to bring individual concerns to. This is an integrated joint board that's charged with governance of health and social care. So it's really important. If the general question is about delayed discharge, that's absolutely fine. But this is not a forum to bring individual concerns, Maureen.
However, I'd be more than happy to get the details from you afterwards, Maureen, and I think it's probably not appropriate to discuss, given that we do have in this report details of some of the financial challenges in and around psychiatry of old age, and we wouldn't want that to be attributed to any individual circumstances.
I wasn't bringing it up as a specific problem. It's a problem that's ongoing and will affect a lot of people, and I wondered what's been done to address that. You know, I said I would bring it up because that seems to be a missing part of the link, like, you know.
So addressing the question in general concern, in general terms.
So, I mean, I think I would address it by highlighting the fact that we have achieved significant improvements in Perth and Kinross over recent years in relation to delayed discharge in terms of both people who are waiting and how long they're waiting for. We have moved from a position where we were performing fairly poorly in relation to the number of unscheduled bed days lost to a position where we are the second best mainland performing health and social care partnership. However, as we've heard today, there are significant challenges about people who are experiencing very lengthy and unacceptable delays, people with learning disabilities who are looking for complex care support and packages to get them into more suitable accommodation. And absolutely, there are significant challenges in relation to the situation that you've described that we need to consider, and we need to look at how we can work with care providers and work imaginatively with our housing colleagues to see what kinds of solutions that we can come up with, or to work with care homes and identify what sort of additional support that they might need, what sort of input that they might need from community nurses or from liaison services in order for them to support people whose behaviours can sometimes be a challenge to services. So we will take on board your comments and happy to discuss individual situations after the meeting or elsewhere.
Thank you.
Okay, Ms. Kilpatrick.
For the Chief Finance Officer, you talk about the areas of further financial risk, and we have discussed what those are. I think it might be useful for the board, though, to have a kind of indication of the range, because it's quite open-ended, you know, so complex care packages continue to increase in number and cost. Some kind of ballpark figure, Jane, that says it could be, it's currently running at an overspend of 150,000, it might go up to 300,000. So we could, I think what board members get nervous about is when things come out of the woodwork that we didn't know about and couldn't maybe have forecast. So just a range, maybe, even just your best guesstimate. Nobody's going to hold you to it, but at least it would give, I think, just a wee bit reassurance that we've got a bit of a handle on that. And if it changes, you know, it needs to be updated, I think. I know that's probably quite difficult because, you know, things will come out the woodwork, but if it's your best estimate, I think at least it's an assumption, a planning assumption. And
I think we could absolutely do that. I think that could be based on, for example, just advising the IGB that a further 2 packages at an average cost would be approximately, you know, 200,000. So we can give you a quantum based on a number of assumptions that may or may not come to pass. I think that's perfectly reasonable. Thank you. Yeah.
Ms. Gourley.
I think some of our discussion reflects what we've discussed this morning in terms of the end-to-end pathway kind of work that we need to do for mental health. I think the same principles need to be applied in terms of the predicted and actual overspend in terms of older people and unscheduled care services. Now, I know that there are ongoing discussions around how that is going to work, and I would assume that it's the Older People and Unscheduled Care Board within the partnership that's taken forward that work from a patient journey end-to-end perspective. One of the things, though, for me that
really has to define how we look at the financial planning is in terms of our workforce. We heard today that the workforce is the kind of driving force in terms of quality of care, but of overspend. And in terms of what we're being presented with today, I just wonder, one of the annual accounts made reference to there not being a workforce plan being developed in terms of the timescales that had been expected. And I just wonder, I'm just sort of looking for assurance in terms of how the workforce plan is being developed across the partnership, across older people's service, and I suppose across all of the boards that are under the partnership.
Chief Officer.
So this was an issue that was highlighted also in the joint inspection around, in fact, both issues: the lack of progress in relation to complex care, the lack of progress in relation to the development and delivery of a workforce plan. So we need to attend to this because, as you rightly point out, so many of the challenges that we're encountering are around the dearth of GPs or of psychiatrists or of nurses or of staff who would work in social care. What we need to do is look, I think, much more creatively at the workforce and ensure that we can think about people working in a more agile way, to think about the potential for people to work in generic roles, to anticipate that we want people to work at the top of their license, and that might mean that we have to create other opportunities for different types of roles. So the solution to doctors is not more doctors, it's about advanced nurse practitioners, it's about OTs, it's about different types of roles. Similarly, in relation to the challenges that we have with our psychiatric workforce, it's about looking at how we use staff differently. That said, those are the types of considerations that do need to inform our workforce plan. We now have the added impetus that has been given to us by the Scottish Government, who are expecting us to submit by the 31st of March next year an integrated workforce plan for the partnership. We have begun some work under the programmes of care to look at their workforce requirements, to begin to think about succession planning, to begin to profile the age of our current workforce and anticipate where we're going to have challenges moving forward. We do await further guidance and a template from the Scottish Government, but the work is underway, and we would look forward to reporting to the IJB early in the new year the progress that we've made in relation to the development of that workforce plan.
Thank you. Another question, Ms. Kilpatrick?
Yeah, I have a question. I think it's probably the last point I want to make on paper 8.1, which is about the table IJB Reserves Appendix 4. And I've got some concerns about that. You know, given the pressures in primary care to move activity from GPs to other primary care professionals, if I say that, and there's a shortage of GPs and there's a shortage of primary care professionals, the Mental Health Action Fund and the other section of the Primary Care Transformation Fund. Now, given what we've had this morning, given the issues of mental health, given the issues of primary care, and also maybe thinking about how we get GPs and CPNs in practices to take a greater role in the management of mental health, I'm a wee bit concerned about using earmarked reserves to bail out our financial position, and also the Alcohol Drugs Partnership Fund, given the profile that NHS, not NHS, Tayside, Perth and Kinross, Dundee and Angus have got in relation to our drug and alcohol problems. Would we really want to be using money that's been earmarked? I mean, what we're really saying here is the government have identified this as a priority. They want to put money into it. That's a government priority. By holding that money back, we are shooting ourselves in the foot, and that's my view, because that money is needed for all these transformational models of care that we need to put in place. And if we hold it back in reserves to offset our financial position, then we make Gordon's job harder, we make the Mental Health Alliance's job harder, we make everybody's job harder. And that, as a board member, that's my concern.
Chief Financial Officer.
Okay, so just to be clear, at Appendix 4, what we are saying in that appendix is subject to discussions which will come on to around the financial recovery plan. We would be seeking to earmark all of those currently forecast unspent funds and carry them forward next year, you know, to meet the commitments that we've got. What we'll come on to in the financial recovery plan in relation to ADP funding and GP primary care transformation funding is the fact that we've had balances of funding that have been sitting for a number of years for which we still don't have any spending commitments. And when I look at all possible options for balancing the financial position and have asked time and time again for spending plans and I still have nothing coming forward, that is the reason why an element of very historic ADB funding and historic primary care transformation funding has been put in as a proposal in the financial recovery plan for consideration later today, because despite a number of attempts to ask those budget holders to bring forward plans, we have still not got them. And in the context of a very difficult financial position, I have taken the decision to put those forward as proposals for you to consider today later on.
Chief Executive.
Thank you. For those of you who were around last year when the interim Chief Executive of NHS Tayside and I instructed the financial recovery plan, you'll be aware at that point I noted that I did not want ADP monies that are held in reserve used for any other purpose than what they were giving, and that was for alcohol and drugs. My position remains the same.
Mrs. Kilpatrick.
I'm very pleased to hear from the Chief Executive that that's the position, and I don't doubt how difficult all of this is. I think from a management perspective, we have to raise our eyebrows a bit, I think, about having money in there in lines for service developments that people don't seem to aren't bringing forward proposals for. And I find that quite shocking, really, because mental health, primary care transformation, these are services all under immense pressure, and so I think there has to be a difficult discussion with service leads about there's money in the budget. Have you got service developments? I mean, you know, that doesn't feel quite right to me. After all of the discussion we've had today, that just feels counterintuitive. And I completely understand your financial position, and I know you're probably looking for every penny that you can. And I understand that if money's lying there historically and has not been, but that is an issue for management.
Just in order to clarify, particularly given the lengthy discussion this morning about all of the priorities on mental health, what Appendix 4 shows in relation to Mental Health Action 15 is that we don't propose that there'll be any funding unspent at the end of this financial year for carry forward. So that is one area where we have got specific plans, which I think is extremely positive. However, there are some areas where those aren't in place and haven't been for some time.
Chief Executive again.
Just very briefly, I appreciate this is not a question, it's an observation. So what we have in terms of financial recovery, and I appreciate we'll go on to that in a few moments, is pretty much a chicken and egg situation, whereby we can't have detriment to either the NHS or indeed to the council, but what we need to see is significant shift into community care. Before we can do that, we need a shift in terms of the large hospital set-aside budget into communities, and equally so, I recognise the challenges in terms of delayed discharge and not impacting on delayed discharge, emergency admissions, unscheduled care, etc.
Okay, do we have any other questions? Councillor Drysdale?
Sorry, yes, another one. I'm not really expecting an accurate answer, Jane, so don't fret. But you know, the projected financial deficit for this year is scary enough, and we've heard about the potential risk of further adjustments to that in the remainder of the financial year, obviously. Over and above all that, there are a number of underspends, many of which are bad underspends, if I can call them that, due to vacancies, it's especially to staff vacancies and so on. So isn't it true to say that if there were no vacancies, if we didn't have this issue of staffing, the actual many of the underspends disappeared, the actual...
Those vacancies weren't there, the financial position would be worse. But what I would say is that vacancies are routinely part of what allows us to manage our overall financial position. In terms of significant areas of vacancies, I mean, I would really defer to kind of service colleagues in terms of it. I'm just thinking off the top of my head. There are not any. I mean, we've talked a lot about inpatient mental health this morning, but aside from that, a lot of our part of the issue with vacancies is actually we're having to cover them through supplementary staffing. And that's what's giving rise to the overspend. We're not actually allowing these vacancies to be vacant. We're having to fill because of service need.
Yeah, thank you. I'm really just trying to build up to the comment, my old hobby horse, if you like, that about the adequacy of the budgeting in the first place. This is a structural deficit that is not going away anytime soon, and so I would like to speak probably under the next paper in terms of the requisitioning process going forward.
Okay, do we have any other questions on this paper? Okay, just to note then that the recommendation... Oh!
I'm not sure if it's the same question that you were referring to, but on page 165, they're referring to historical ADP carrying forward. Was that what you were referring to earlier when you were speaking? Yes, because I think the same thing has happened in inpatient mental health services, and if this money was actually, awarded for a certain thing and ring-fenced, then I think it should remain there. I don't think it should be used to offset, overspend elsewhere.
Okay, we'll come on to that particular thing in discussion of the next paper, but just to conclude the discussion of this 2019-20 financial position, the update from the Chief Officer, we've got recommendations to note the 2019-20 forecast year-end overspend of £4.86 million for the IJB.
Can I make a very general observation?
I'll let you come back in with a comment.
Sure,
I'm just in the middle of moving the paper. Note that this compares to a gap anticipated based on the financial plan approved by the IJB, adjusted for inpatient mental health services of £4.168 million, and note the update regarding the IJB reserves. You wanted to come in, Mrs. Kilpatrick?
Yeah, and sorry to interrupt you. It's not a big issue. Well, maybe it is a big issue. I found that paper and the next paper, and maybe I'm being a bit preemptive here. If you're not an accountant, I find sometimes it's difficult to track across the train of thought and the logic. I don't think like an accountant. In fact, I'm not very good at maths. So I wonder if maybe a kind of more member-friendly or board member-friendly.
Non-executive.
Thank you. Yes, I was going to say finance for dummies, but that isn't a very nice thing to say. But a more simplified version of the key points, maybe. It was quite hard to pick out the salient. I don't know if I'm the only one that thought that, but
I'll take this. Okay. I don't think we want to oversimplify the financial details. I think that when we get these papers out, we have got contact details at the end. So if there are any questions or any issues of understanding or any points that need clarified in advance of them coming out, perhaps maybe just because I've been used to reading them for longer, but I don't know if you wanted to come in, Chief Financial Officer.
Well, I think we would take that on board, and what we can do, certainly in terms of the upfront executive summary, is to pull out the key points, and you can track that to the overall summary and then to what you're reading in the more detail. So it provides that link between high-level figures and the detail in the the main part of the report.
Yeah, I mean it's not a big. I don't think it's a big deal. It's not about reducing the level of detail. It's maybe just more about the executive summary.
Yeah.
Thank you, Jane.
Okay, thank you. So having moved the paper, if I could get a seconder to accept the recommendations on the front page. Thank you, Mrs. Kilpatrick. Any other comments, or can we agree the paper? Agreed on a general eye. Agreed. Agreed. Right, thank you very much. Okay, we're going to need to consider our time, but we do have to, in terms of dealing with the papers that come under the Chief Officer updates, but I think we do have to consider financial recovery plan for 2019-20. Again, this is a report by the Chief Financial Officer. Jane, if you would like to lead that.
Yes, so the first thing I would like to clarify is that yes, we have before you a financial recovery plan today, but unfortunately on pages 162 and 163 it does make reference to the fact, or it does make reference to this being supported by the executive teams of NHS Tayside and Perth and Kinross Council. I think it's important to say that had been our ambition. And meetings have taken place with colleagues on both sides, but it is not accurate to say that this plan has been approved. So I just want to make that clear absolutely up front. What this report does, however, though, is respond to the duty that has been placed on the Chief Finance Officer and the Chief Officer to bring forward a recovery plan to the IJB, and the responsibility of the IJB to bring forward a financial recovery plan to respond to the significant forecast deficit position. So we had a choice to make. We could have we could have taken this paper off the agenda and waited for those further discussions to take place, but that would have meant getting agreement from both parent bodies and then coming back to another meeting of the IJB. So we've taken, I think, what is, I hope, a pragmatic decision to bring it to the IJB today, but to then seek those further discussions that are now required with NHS Tayside and Perth and Kinross Council colleagues to take from whatever comes from the IJB today into those forums to get agreement so we can then proceed to implement. And I think that is really, really important, because the figures set out before you today are based on implementation from the 1st of October, and any delay in kind of getting agreement to whatever proposals are acceptable will mean a reduced in-year benefit. So I hope that gives some comfort as to why we've brought it forward today, despite that agreement not yet quite being in place. The Financial Recovery Plan proposed actions at this stage are set out at page 165. They have been the subject of detailed scrutiny of the Budget Review Group. From a Chief Finance Officer's perspective, these are the least worst options. A number of proposals that were on the table have been taken off, subject to further discussion around full system impact of what they mean. So I recognise that there may be a level of concern around some of these actions, but from a Chief Finance Officer's perspective, and Gordon can speak for himself, these are our least worst options that we're bringing forward today.
Questions? Councillor Drysdale.
As you know, I see the younger members of the Budget Review Group have slipped away. An older gentleman here still sitting after all these hours. As Jane has indicated, the proposed financial recovery plan has been scrutinised by the Budget Review Group, and we have come to a consensus around the proposals that are before us today. As Jane says, they are the least worst options. Reference is made in paragraph 3 of the report to other measures which were initially under consideration but have been removed for the avoidance of doubt. I'm not supportive of these. But, you know, if they come back, that will be a real challenge for me to support. However, I am supportive of what we have in front of us just now. We have genuinely squeezed savings out of every orifice, and whilst at the same time we've tried to improve and maintain essential services, but we really have squeezed everything. And so it comes back again, and I'm sorry to keep on going on about it, but it really does come back to the adequacy of the budget in the first place. And when we come to the requisition process for future years, we really do need to think long and hard about the amount that this IJB is requisitioning from the parent bodies.
Okay, thanks for your question. I know that thanks for your comment disguised as a long question. I note that when we have discussed the budget previously, just as you say, we have on previous occasions noted the insufficiency of the budget, at least in relation to prescribing, GP prescribing and inpatient mental health. Obviously key elements that we, most of which, key elements that we've discussed today. Obviously we spent an awful lot more time on inpatient mental health, but previously, as was alluded to, we have spent a lot of time talking about GP prescribing too. But I don't know if the Chief Financial Officer wanted to come in relation to that. No. Okay. Are there any other questions then? Mrs. Kilpatrick.
So if we can deliver this recovery plan, it'll take the deficit down from 4.8 to 3.5, is that right? Yeah. Well, I would just like to say that I think the Chief Financial Officer ought to be commended for all the work, although I said that it was quite complicated. That's not necessarily any reflection on the work. I think the work is difficult, and I think she and her team should be congratulated for doing a really good job on this. I think members appreciate that.
Thank you very much. I think that we'd all like to thank the Chief Financial Officer, but I know that if we did, the Chief Financial Officer would immediately turn around and say that she was supported by a whole team of colleagues behind her, and she would want to thank them. Have we got any other, and the Chief Officer, have we got any other questions? No? Okay. Oh, Dr. Pratt, yeah.
Obviously, you're squeezing every penny out of this. I just wonder if looking to the long term, you know, our alliance is going to be on transformation, which would be a lot better working in partnership, but would probably be struggle to be delivered in a short time frame. And I wonder if we should be trying to keep some view to the bigger picture, and particularly thinking about how to make this area, all of Tayside, an attractive place to work, so that we recruit the right people, get social prescribing going, and think to a long game.
I think the points are well made, particularly in relation to social prescribing. Reference was made earlier to the number of social prescribers that we have within the Perth and Kinross Health and Social Care Partnership. 6, covering an area, covering a population of 150,000. In order to achieve the transformational benefits of an increased degree of social prescribing and the access to it, which becomes then preventative for the use of other potentially much more expensive services, you know, we would be needing to look at a budget which was more than the equivalent of 6 full-time equivalent social prescribers. But I don't know if the Chief Officer wants to come in.
I would like to come in. So I think this has proven to be a very challenging exercise, particularly in the context of the current arrangements that we have with separate budgets for adult social care, social work and health. I suppose I would wish to illustrate the fact that, and this maybe relates back to the comments earlier about the risk-sharing agreement, that the challenges that we've experienced in trying to settle on this recovery plan are really about the ways in which we've identified that if we take from one part of the system, it will critically influence and impact adversely on other parts of the system. And particularly when we're thinking about older people's services. You know, we've effectively opened beds up in Tay Ward in order to deal with a growing number of patients with a higher level of acuity and a higher level of activity coming through Perth Royal Infirmary. But what we've also done, and you know, I talked earlier about the effectiveness of our response to delayed discharge, is using the social care budget. We've opened 50 beds. So we've bought 50 more beds in care homes across Perth and Kinross than we have the funding to deliver on. And if we were to move away from that, that would back up patients in relation to delayed discharge. So the pressures that we've got are about how we transform that whole system. And Dr. Pratt's absolutely correct. We need to think about how significant the financial challenge is, and what we need to do in a more transformative way to deliver enhanced community support, to think about prescribing, to think about social prescribing, to think about whether or not we can continue to sustain the number of community hospital beds that we've got. And we need to bring forward some of those more medium-term transformational programmes that will change the way in which the system operates and take us away from a situation where we are looking to try to achieve small savings across a number of areas, because this is the first financial recovery plan. We will need to look at what we do next in relation to getting that 3.5 million down further, and that will require officers and IJB members to have to wrestle with some really difficult, challenging options that we'll be bringing back. But we need to bring back to the IJB after we've had the opportunity for more members to be participants in the BRG, the Budget Review Group process. So we shall be scheduling those, and appreciate that the two that took place last week were at fairly short notice and that many members had other commitments. So we will give you a commitment that we'll do that in a more planned way, and we'll build that into people's diaries so that we can have probably a deeper level of insight before we're bringing papers here, so that members are comfortable with what it is that we're proposing.
Thank you. Are there any other questions? Yes, Ms Pepper, Chief Social Work Officer.
Thank you, Vice Chair. It's a question again about the alcohol and drug partnership monies, because the ADP monies are not just for adult services, they're also to support families and young people and children. So the proposal that you have here, my question is, what consultation has taken place with the Children, Young People and Families Partnership in relation to this?
Chief Financial Officer.
I think that's an absolutely valid challenge. Whilst we have engaged with the Chair and the Vice Chair in terms of specific discussion around the Children's Service, we would have to clarify that.
Thank you. I suppose my question is really because the partnership received the Child Protection Committee Standard and Quality Report, which is the annual report for last year, and noting pressures and demands within the child protection system, and substance misuse is a key factor within that. So certainly if there are no spending plans within the alcohol and drug partnerships strategic planning at this point in time, certainly in my role as Chief Social Work Officer, I'll be seeking to challenge that, because there's certainly pressures and demands within the system and evidence of that. Thanks.
No other questions? Okay, so the recommendation in the report is that the IGB are asked to support the actions identified to address the forecast in-year deficit. I'd ask the Chief Officer to bring back further proposals to the next meeting, and I'm going to add on to that that will be through the financial position update, so we don't necessarily have to have separate papers on the financial recovery plan at the next or subsequent meetings. Do I have a seconder for that? Councillor Drysdale, thank you very much. Do we have any other amendments, or anybody who would like to make a comment, or can we agree the position in the report? Agreed. Thank you very much. Right, we have now reached 5 o'clock. We have got two substantive items of business left on the agenda. Can I just check that people are okay to continue? I think that in terms of asking questions, we can probably get through these relatively rapidly, and they are important items of business, so I wouldn't want to leave them or to defer the meeting, but if that was the will of the meeting, then that's what I would do. Can we carry on for maybe 20 minutes, 15, 20 minutes? Yep. I'm just going to return to my original appeal for people's questions to be concise. Sorry, I do know that the Chief Financial Officer does have another engagement, so we'll allow her to depart. But we'll go on to then item 10.1 on the agenda, the Bridge of Erne GP practice report from the Chief Officer.
Thank you, Vice Chair. I hope IGB members have had the opportunity to read this and the next report. They are important items, and I have a slight concern that we might not do them justice, but I shall in any case take you through this report very swiftly. This relates to the Bridge of Erne GP practice, and members will see that in the context of the GP partners handing in their resignation, this required NHS Tayside Primary Care Services to receive the resignation, and we in the Health and Social Care Partnership sought to provide other options that would retain GP services in Bridge of Erne. So just to clarify, the background to this is at 2.2, 2.3. There were particular challenges around recruiting into this area for a number of years. There have been significant challenges around the adequacy of the premises, which is leased from a retired GP. And these factors have led to the Health and Social Care Partnership working with the practice to try to sustain and consolidate their activity as outlined in section 2.5. When the GPs handed back or gave notice of their resignation, the Health and Social Care Partnership then did an appraisal of the various options that were available to us, and those are described in section 3 of the report. This led us to conclude that the best option, should it be able to be delivered, would have been for the provision of a 2C practice, where the GPs would be contracted by NHS Tayside, who would also have to lease the premises, and the Health and Social Care Partnership would support them in the continuing delivery of local GP services. While during that time we were unable to bring a report to the IJB, we, as Health and Social Care Partnership Executive Management Team, took a view that 2C would be the preferred option. We made that recommendation to colleagues in NHS Tayside, and then you'll see from section 4 onwards that once the various options were considered by colleagues in NHS Tayside Primary Care Services, including with the involvement of the Medical Director, it was identified that in the absence of additional medical cover, the preferred option of a 2C arrangement couldn't be safely delivered and sustained. So essentially the further inquiries that were made by NHS Tayside led them to conclude that in order to deliver a safe and sustainable GP service locally, they would need far more sessions than they were able to get from the existing GPs and from other sources, and ultimately the decision was taken that given the challenge around recruiting doctors, given the limited number of sessions that were able to be covered, and given the over-reliance that any arrangements would have on locum doctors, the conclusion was that to transfer the patients to nearby surgeries was the only safe option. So what happened was that a notification was made that the practice would close, and that instead of looking at the provision of alternatives, the patients would be transferred to a number of GP practices in Perth City, including, in addition to which, some patients were transferred to the practice in Kinross, and more recently further information is being provided to patients who live in Abernethy about the potential that they may be able to transfer to the Newborough practice, which involved cross-NHS board negotiations. So we arrived at a position where the practice was dispersed, and immediately our focus within the Health and Social Care Partnership was to think about what could we do, both in relation to supporting the GP practices in Perth City, but also, and perhaps more importantly, to think about what community health services might we be able to provide in the Bridge of Erne to ensure that a significant number of people who might otherwise have to travel into Perth City need not do so. So we've brought forward a proposal that involves the provision of community health services by staff who would be recruited or have been recruited by the Health and Social Care Partnership to deliver some nurse-led services and AHP-led services within Bridge of Erne. The types of community health services that don't require GPs are including wound management, bloods, diabetes care, long-term conditions, various other types of clinics and services that people could visit a local premises without having to then travel. Unfortunately, the challenge around premises remains so. We have looked at various options. We have looked at vacant units in the high street. We have looked at the existing GP practices, GP surgery, which Perth and Kinross Council were very keen to think about potentially leasing. And we've looked at other council buildings. So very early on, we looked at the potential that the school might provide a base. And again, Perth and Kinross Council education colleagues were happy to look at the potential that that would bring. Unfortunately, those opportunities were not able to be realised. However, we do have an emerging plan. There is a nurses' house in Bridge of Erne, and we have NHS Tayside have scoped out the potential to introduce a couple of treatment rooms there. We have had an early indication from Perth and Kinross Council's planning department that they would look favourably at the proposal. Previously, there had been a proposal that the whole GP surgery move there, and that had attracted some opposition, but we're less concerned about this proposal. I can share with the IJB, because it's a matter of public record, having been discussed in Parliament last week, that myself and the Chief Executive of NHS Tayside met this week with the Cabinet Secretary, Jean Freeman, out of her concern about the current situation based on representations that she had received. So we were able to provide Ms Freeman with an assurance that NHS Tayside will look to invest whatever capital money is necessary in order to try to deliver a local community health service, and that we would collectively work together to look at whether in the medium term there was the opportunity to think about the reinstatement of GP services, which from the Health and Social Care Partnership's perspective was something that we felt needed to continue to be considered, given the significant pressures that might otherwise be placed on GP practices in Perth and Kinross, but also because of the significant population growth that we know Bridge of Erne is going to experience with the expansion of around 1,800 houses being built in the Oudenarde site over the coming years. And there is the potential for us to look at, with the developer, whether or not some sort of health facility could be included within the plans for that site. That's a bit of a whistle-stop tour. I'm mindful of the time, but happy to also take as much time as necessary to answer any questions on that.
Questions? Councillor Drysdale.
Thank you. First of all, can I just thank the Chief Officer for the effort that he and his colleagues have put into trying to resolve this problem that has landed on his plate after 11 years of comparative inaction by NHS Tayside. So thank you for your efforts, and I hope that they prove ultimately successful. My question, you referenced your discussions with the Cabinet Secretary in recent days, and I'm not sure if your reference to public record, but there was a question to the First Minister which related to the impact, the contagion effect, if you like, on practices within the city of Perth and surrounding areas, and concerns expressed by city GP practices. Can you say a bit more about that, and what is being done, what can be done to minimise that impact going forward?
So thank you, Councillor Drysdale. I wasn't actually aware the First Minister had been asked a question about this, but thank you for alerting me to that yesterday. So the reference that I was making to matters that were discussed in Parliament following representations from MSPs, Liz Smith and from I think perhaps Murdo Fraser as well. In any case, we are continuing to work with GP practices in Perth and Kinross and are very keenly supporting them by looking to accelerate the work that we were planning to do with them under the auspices of the Primary Care Improvement Plan. So we're looking at how we can support them through the provision of additional services that would relieve them as GPs of some of the things that can instead be done by pharmacists, by AHPs, by advanced nurse practitioners, and by mental health nurses. So we have, in light of this development, had to look at how we can accelerate the support that we're able to give the GPs in Perth City. I have to say also, in fairness to NHS Tayside, that the primary care services have been very actively involved in supporting Perth City practices, and in terms of remuneration, in terms of whether or not there was any need for them to develop their surgeries and require some additional works, opportunities have been made available to support that through NHS Tayside. I think moving forward, it's probably important to recognise that the local medical committee have made representations as well as some of the GP practices, and I know that Grant Archibald and I think probably Peter Stonebridge met with them very recently. The commitment that Grant Archibald and myself gave to the Cabinet Secretary was that we would reflect on what learning we could take from this, because there were challenges around the approach that was taken in terms of engagement, communication and the timescales that we were having to manage collectively our response against. But we will also be looking at what this tells us for how we can perhaps more effectively risk assess the situation that others may be experiencing in terms of the sustainability of primary care services, albeit that becomes a challenge because obviously we're talking about independent contractors. There are issues of commercial confidentiality, but we would wish to work alongside GPs and to ensure that we can, as best we can, support them to sustain the delivery of their services.
Thank you, Chief Officer. And just one reflection, I'll bring you in for a question in a second. One reflection just on what you were saying there had struck me, which was that I think we are meant to have a primary care representative on the IJB, and we don't, and it would be helpful if we maybe had that input. I know that the clerk is trying to get that membership spot on the IJB filled. Dr. Pratt, you had a question.
So it's not dissimilar from the mental health issue. You know, of course, it was sad that Thomas Cook went under and other companies before that. But as we heard yesterday, sometimes there's just a problem about sustainability. And it's already clear you're thinking imaginatively about it, but that's what we need to do. And it should be about the overall quality of care in the long term. And it's just a plea that where we can, we take a long-term view of these fundamental health issues.
Okay, thank you. Any other questions? Okay then, I wonder if the IGB is minded to make any further recommendations or directions over and above what's detailed here. So within the paper it's recommended that Perth and Kinross IGB considers the content of the report and provide appropriate comments. I think we've done that. Note the context and current situation as regards the closure of the Bridgefern GP practice. Approves the proposed strategic approach for the future delivery of primary medical services to Bridgefern patients, and authorises the Chief Officer to work with partners to implement the necessary operational arrangements to ensure the delivery of the relevant services in Bridgefern. Chief Officer, I wonder if I could check in terms of that fourth recommendation, do you need any, does the board need to issue any directions?
No, I suppose I would wish to reassure the board that we are working very closely with NHS Tayside, who have asserted very clearly their commitment in this regard. And, you know, at this stage it will be about how we can jointly work to deliver a local community health service. Now, I think that if that fails to come to pass, then I would be reporting back to the IGB, who may wish to reflect on that, should that be the situation.
Okay, thank you. Councillor Drysdale, you wanted to come in?
Yeah, I just wondered if, I appreciate this paper is about the Bridge of Erne GP practice alone. However, I wonder if the IGB would consider trying to avoid future problems. Colleagues may be aware of concerns that I expressed on the Planning and Development Management Committee in relation to input from NHS Tayside in relation to new developments. I'm aware that the Local Development Plan 2, which is in the process of approval just now, that was consulted with NHS Tayside, and I'm aware that input did come forward in relation to that. However, this is an example, the Bridge of Erne situation is an example of where unexpected changes affect delivery and have a contagion effect around the whole of Perth and Kinross potentially. And I'm just looking for some way to form a more joined up approach so that going forward, when new planning applications do come forward that are perhaps stretching, shall we say, the LDP2 parameters, that the opportunity is specifically given to NHS Tayside to comment where there's any doubt as to the adequacy of the local GP practices.
I think the Chief Executive would like to come in response to that.
Okay, thank you, Councillor Drysdale. I can confirm that both NHS Tayside and Perth and Kinross Council are currently looking at a process that will enable exactly as you outline.
Hurrah. Thank you.
Okay, so I've read out the recommendations. I think I would like to maybe just beef up, I think, probably recommendation 3, approve the proposed strategic approach for the future delivery of primary medical services to Bridge of Erne patients. I think the only thing that gave me pause, Chief Officer, when you were speaking was about talking about the medium term potential for reintroducing a GP service in Bridge of Erne, and if we looked at 4.8 in the report, in the longer term there may be potential to look to reintroduce GP services, but that being dependent on the development at Oudenarde going ahead. I think it would be maybe appropriate if we moved the report with an encouragement to both yourself and to NHS Tayside to look at the reintroduction of GP services, acknowledging all the good work that's done in terms of the provision of community services, other aspects of primary care, but look to reintroduce GP services at the earliest possible opportunity. Doesn't specify when that is, whether it's whether that is short term or medium term, but just to give you that direction. If I wonder if I could have a seconder for adding that in. Councillor Drysdale, thank you very much. Has anybody else got any other suggested?
So no, I'm happy to accept that. I think the important thing, I suppose, is we are where we now are, and where we now are requires that we have to think about doing a community health needs assessment that ensures that people's needs are being met effectively. For some people, it has to be said, this has had limited impact. Lots of people would routinely travel to Perth City in the course of a week on many occasions. But those are probably not the people we should be worried about. It's the people who are isolated, people who don't have family, the people who don't have transport. So we need to do that needs assessment, and we need to assess the impact of this and how we mitigate it, which may well be about bringing forward a proposal around GP services. But that, I think, gains greater traction if the Oudenarde development starts to take place, because then we've also got a significant increased population that would further justify the need for that.
Yes, it no doubt does get greater traction if the Oudenarde development takes place locally. However, if there are other, I think the point that Councillor Drysdale was making was if there are other developments taking place elsewhere, that is putting pressure on other parts of the system, which at the moment are obviously having to take up take on those extra patients from Bridgefern. So unless there are any other comments, we can agree that report with my further comment. Yep, okay. Last item then is, or last substantive item is 10.2, the joint inspection of the effectiveness of strategic planning in Perth and Kinross Health and Social Care Partnership. Chief Officer.
Thank you. So members were briefed last Friday when they received this report in anticipation of the publication on Monday of the joint inspection report that was carried out by Healthcare Improvement Scotland and the Care Inspectorate. It had covered a 2-year period over essentially the years 2017-18, but taking us into January, February this year. There was a delay in the publication of the report because we felt it necessary to provide other evidence, to have some discussions with the regulators and to provide comment and correction on the first draft of the report. And I suppose that's relevant insofar as that we've now had a period of delay over the summer months. I think it's really important to reflect that the report is essentially about how effectively over that period the partnership has been able to deliver effective strategic planning. It's about our approach to performance management. It's about the strategy and commissioning activity that we've been involved in. And it's about the strategic leadership and the direction that's been given. What this report is not, it's not a report about how effectively we are improving lives and delivering good outcomes. And the final substantive item, or the final item for noting on this agenda, coincidentally, is our annual performance report, which we have considered at the Audit and Performance Committee. And in respect of the national indicators and the local performance measures, it is important to say that we are performing at or above the Scottish average in relation to most of the indicators. And I was very grateful to get feedback on how positively staff are delivering improved outcomes from members of the Audit and Performance Committee who were impressed by what that was telling them. However, to this report, the key findings from this joint inspection, whilst giving them that context and that timescale, remain of great concern to us, and we are committed to taking the necessary action, but probably worth reassuring the committee, the IJB, that the findings of this inspection report very much mirror things that I have been aware of since I came in and started to do some diagnostics. They mirror the self-evaluation that was carried out ahead of the inspection, and they reflect some of the findings that have come through in audit reports and in our own self-evaluation in relation to governance. So some of the work is already underway, some of it albeit in an early stage, but we're committed to take the actions that are outlined on page 175 and 178 of your papers in relation to the key areas for improvement that the inspectorates have identified we need to progress. I couldn't comment on this report without, however, acknowledging that the grades that have been provided and given in relation to our performance around performance management and around strategic planning and around leadership and direction are not the grades that we would seek to achieve. I hope that they don't mask the fact that there are some real positive examples of where staff in the front line are working well, despite us not having in place the most enabling arrangements, processes and conditions for them to do so. We've been commended for the work that's going on in localities. We've been commended for the work that we've done in relation to tackling delayed discharge. And we've been commended on the work that we're doing with local third sector and private providers in terms of our contracting activity. That doesn't detract from the fact that this is a report that's highly critical of aspects of our performance, but we are committed to addressing those.
Questions on the report, Dr. Pratt?
Yeah, just to repeat what, confirm what Gordon said, your metrics are good and they're not getting worse. So there's, I'm sure there's work to be done, but maybe not beat yourselves up too much.
Thank you for that. I mean, I think what I'm taking from this is we are performing well in terms of making a difference, and how much better we will perform if we put in place the right systems and structures to enable staff to work in an effective and integrated way.
Councillor Drysdale.
Thank you, Vice Chair. Yeah, I just wanted, I'd just like to echo these previous comments first of all, and I appreciate that the evaluations are not what we would want to see, but I think we can all see the direction of travel is very positive, and I'm grateful for everybody's efforts in that regard. My question relates to 3.4 and the concern expressed about the use of data, how it was collated and used, and where responsibility lay for reviewing and monitoring performance, in particular about the collation and use of data. Where are we with, you know, Perth and Kinross Council agreed to fund staff to improve the data collection process on the basis that that was matched by NHS Tayside. Has that been agreed? And if not, why not?
So I mean, I think that's a point that I'll maybe invite the Chief Executive to comment on if she may. But I think the important thing for me is also to reflect on some of the challenges, I think, around how effectively we are monitoring, managing, reporting and improving on performance are a consequence of a lack of clarity about responsibility and this aligned structure that we have. I have a concern that with a structure that has a health and a social work line to it, that we are spending undue amount of time in servicing that interface and working across it. We have people, we have capacity, and we have people with commitment and enthusiasm about wanting to move forward. And that includes in and around performance data and monitoring. And we heard earlier about the progress that we've already made in relation to the Older People's and Unscheduled Care performance report. But we do need to use the catalyst that the Council have provided, should that become available in relation to data and digital. And at the moment, I know the Chief Executive has sought to invite NHS Tayside to match fund, but that hasn't yet been realised. So I don't know if you want to add to that.
Chief Executive.
Thank you. So work is underway at this moment in time and across the whole Council to look at data and how we actually analyse, synthesise and triangulate that into intelligence. That includes working across the Health and Social Care Partnership. In terms of one of the recommendations in relation to the inspection report, that will help us have better performance management information, particularly for the IJB, I would imagine for both the Council and indeed NHS Tayside. I have made the Chief Executive of NHS Tayside aware of the monies that have been put into our budget, and I await his confirmation of match funding.
Thank you, Chief Executive. You're more patient than I am.
Okay, if there are no further questions on the report. So we've got a recommendation, well, we have considered the report on the joint inspection. We're recommended to note the detailed findings in the full joint inspection report and request the Chief Officer to produce a comprehensive improvement plan to address the areas for improvement outlined in the joint inspection report and report back to us on early progress at our meeting in December 2019. I have a seconder for that. Councillor Drysdale again. Any comments or amendments? Oh, yeah, Maureen, a comment.
I just wanted
Sorry,
to know
Mrs.
how
Summers,
soon
comment.
the inspection team are coming back to look at improvements.
So we asked them this because we felt reasonably confident that we were already on an improvement journey and could begin to demonstrate how effectively we were moving forward. Unfortunately, they're not intending to come back, but I mean, I say unfortunate because actually what we need to do is recognise that these evaluations will remain on the public record and actually they won't reflect the improvements that we're achieving. So we might look at how we can address that. I would also say that the most important thing for me as a senior officer is about satisfying myself and my staff being able to satisfy themselves that they are continuing to improve and deliver effectively. And we then need to find means and mechanisms for ensuring that the IGB receives that assurance. And if we get better at doing that ourselves, then it probably matters less what happens when the Care Inspectorate and Healthcare Improvement come in. They should be able to come in and say, you have made the progress, you have made the improvements. So for me, it's about ensuring that we're confident and satisfied of that. But I take your point, Maureen, that means that these grades remain on the record. And we will be looking at how we can engage with the Inspectorate because they also have a link inspector who will work with us in order that we can ensure that that person's cited on the progress and improvements that we're making.
It's just that when the Care Inspectorate visits care homes and places like that and they get the kind of markings that they've given you here, they do come back and within, a few months they get a chance to have the grades upgraded, but, that's why I wondered when they're coming,
I'm not sure if there's anybody in the room who knows how the Care Inspector... Oh, the Chief Executive...
There's one or two people who know very well how
the Chief Executive would like to come in on that point.
I think, Vice Chair, you're having fun at this time on a Friday evening. Maureen, as you're probably aware, both the Chief Officer and myself can comment in great detail about how the Care Inspectorate undertakes its inspection. So in terms of the strategic inspection, this is a strategic inspection that looks at performance data, the use of data and performance management reporting. It looks at strategic commissioning and it looks at leadership. Those are underpinning factors to good quality care, but they don't actually mean that people across Perth and Kinross are not receiving good quality care. So in terms of strategic inspection, it's not normal for there to be a follow-up inspection in every case across the country. And whilst it's not for me to speak on behalf of the inspection bodies any longer, I would doubt they would have the resources to be able to fulfil that. What's critically important here is that in the IGB, there is assurance about the quality of care. And I do know that you get regular reports about the quality of care. So at this moment in time, in the care services that are delivered by this partnership, they are all achieving grades of very good or excellent. And that's quite significant because that means the quality of care and outcomes for individuals in our community are good.
Thank you.
Okay, thank you. Can we agree the recommendations in the report? Agreed. Thank you very much. Okay. Item 11 on the agenda is the annual performance report for 2018-19. That is provided for information. So unless there are any questions on that, it did have quite a good review at the quite a thorough review at the Audit and Performance Committee, and Councillor Purvis has obviously updated us on that earlier in the meeting. So if we can just... note the annual performance report. Thank you very much. And the last item on the agenda, thank you for your patience. The next scheduled meeting is the 11th of December, but we are proposing, because we've, unbelievably, we've actually had to strip down the agenda for today's meeting and take stuff off it. So we're proposing an additional meeting on the 6th of November, if that's acceptable to the board. Yep. And a reminder that we have a development session on the 23rd of October. And we've already covered what some of the content of that would be. I'd like to thank everybody very much.
Chair, I wonder, I have to go shortly. I know everyone wants to go. I've been asked by IJB colleagues to recognise the contribution of Dr. Robert Peat. Normally, an incoming chair would recognise that contribution. I appreciate the difficulties of that.
I did that at the start of the meeting, but you're welcome to add to that.
Yes, but I think we wanted something that fully reflected that. And I want to pay tribute to Dr. Peat, who recently resigned as chair of the IJB following our last meeting on Monday, the 29th of July. And I want to recognise on behalf of some others and acknowledge his contribution to the work of the board throughout his tenure, and to thank him for his guidance and expertise on health and social care throughout that time. His additional contribution to Tayside through his chairmanship of the Dundee Drugs Commission should also be acknowledged, and further underlines and marks a major loss to the capacity, credibility and status of the IJB since his demise. This loss to the IJB was entirely avoidable, but I won't dwell on that because I realise there are other processes currently in place to address these issues. What I want to do is to focus on Dr. Peat himself. It's worth saying here that his leaving may negatively impact on good membership scrutiny, leadership and partnership working, and I need to say that to you. Dr. Peat also brought the key post requirements to provide an authoritative, strategic lead, uphold the public code of conduct with the duty of care, and to demonstrate collective leadership in a collaborative partnership approach. I would expect the new chair to match these requirements. Now, in my role as the new incoming vice chair, I want to ensure that such events don't happen again, and now we're working to uphold those standards. Thank you very much.
Councillor Stewart, can I intervene, please? Thank you for your words, and I think we would all support the contribution that Dr. Peat has made to the Integration Joint Board. However, it's equally important to recognise that in his opening remarks, Councillor Stewart, as Vice Chair, did indeed acknowledge the contribution of Robert Peat.
Thank you. So, what I wanted to do was just thank everybody. It has been an extremely long day. I know that we started with a private briefing at 9:30 and we started our formal meeting at 10:30 and we're now past 6:30 in the evening. We did have a couple of extremely important items in terms of hearing from Dr. David Strang about the independent inquiry and discussing the inpatient mental health redesign service redesign programme. I think it was appropriate for us to spend a good amount of time on those, and obviously following that as well we have had an extensive discussion on the financial position and the recovery plan, and it's appropriate for us to do that. I'd like to apologise for the length of the meeting, but I'd like to just acknowledge everybody's contribution during the course of the meeting, and to thank everybody for their attendance, and thank in particular the officers for their diligence in staying on and being able to provide answers to the questions. So with that, I'm going to close the meeting and see you all, I think, at the development session on the 23rd of October if we don't have informal meetings before then. Thank you.
Just a quick vote of thanks to the Chair for the way that this meeting, a very difficult debut meeting, has been handled. Thank you.
Thank you very much.